Hello, good morning, doctors. This is again Dr. 𝗧𝗵𝗶𝘀. Welcome to the game changer session of this pathology part. I guess you are audible? Like, I guess I'm audible to you. Can you please confirm in the chat section? Yeah, good morning, Kwanen. Good morning, Ria, Reka, Rituraj. Yeah, Vinky, Naresh, Parul. Yeah, good morning, guys. Like, Muhammad Shanwas, Aishi. Yeah, good morning, guys. I hope I'm audible. Yeah, good. Then all fine. Yes, okay. Yeah, good morning, champion. Monograph. Good. Hello. Guys, first, how was your yesterday? Like, did you went and revise the yesterday topics? Yeah, waiting for answers. Yes, good, Dr. Ansh, good Dr. Ria, good Dr. Abhay, good Dr. Aishi. Yeah, just keep this motive that whenever you attend the session, make sure you are going to revise the notes and make sure you are attempting these PVQs of last 5 years, because this note is to help you and to aid you, to supplement you, because in this we are making subjects in a more concise manner, and these are all the most important and high yield points. So you need to read them multiple times to get them into your mindset, and at the same time you need to do multiple choice questions, because without questions you cannot get the grasp of the content what they are asking, because in your main examination at the end of the day it is the MCQ part of examination. If you do it well, then you will come out with flying colors. So make sure you are reading this once more time, and if you have any doubts, make sure you are watching the part of the video once more time, and make sure you are doing your questions on time. So if you do these 3 things for sure and consistent enough, then you will be coming out with flying colors. And today we have 3 subjects in line: the pathology part, the microbiology part, and this pharmacology part. And each of the session it will be bit length, like each of the sessions it will take around 2 hours. Fine. And after each subjects will have a break. Okay, that's our main motto of a session. I hope your things are clear now, and if any doubts you just put up in the chat section. We'll aid you during our break section, and after each topics we'll check out your comments. Okay. Yeah, thank you, Dr. Reka. Thank you, Dr. Anjali. Thank you, Dr. Surya Prakash. And thank you, Ada Chiku, Shanwaskan. Thank you, everyone. Thank you, Dr. Harsh. Okay. So without wasting time, let us move on to the topics. Fine. First, you're able to see the first topic we're going to discuss. It is what it is, the cell injury. We know when there is a normal cell, like it will perform its normal function. But when a cell undergoes ischemia, or when a cell undergoes a stress, it leads to this cell injury. For example, there is a normal cell. Because of a thrombus, the blood flow is decreased blood flow, and because of this decreased blood flow, the cell blood flow will be decreased, and because of this, ATP generation will be decreased. And if there is decreased ATP generation, and we know there is a pump which we studied yesterday, which is a primary active transporter. Which of the following pump is an example of primary active transporter? Yeah, guys, that is what it is, the sodium potassium ATPase pump. It is a sodium potassium ATPase pump. And if there is any failure of this pump, because there is no blood supply and there is no oxygen, because if there is no oxygen, there will be no production of ATP, and if nothing happens, then the cell will undergo injury, or the cell will be injured because of this ischemic one. And after this, if you see, because there is no sodium potassium ATPase pump, the sodium will start collecting inside. When the sodium start collecting inside, then you know this sodium will absorb more water. So when the sodium will staying inside the cell, it will absorb more water. When it absorb more water, then we'll able to see this first light microscopic changes in cell injury. The first light microscopic changes in cell injury, it is what it is, a cellular swelling. So cellular swelling, it is the first light microscopic changes. Okay. Yeah. Good, Dr. Anjish, Dr. Madani and Ansh. Yeah, good. Yeah, fine. and this is known as the hydrophobic change. And once there is a swelling and this fluids, it will start accumulating into the other organs as well. For example, the mitochondria will get swell, and there will be this detachment of these ribosomes. Remember, there will be a detachment of these ribosomes in a case of reversible cell injury. In a case of reversible cell injury, first there will be a normal cell, followed by this injury, it will go for this reversible cell injury, because if we remove the stress, after a certain point, the cell will perform its normal function. So that is known as reversible cell injury. But there will be a certain point at which this normal cell cannot do its function again. That is known as irreversible cell injury. We studied yesterday, right? There is this action potential in physiology in which there is a threshold level. Once you reach the threshold level, then the action potential starts generates. Okay, the action potential generates after a threshold level. Likewise here, there will be a time till which it is known as reversible, and after which the cell will become irreversibly injured. Okay, that is the concept here. And if you move on with this, and what are the changes? I told one is this cellular swelling, next one this mitochondrial swelling, and you will be able to see this type of membrane swelling. It is known as membrane blubbing. So membrane blubbing, cellular swelling, and mitochondrial swelling, and along with this ribosomes get detached. It is known as ribosomal detachment. Okay, it is known as ribosomal detachment. Fine. And these are the few changes which you see in a case of reversible cell injury. Whereas once these things get passed, if the stress is not yet relieved, then it will go to this next process which is known as irreversible cell injury. In a case of irreversible cell injury, it leads to this lysis of this membrane. So the membrane will be damaged in a case of irreversible cell injury. So in a case of irreversible cell injury, membrane will be damaged. So we know if the membrane is got damaged, then it leads to this leakage of this content to the outside. Okay, leakage of this content to the outside. Just remember this thing. And why it is irreversible? Because if there is just cytoplasmic changes and other organal changes, it can be reversible. But if the changes started occurring into the nucleus, then it becomes irreversible. So initially our chromosomes will be like this. It will be like a woolen ball, you know, right? Woolen ball. So it will be like a woolen ball. But once there is injury started occurring, it will just initially it will start to clump together. So in a case of reversible cell injury, there will be this clumping of this chromatin. So reversible, there will be a cellular swelling, mitochondrial swelling, ribosomal detachment, and there will be a clumping of this chromatin in the nucleus. Okay, these are this reversible one. Whereas in a case of irreversible cell injury, what will happen? It will leads to this deposition of this material into the cytoplasm. There will be deposition of the material, first one. Second one, the membrane will be damaged. There will be lysis of this membrane. And third one, what will happen? This nuclear changes. What are the nuclear changes? As I told you, this is how this normal nucleus looks like. It is like a woolen ball. You know, right? Woolen ball, there will be this much spacious and it will be very compactful. Whereas in a case of irreversible cell injury, this compacted one become clumped. Means it is like the crushing of your tissues. Like it will be compact. When you crush, it will become very small. So this is known as pycnosis. This is known as pycnosis. Here you will be able to see some spaces, but here there is no spaces. Then it is known as pycnosis. And once there is clumped, once there is a clumping, then the cell undergo next changes, which is this irreversible one. Then this nucleus should be removed, because in this cell there will be a presence of this structure which is known as lysosomes and lysosomal enzymes. And this lysosomes and lysosomal enzymes, what they will do, they will start digesting the cell wall and into the nucleus. When they go into the nucleus, they will break them into small parts. For example, take up your journey of your FMGE, or take up the journey of any competitive examination. The information everywhere, it is widespread. If you open YouTube, if you open any book, there is already enough amount of information. But if you see, they are very much spreaded. In a case of inflammation, what it will do, it will clump. Means you need a information which is required to pass a specific examination, that is FMGE. So for passing this FMGE, you need to know what are the PYQ questions, what are the PYQ topics, what are the must-know topics, and you should have a strong base notes. So if you have all this content, then everything will be together. So if you have this content in a simple set, then what you should do is you need to split them up. What is the weightage topics? What is the notes tells you how to solve this question? So you need to decode them. That's why if you able to see here, you will separate them into small pieces, Once you separate them into small pieces, then it will be very easy for you to lyse the information or to understand the information. So initially there will be this normal nucleus, followed by this clumping, which is known as pycnosis, followed by this small breakdown, it is known as karyorrhexis, and followed by this there will be this lysis of this complete chromatome material, it is known as karyolysis. Okay, that's all. Yeah, there is no any issues. Yeah, good guys. So this is the things which you see in a case of normal irreversible cell injury. And in a case of irreversible cell injury, there are different types. There might be a programmed one, there might be a non-programmed cell death. In a case of programmed cell death, we'll call them as caspase dependent programmed cell death. And this type of caspase dependent programmed cell death, what it is known as? Hey guys, it is known as apoptosis. And we know if this apoptosis occurring in liver, then this liver cells, it will become small because of after its death, and it will become pink in color. So what is the name of this body? You will see in a case of liver, it is the Councilman bodies. It is known as Councilman bodies, which is seen especially in a case of hepatitis in the liver. Okay, hepatitis in the liver. Sorry. Good guys. Good, Dr. 𝗚cie𝘁𝗲𝗀𝗀𝗀𝗀, Dr. Anjali. Yeah, good. Keep going. Okay, keep going. Then, in a case of irreversible cell injury, I told you this leads to this accumulation of few particles. If this calcium, if it is getting accumulated into the mitochondrial content, it will start accumulating into this circular fashion. Can anyone tell me what is the name of this fashion in which this circular deposition of this debris and the calcium material in the mitochondria? It is what? It is the 𝗵𝗲𝗂𝗍𝗍. It is the 𝗵𝗲𝗂𝗍𝗍. So remember, it is known as 𝗵𝗲𝗂𝗍𝗍, which is seen in a case of reversible and irreversible cell injuries, and mostly it is more prevalent in irreversible cell injuries. And after this cell is being dead, or this, there will be debris will be there, right? So that this debris will start accumulating. So we know when we see a packet before packing or before eating something, it will be very nice, but when you throw, it won't having a proper shape. So after cell injury, there will be this deposition of this material which won't have any proper shape. So we'll call them as dense amorphous without morphology, dense amorphous densities. And how will you differentiate this amorphous densities? In a case of reversible cell injury, this amorphous density, it will be less, whereas in a case of irreversible cell injury, we call them as, how we'll call them? We'll call them as this thing which is known as what? Flocculent amorphous densities. So see, this both of them, they are this electron microscopic image in the case of inflammation part, and in inflammation you will able to see this one. This is this irreversible and reversible one. In a case of reversible, there will be this less densities, whereas in a case of irreversible, there will be more amorphous densities. Yeah guys, yeah, good guys, good going. Yeah, onion ring will be also seen in a case of some bodies. Yeah, that's good. Fine, that we'll discuss on long run. Don't worry. So these are the parts, are the cellular changes you need to remember for this first part, which is this reversible and irreversible cell injuries. Next, we'll move on to the next part, in which we'll learn about this apoptotic and anti-apoptotic genes. So most of these pathological genes and the pathological parts, it is most of kind of remembering. So try to make some mnemonics or stories. I will help you out with some of these mnemonics. ठीक है, मुझे जो पता है उसके हिसाब से I will tell you few mnemonics. आप उसको यूज करके आप याद रख सकते हो. You can keep these things with few mnemonics, then it will be easy and cakewalk for you. So how I used to remember is, if you see this one, this anti, okay, if there is someone anti to you, or if someone is against to you, what you will do? You will clear them. So remember, this anti everyone will be having this suffix of Cl. Yeah, good doctor. Yeah, mostly Cl and L. Okay, so if you see this anti-apoptotic, that is this BCl2, MCl1 and BClXL. BCl2, MCl1 and BClXL. Whereas you should be vigilant in this. There is one more BCl, but it is not XL, it is XS. is X. Yes, it is a pro-apoptotic in nature. It is pro-apoptotic in nature. Means in your family there will be there, right? In your family or in your relatives or your friends will be there. Someone will be supporting you and someone will be against you. So pro-apoptotic genes are the supportive genes which promotes apoptosis, whereas anti-apoptotic genes, they will be against apoptosis. They will stop this apoptosis. Okay, and there will be few people who will sense you. Means they can read your faces, right? They can sense and tell you, yeah, you are sad, wow, you are in confusion, you are in FMG preparation part. So likewise they will see and they will tell you. So these are known as stress sensors. Okay, there are few stress sensors and there are few people who will be supporting you that you can do your FMG examination well, and there will be few people who gives you this enough motivations that they will tell you that you cannot pass, but you know that you will pass. So with this motivation, you will proceed ahead that I will show them one day that I can pass this examination. So that is what, that is this three and few concepts like pro-apoptotic genes, which include this BAC, box, BCL-XS. Remember, it is BCL-XS, then SMAC and 𝗏. SMAC and 𝗏. So BAC, box, BCL-XS, SMAC and 𝗏. These are this pro-apoptotic genes, and anti-apoptotic genes, as I told you, it will be having this Cl in their suffix. So it is what it is, BCl2, MCl1 and BCl-XL, BCl-XL. Yeah, good guys. And we know in the case of apoptosis, the marker is what? It is this annexin 5. Yeah, good guys. Then if you see next one, they are known as stress sensors. These stress sensors, they will sense whether is there any stress which is this cell is experiencing. These stress sensors include 𝗵, 𝗵𝗵𝗊, 𝗵𝗵, 𝗧𝗵𝗹𝗄 and 𝗵𝗵. 𝗵, 𝗵𝗵𝗊, 𝗵𝗵, 𝗧𝗵𝗹𝗄, 𝗵𝗵. 𝗵, 𝗵𝗵𝗊, 𝗵𝗵, 𝗧𝗵𝗹𝗄, 𝗵𝗵. So anti-apoptotics, they will be having this Cl. Okay, BCl2, MCl1 and BCl-XL. Okay, whereas pro-apoptotic, they include BAC, BACS, BCl-XS, SMAC and 𝗏. Okay, whereas the stress sensor includes 𝗵, 𝗵𝗊, 𝗵𝗵, 𝗧𝗵𝗹𝗄 and 𝗵𝗵. So these are this stress sensors, you need to remember. And as I told you, the marker is what? It is this annexin 5. It is the marker for apoptosis. Okay, I will ask you one more annexin 1. Just be connected with us. Okay. Yeah, we'll use this one more dye which is known as phosphatidylserine, and in the case of extrinsic pathway, we'll use CD95. Yeah, good guys. Next, there are this questions because we know now there are many of these anti-aging therapies are being underway. So they will be asking this one, which is which of the following gene is responsible for this anti-aging and this aging, and how it will be reversal, or how will you decrease the progression of aging. Okay, if you see it, this aging is because of this telomere shortening. Okay, telomere shortening, it is done by this enzyme which is known as telomerase. Okay, telomerase, and mainly this happens due to this free radical injury. We know our free radicals like, right, superoxide and the hydroxyl radicals. All of this, they are the free radicals. They will snatch one part of our electrons in our cell membranes, and it will cause injury to the cell membranes. Once they cause injury to the cell membranes, then it will cause what? They will destabilize the membrane, and it will go for this healing, but it won't heal us properly. So this is known as free radical injury. And how will you decrease this aging or free radical injury? By taking up this free radical scavengers like our vitamins, vitamin C and vitamin E. Then there is this one more thing which is known as sirtuins. Like if we increase the intake, or if we increase the levels of sirtuin, then there will be a decrease in the metabolism and there will be a decrease in stress. This leads to this decrease in the aging. Okay, yeah, the red wine. Yeah, good, Dr. Chico. There will be an intake of red wine which is having this high in sirtuins will lead to this decrease in aging, and there will be this blushing, they will tell it, right? And there will be this drugs or this thing which is increasing this insulin sensitivity. Can anyone tell me in the chat box, like what is the GLUT transporter which is insulin dependent? Which is the insulin dependent GLUT transporter? Yeah, good, Dr. Anch. It is what it is the, and good, Dr. Quinin, the Crazians. Yeah, it is what it is the GLUT4. Good, rest of the others, yeah, it is what it is the GLUT4, which is an insulin dependent transporter. Next one, it is the calorie restrictions. Like if you take decreased calories, then there will be a decreased metabolism. The same wise, then there will be an increased sirtuins. Okay, so the calorie restrictions by around the less than or around 50% less than the usual one, it will lead to this decrease in aging process. And we know there is a syndrome where there is early aging, which is known as Werner syndrome. It is not Werner syndrome, it is Werner syndrome. Remember, it is Werner, okay, it is not Werner, okay. So agar Werner syndrome hai, it is due to the defect of DNA guidance defect. So Werner hai, so ye kya? So it is what? It is the DNA guidance defect. Whereas if it is Werner, it is this M for M, it is the Men syndrome. It is this Men syndrome. Yeah, good guys. Then we'll see about few inflammatory mediators. You know, once there is a cell, once it undergoes injury, it need to be repaired. So when it be repaired, before that there will be a process which will be going on, which is known as inflammation. Okay, during this inflammation process, few things will happen. Okay, what are them? Initially, there will be fever, or favorite fever. There will be what? There will be this fever. So we know this fever, it is due to this interleukin 1, 6 and TNF alpha. So three things you need to remember: 1, 6 and TNF alpha. It is for this fever. So 1, 6 TNF alpha, it is responsible for fever during inflammation pass. Okay, so if we give paracetamol, it will what? It will decrease this inflammatory cytokines which causing this fever. Next one, in a case of cancer, or in a case of cancer and cachexia patients, there will be a loss of appetite and there will be a weight loss. There will be this weight loss, and it is due to this TNF alpha. So this TNF alpha will cause this cachexia. So TNF alpha will cause this cachexia. Fine, yeah. Interleukin 11, like it also will cause this pyrogen. So especially we'll read about one more process where this interleukin level comes. Okay, I'll guide you guys. Don't worry. Fine, yeah, good. Next, if you see about the next one, which is this fibrosis. This fibrosis, if you see, like once there is inflammation, it need to heal, right? Once you suffered a heartbreak or something, at some point of time you should come out of it, right? You cannot stay with some part of your heartbreak and you can take them all your life along, right? So some point you need to heal these things. Yeah, this is for your goodness. You learned big things from it and you should move on. So this type of healing, it comes because of this fibrosis. Okay, during your inflammation, it will be healed by this fibrosis, and this fibrosis is because of this factor which is known as TGF-beta. Okay, whoever told beta, they told you that they cause scarring, which is the fibrosis. Okay, like the previous, like beta, B2, they made you to heartbreak and made your heart to be scarred. Okay, with and memories. Okay, just itna yaad rakho. Okay. Then if you're able to see the next one, there will be in few conditions, like for example in a case of tuberculosis, in a case of leprosy, they are what? They are this chronic granulomatous inflammation. Okay, they are what? They are this chronic granulomatous inflammation. So in such cases, there need to be formation of this granuloma, and this granuloma, it is due to the G for G, it is due to this factor. Sorry. So it is what? It is this interferon gamma. It is this interferon gamma. So interferon gamma will lead to this formation of this granuloma. And there are few things, like you cannot keep everything for a very longer time, as I told you. So you need to stop this inflammation after a certain point. So there are few anti-inflammatory cytokines which include interleukin 4, interleukin 6 and interleukin 10. So remember, 6 plus 4, it is 10. So all of these three, they are what? They are this anti-inflammatory cytokines. So 6, 4, 10, they are this anti-inflammatory cytokines. And finally, there will be this eosinophils. In the case of allergic reactions, these eosinophils will release histamine, okay, and along with this mast cells. So this eosinophils, it will be brought to there by this cytokine, which is what? Which is the interleukin 5. So interleukin 5, it is responsible for this eosinophilic actions. Okay, I guess most of these things about this initial interleukins is clear. Yeah. Repeat granuloma. So if you see in a case of granuloma, there will be this caseating granuloma and non-caseating granuloma. Some disease, it will cure very suddenly or within an ample of time. Whereas some disease, the pathogens, it will having some pathogenic mechanisms which evade from this macrophages, like which will evade from these macrophages or which will prevent themselves from killing. So in such cases, there will be the formation of granuloma. We'll see in further run, there will be this caseating granuloma and non-caseating granuloma. Okay, so to form this granuloma, we need this interferon gamma. So to form this granuloma, we need this interferon gamma. So just these are this few interleukins on. Yeah. Then about, yeah, good Dr. Ansh, good Dr. Shanvas. Then if you see about chemotaxis, As I told, there is inflammation, but who will tell or how will tell that there is inflammation going on, and these cells need to come there and they need to fight against this inflammation part. So if you see, there is this chemotactic cytokine which is known as CX3. So remember this 3, make this 3 into M. So if you split this 3 into M, it is what it is this. The monocytes and the T cells, the monocytes, especially the monocytes, it will come there because of this CX3. Then there will be this CXC. So remember this X, okay, not your X, see this X. And if you make this X into this is this 8. So make this X, make it to 8. So it is this 8. So remember this 8, it is what it is, interleukin 8, it is at the CXs, and it is because, and it will cause this attraction of these neutrophils. It will cause attraction of which of the following? It causes attraction of the neutrophils, because we know that cells which is predominant during this acute inflammation, it is what it is, the neutrophils. So CX3, 3 looks like M, so it is what it is, monocytes. CXC, so if you make this X into 8, it is what it is, this neutrophils. Yeah, good guys. Yeah, X को कभी नहीं भूलना, बिल्कुल, ठीक है. Then about CC, you need to know about this eotaxin, rantis, and MCP. Whereas just C, it is what it is, this lymphotaxin, about this lymphotaxin, okay. And these are the people who will call them, yeah, come, we need to fight for this inflammation. Whereas there is few more guys, when they saw this microorganisms, what they will do, they will just go and attach over them. For example, okay, for example, when you pass your examination, your friends, your school friends will know, yeah, this guy passed FMGE examination, so we need to get the party, okay. One friend will start come and attach, and everyone will start come and attaching you, and they will be what, they will be making your journey very peaceful or making you more enjoyable. So what they will do, this opsonin, they will make the food tasty, or they make them to be easily recognizable, okay, easily recognizable for this macrophages. And this, the most important, if you ask me the most important one, it is this IgG. Whereas sometimes they will ask you which of the following complement protein, it is this most important opsinogen. It is what it is, C3b. It is C3b, and there is one more one, it is this fibrinogen. So these, all of them, they are this opsinogens. What they will do, opsonins, what they will do, they will make them easy to identify for this macrophages and other cells, okay. That is the thing. Yeah, good guys. Then about this slides of giant cells, as I told you, this interferon gamma, this here I told you, right, interferon gamma, it leads to the formation of this granuloma. Interferon gamma lead to the formation of granulomas, and there are different types of granuloma. The one of the most common type of granuloma you will see in a case of TB, it is what it is, the caseating, okay, caseating granuloma, okay. And in a case of TB, we know there will be a presence of this giant cells. How will you tell it is giant cells? Because we'll tell them this type of giant cells because there will be this multiple nucleated, there will be this multiple nuclei will be there, okay. There will be this multiple nuclei, it's not one, it is this multiple nucleated giant cells. And if you see them, they are not arranged in a circular fashions, they are arranged in this pattern, which is known as what, which is known as horseshoe pattern. So this type of arrangement of this multinuclear giant cells in this horseshoe pattern, can anyone tell me what is the name of this giant cells? This type of horseshoe arrangement of giant cells, they will give this slide and they will give this classical history of this TB, and they will ask you what is the name of this giant cell. It is what, it is this Langhans, it is Langhans. Remember, there are two cells, Langhans giant cells and Langerhans cells. So Langhans and Langerhans. So remember, Langer, okay, Langer. So Langerhans, it is what, Ger for Der, means it is a derma cell. So Langerhans cell, it is a derma cell, it is seen in skin, okay, seen in skin. Whereas in TB, you will see this cell which is known as what, Langhans giant cell, Langhans giant cell, and it is horseshoe in shape, and mostly this will show this caseating granuloma. And next, you see a child who with this features of, there is a clinical features of conjunctivitis, oryza, there is a features of this conjunctivitis, coryza, and there is a presence of this part which is known as Koplik's path. Yeah, I'm getting the answer. Yeah, it is what? This is the classical history of what? Classical history of measles. And in some cases of this measles may be complicated into a pneumonia. What is the name of this pneumonia which is seen in a case of measles? It is known as what? It is known as hex pneumonia. Good guys. It is known as what? Hex pneumonia. And in the case of this measles, you will be able to see there are two types of intracytoplasmic and intranuclear. This type of both type of this inclusion bodies and this type of giant cells. And if there is this multiple nucleated giant cells along with these inclusions and this type of giant cells, they are known as what the name of these giant cells, guys? Yeah, it is what it is. Yeah, good. Dr. Ansh, it is what is this? 𝗵𝗵𝗶𝗀𝗀 giant cells. Remember, in measles, you will see this 𝗵𝗵𝗶𝗀𝗀 giant cells. Okay, that's it. Okay, and in measles, the name of the pneumonia which is seen in a case of measles, it is this hex pneumonia. Fine. And next, you say a patient who is presenting with this rash or group of rash over the genitalia, and you did a smear which is known as Zancke smear. And Zancke smear, you will be able to see there is this multinucleated giant cells. Zancke smear showing this multinucleated giant cells. It is not HPV, guys. It is seen in a case of HSV, herpes simplex virus will show this multinucleated giant cells. Okay, so you took a Zancke smear, you will see this multinucleated giant cells. Okay, giant cells. So this is seen in a case of HSV. So there are two HSV. One is above waist HSV. Second is this below waist. So one is above waist. It causes this herpes labialis. Whereas this HSV2, it causes this sexually transmitted infections. Okay, it causes this sexually transmitted infections. That's it, guys. Next one about this owl appearance. So they will ask this simple questions even. In FMGE, there won't be always 300 questions are not harder in nature. Okay, if it is 300 questions are harder, then no one will pass the examination. You see your friends, your seniors, they are passing the examination because there will be these easy questions and this game-changing questions as well. So these easy questions you should make correct in these easy questions. That is the game-changing point, and that is the point where it will bring you from 149 to the 150 mark. From this 149 to the 150 mark, it is the easy question. It is not the tough question which makes the difference. It is the easy question which is making this 1 mark and a big difference. Okay, if you see, this is what this is, this owl eye appearance. Okay, owl eye appearance. And how will you differentiate these two owl eyes? If you see, there is this red center or this pink. If you see this red one, remember it is this Reed-Sternberg cell. So red one, it is this Reed-Sternberg cell. So we know this Reed-Sternberg cell which is seen in a case of Hodgkin's lymphoma. So Reed-Sternberg cell which is red in color means the center will be red in color. So it is what is this seen in a case of Hodgkin's lymphoma. Reed-Sternberg cell red in color seen in Hodgkin's lymphoma. Whereas in a case of cytomegalovirus, you will see there is this nucleolus, but it will be what? It will be blue in color. If you see this kind of blue in color, if the nucleus is blue in color, then it is what? It is the CMV. It is this CMV. So CMV will be having this blue color central or this basophilic central. Next one, if you are able to see this type of giant cells, where you are able to see there is this large vacuoles. There is this large vacuoles and there is this surrounding giant cells. So if you are able to see this type of cytoplasm which is containing large type of fats and the materials inside. So it is what? It is known as Teuton's giant cells. It is known as Teuton's giant cells. And this type of Teuton's giant cells, it is most common and classically seen in a case of xanthoma. So Teuton's giant cells will be seen in a case of xanthoma. Okay, just remember, if you are able to see this type of collection of this fat, it is what? It is the xanthomas which is causing this type of giant cells which is known as Teuton's giant. Okay, that's it, guys. These are this few giant cell images you need to look into. Like horseshoe shaped will be seen in a case of TB. They are known as Langhans cells. Next one, Wadden-Finkeldy giant cells will be seen in a case of measles, and Multinucleated giant cells in SMAX, like in 𝗧𝗵𝗶𝘀, will be seen in a case of herpes simplex virus. And next, this olive appearance, blue eye will be seen in a case of CMV, whereas red eye will be seen in a case of Reed-Sternberg cell. Will be seen in a case of Reed-Sternberg cell. Okay. And this fat containing cytoplasm 1, it is known as 2 tons giant cell. It is known as 2 tons giant cell. Okay, good guys. Good Dr. 𝗏𝗏 and good Dr. 𝗏𝗏𝗀𝗀, like, yeah, good Dr. the creations, yeah, you are getting it correct. Fine. Next, we'll move on to these few genes of carcinogenesis. Let me give you the disclaimer. Yeah, these genes will be bit confusing. It will be bit confusing, I know. Okay, but there is no option. You should read it. If it is more confusing for you, what you can do is that you can make a list of it. Like, I'll tell you for which things you need to make a list. In pathology, make sure you are making this list for these genes and for this tumor markers. Okay, if you try to make these 2 things and few in long run, I will tell you, then you just sticks them into your wall or into your library part. If you do these things, then what will happen is you will able to see them in regular basis, and if you see them in regular basis, you will able to get these things into your mind, and it will be under your subconsciously you will get these answers correct. Okay, and I will try to tell you this about this genes. Okay, and about this genes, first we'll see about this growth factor, and this growth factor, which includes the first gene, it is this 𝗏𝗏𝗃 gene. So if you see this 𝗏𝗏𝗃 gene, so remember this, make 𝗏𝗏𝗃 into OST. So remember, 𝗏𝗏𝗃 will be seen in a case of osteosarcoma, will be seen in a case of osteosarcoma. Next one, there are these 2 genes, cis gene and PDGF-beta. This platelet derived growth factor, they will ask you, platelet derived growth factor will be seen in a case of astrocytoma. Okay, astrocytoma. So 𝗏𝗏𝗃, osteosarcoma, PDGF-beta, astrocytoma. 𝗏𝗏𝗃, osteosarcoma, PDGF-beta, astrocytoma. Yeah, good guys. Then this growth factor receptor, this includes this ALK, EGFR1. Remember, it's EGFR1. EGFR1, it is for this adenocarcinoma of lung. Whereas this EGFR2, which is this HER2/neu. Okay, HER2, both of them it will be positive for this breast cancer, or both of them it is responsible for this breast cancer. So HER2 and EGFR2, it is this breast cancer. You can remember this EGFR2, second alphabet it is this B. So second alphabet it is this B, which is this breast cancer. Next, if you see the next one, this 𝗏𝗏𝗃 or CD117. 𝗏𝗏𝗃, CD117, you can remember by this mnemonic of games, you remember it as GIST, AML and melanoma. And finally the seminoma. So GIST, AML, melanoma and seminoma. GIST, AML, melanoma and seminoma, all will be positive for this 𝗏𝗏𝗃 or CD117. 𝗏𝗏𝗃 and CD117, the GIST, AML, melanoma and seminoma. GIST, AML, melanoma and seminoma, it will be positive for 𝗏𝗏𝗃. Next, this red gene mutation will be responsible for one disease and one multiple endocrine neoplasia. So it is responsible for this disease, which is known as Hirschsprung disease. It is known as Hirschsprung disease, which is what? Which is this congenital aganglionosis. Yeah. Then MEN2A, it is because of this red gene mutation. It is because of this red gene mutation. We'll discuss this MEN in our medicine part. Fine. Next, about RAS genes. You need to know about this KRAS, HRAS, NRAS. Okay, RAS. Okay, remember RAS or RAS. Okay. If you see this K, remember it as cool lip. You know this cool lip, right? Remember it is the colon cancer, the lung cancer, and this pancreatic cancer. So okay, remember this is 3-1. Cool lip. Okay, it is this colon cancer, lung cancer and pancreatic cancer. The 3 cancer, colon cancer, lung cancer and pancreatic cancer. Next one, it is this HRAS. This HRAS, it will be causing in, or it is responsible for this kidney tumors and pituitary tumors. So HRAS, it is for this kidney tumors and pituitary tumors. KRAS, it is this cool lip, colon cancer, then the lung cancer and this pancreatic cancer. Colon, lung and pancreas. Then there is 2 cancers, gene NAS and gene ARC. So you remember this ARC means it is responsible for this I1. So then it is what? Then it is this uveal melanoma. Gene ARC, it is responsible for this uveal melanoma, whereas gene NAS, it is responsible for this amyotrophic adenoma. Okay, amyotrophic adenoma. Then the final one, it is this BRAF mutation. This BRAF mutation, it is classically seen in a case of papillary carcinoma thyroid and in child who is presenting with features of ataxia and vertigo. And on evaluation, you will be able to see in cerebellum, there will be what? There will be this cystic mass. The most common site of this pilocytic astrocytoma, it is the cerebellum with this cystic mass. Okay, so this BRAF gene mutation, it is papillary carcinoma thyroid, pilocytic astrocytoma, melanoma, colon cancer, and Langerhans cell histiocytosis, and hairy cell leukemia. Hairy cell leukemia. Okay. Then about the MIC, there are 3 MICs you need to remove: 𝗔𝗵𝗃, 𝗵𝗃, and 𝗔𝗵𝗃. C, remember it is B, C. So remember after B, the C will come. So Burkitt lymphoma. So 𝗔𝗵𝗃, it is for this Burkitt lymphoma. Can anyone tell me what is the enzyme deficient in a case of Cory's disease? Yeah, guys. What is the enzyme deficiency in a case of Cory's disease, the glycogen storage disease? Mnemonic. Yesterday we studied, right? C, D. So Cory's disease, it is what? It is this D branching enzyme. Yeah. Yeah, water soluble also it is BC. Yeah. It is what? It is this D branching enzyme. Yeah, good guys. It is what? It is this D branching enzyme. Okay, and we know this Anderson disease, it is because of this branching enzyme. Good enzyme. And next, if you see, there is this 𝗪𝗵𝗃. Remember this L for this L. So this 𝗪𝗵𝗃 will be seen in a case of small cell lung cancer. It will be seen in a case of small cell lung cancer. So 𝗔𝗵𝗃, it is for Burkitt's lymphoma. 𝗪𝗵𝗃, it is for this small cell lung cancer. And 𝗪𝗵𝗃, it is for this neuroblastoma and medulloblastoma. So 𝗪𝗵𝗃 for this N and M, neuroblastoma and medulloblastoma. 𝗪𝗵𝗃 for neuroblastoma and medulloblastoma. 𝗪𝗵𝗃 for small cell lung cancer. 𝗔𝗵𝗃 for Burkitt's lymphoma. Okay, and cyclin D1, it is responsible for this mantle cell lymphoma, and CDK4, it is responsible for this glioblastoma. So glioblastoma, it is because of the CD4, cyclin D1, this mantle cell lymphoma, 𝗔𝗵𝗃 for Burkitt's, 𝗪𝗵𝗃 for small cell lung cancer, 𝗪𝗵𝗃 for neuroblastoma and medulloblastoma. And BRAF we told, that is the papillary carcinoma thyroid, pilocytic astrocytoma, melanoma, colon cancer, and Langerhans cell histiocytosis, and the opposite of it, it is what? It is this hairy cell leukemia. For RAS, it is the KRAS. KRAS, we remember it is cool lip. It is what? It is the colon cancer, lung cancer, and pancreatic cancer. Next one, it is this HRAS. HRAS, which include this kidney and pituitary tumors. Next one, it is this NRAS. N, it is responsible for this melanoma and AML. Whereas this GNAC, it is responsible for this uveal melanoma. Okay. Then remember this HST for osteosarcoma. HST, it is for osteosarcoma. Then PDGF-beta. PDGF-beta, it is responsible for this astrocytoma. ALK and EGFR1. 1, it is for lung tumor, whereas EGFR2 and HER2, it is for this breast cancer. Okay. Then one this 𝗔𝗃 or CD117, it is for this GIST, AML, melanoma, and seminoma. Okay, the games one. GIST, AML, melanoma, and seminoma. Okay, it will be a bit difficult for you while reading for this first or second times, but in long run you will be able to get this. So just make sure you are making it into your short notes or into your small sticky notes and sticking into your walls. Okay. Yes. Then we'll move on to this tumor markers. And about this tumor markers, what is the use? If you see, there are few conditions which you will diagnose radiologically. Okay. There are few conditions you diagnose it radiologically, and those conditions, when you cannot diagnose radiologically, in such conditions you need this tumor marker, or you just a second, sorry. Yeah, guys. Then if you see this tumor markers, it is mostly useful in a case of tumors which is not radiologically detectable, and to know this progression of these tumors. For example, if you see this beta HCG, which is this choriocarcinoma. So we know usually we use this beta HCG for our pregnancy testing, but in a case of choriocarcinoma, we'll use the same. It is what? It is this beta HCG. So choriocarcinoma will use this beta HCG, and remember, in a case of molar pregnancy also we'll measure this beta HCG. So beta HCG for pregnancy testing and molar pregnancy. Next one, if you see this calcitonin, we know there are two cells, follicular cells and C cells in thyroid. So the C cells, it is responsible for this calcitonin, and if there is any tumor of this calcitonin secreting cells, it is what? It is this medullary carcinoma thyroid. It is this medullary carcinoma thyroid. Next one, this catecholamines. This catecholamines and their derivatives, it will be released in during this pheochromocytoma. We'll call them as MVA, okay, or metanephrines. And 5-hydroxyindole acetic acid, it is seen in a case of carcinoid tumor. We know they are this serotonin derivatives. So this 5-hydroxyindole acetic acid, it will be used in the diagnosis of carcinoid tumor. And we know this fetal tumors. This alpha fetoprotein, it is used for the diagnosis of this fetal tumors or this yolk sac tumors. It is what it is, this yolk sac tumor and hepatocellular carcinoma and hepatoblastoma. Hepatocellular carcinoma and hepatoblastoma. All of these things will use this AFP as a marker. So remember 𝗵𝗔, it is choriocarcinoma. Calcitonin, it is this medullary carcinoma thyroid. Catecholamines like metanephrines, it will be used in a case of pheochromocytoma, and 5-hydroxyindole acetic acid, it is used in a case of carcinoid tumor. And AFP, alpha fetoproteins, it is used in a case of yolk sac tumor, hepatocellular carcinoma and hepatoblastoma. Yeah, good guys. Then if you see about the CEA, it is used in a case of colon cancer. Carcinoembryonic antigen, it is used in a case of colon cancer. And PSA and PAP, it is used in a case of prostate cancer. It is used in a case of prostate cancer. And we know in a case of multiple myeloma, there will be mostly defect in this small chains or this light chains, and there will be enormous amount of this immunoglobulin protection. So multiple myeloma will use this immunoglobulins as a tumor markers, and neuron specific enolase will be used in a case of neuroendocrine tumors like our small cell lung cancer and neuroblastoma. And for ovarian, it is 125. Remember, it is 125. 125, it is this ovarian cancer, whereas 19, remember this, make this 9 into P. So it is what it is, this pancreatic cancer. If you flip this 9, it is this P, so it is the pancreatic cancer. Next, it is this 3. If you make this 3 like this, it is what it is, same B, right? So CA15-3, it is this breast cancer. CA15-3, it is the breast cancer. And NMP22, just remember this may ask in your upcoming examination. NMP22, it is used for this urinary bladder cancer. It is used for as a tumor marker in a case of bladder cancer. Yeah, you identified and you know this progression of the tumors, this blood. But when you given a slide, you need to prove them that this is this tumor, or this is from mesenchymal origin, or this is from this epithelial origin. So to do those, then we'll use this marker which is known as immunohistochemistry markers. So immunohistochemistry markers, they will ask you, there is an epithelial tumor like squamous cell carcinoma, and the following image has been given, and which of the following immunohistochemistry marker you will see in this case. So in a case of any carcinomas, like squamous cell carcinoma, you will see this cytokeratin. C for carcinoma and C for cytokeratin. फिर उसके बाद in the case of sarcoma में क्या देखेंगे हम? Sarcoma में vimentin देखेंगे. So in the case of sarcoma, we'll see vimentin. And in the case of lymphoma में, then we'll see this LCA and CD45. So remember, lymphoma, LCA and CD45. Lymphoma, LCA and CD45. Next one, in the case of melanoma, we'll see HMB45. Then again this vimentin positive, then S100. There is one more thing which is known as S100. Okay. Then about this neurofilaments will be seen in a case of neurons and neurogangliomas, and desmin will be used in a case of myomas or this muscle tumors, and GFAP will be used in a case of astrocytoma and oligodendroglioma and ependymoma. So GFAP will be used in a case of astrocytoma, oligodendroglioma and ependymoma. Okay, so just remember this IHC markers. C for C, cytokeratin will be used in a case of carcinoma. Yeah, good Dr. Anjali. Good Dr. Pratap. Yeah, good. Then we'll move on to this most interesting part, it is this pedigree part. You see, this pedigree part, it looks very much simple, but it is as complex as it is. So if you see in normal during the class times, you will be able to see this pedigree charts. So you will be able to come to the conclusion, yeah, this is the answer. But when you see in the main examination hall, everything looks similar to you. Okay, the option A, option B, option D and option C, all of them, it looks very much similar to you. So in such scenarios, you need to have a few differential points. आपके पास few differential points होना है, तो अगर आपके पास वो few differential points है, then you can come to this conclusion to the earliest. ठीक है? So to solve this pedigree charts, you need to look into this. கண்டிப்பா தமிழ்ல சொல்லலாம், ஒன்றும் பிரச்சனை கிடையாது, but எல்லாருக்கும் புரியணும் இல்லையா? Then if you are able to see this pedigree chart, you need to see first there is this thing which is known as gender. Then if you see, next one is the generation. Okay, generation. Okay. See, yeah, good, Dr. Shanvaskan, you already started answering, but like, yeah, let others to understand what is the thing which is going on. Fine, yeah, good. That is really good. Okay, you are understanding very well. And first, you need to see this gender. Next one, you need to see about the generation. So, if there is any gender bias, present, gender bias agar present hai, then it is what? It will be two things. Either it is X-linked dominant and X-linked recessive. So remember, who is this dominant species? Is it male or female? Or who is dominant in your home? It looks like that male are the dominant people, right? But actually not. The females are the dominant people. So remember, this X-linked dominant, it will be affecting the females. Okay, it is females to all the sons and are the father to all daughters. Okay, especially it will be mentioned like father to all daughters will be seen in a case of X-linked dominant. Okay, X-linked dominant. So see, is this a female? It is being transferred to this male, and this from this male it is transferred to all these female genders. Okay, only these females are being affected once the male is affected. So it is what it is, this X-linked dominant condition. So it is what it is, the X-linked dominant condition. Yeah, good, Dr. Kandesh. Yeah, where level da. Okay, then if you see this X-linked recessive condition, then as I told you, the males are recessive. Okay, the females are dominant. So in a case of X-linked recessive conditions, the males will be affected. The males will be affected. Agar if a disease is spreading from a female, it is the female. ठीक है ना, जो भी गोल है वो female है. ठीक है, so whichever is in round, it is the female one. It is the female. Okay, agar if it is in a square, it is the male. ठीक है, इतना याद रखो, उधर जाके कंफ्यूज नहीं होना. Like just make these things simple things. You just remember, there you are getting confused in the examination whether this is male or female. Okay, okay, male will be they won't care about the shapes, right? But females, they are always the figuring shape. So see this circle, it is very much good in shape. So remember, the females will be represented as circles. Okay, at the proper shape. Okay, just remember. Then this, if from females to all the males are being affected, then it is what? Then it is the X-linked recessive condition. Right? Then this is this gender bias. If this gender bias is present, ठीक है, yeah, confusion होता तो बस इसको देख लो. अगर इसके हिसाब से आप जाओगे, then you won't get confusion. So that is why there is a sequential. सबका एक step होता है. ठीक है, अगर एकदम से आप कुछ करोगे तो कुछ नहीं होगा. पहले आपको मन बनाना पड़ता है, फिर उसके बाद उसको decode करना पड़ता है. तो you should have all these things in your mind. You should go step by step. पहले हमने gender देख लिया. First we saw this gender. If females are affected and the females are affected from the males, then it is what? Then it is X-linked dominant. Or if it is males are being affected and this affected males are being affected from a female, then it is what? Then it is X-linked recessive condition. Then we need to go into this, which is this generation part. Then in a case of autosomal diseases, autosomal one, yeah, that's what, yeah, that's Dr. Shanvas Khan, that game changer will change your game and will clear your confusion. Yeah, good. Okay, if you see this autosomal one, there will be no gender bias. No gender bias means both females and males will be equal. Okay, both females and males will be equally affected. Whereas here you need to look into this generation, means how you are spreading to your generations. For example, you passed your FMGE examination, then you need to tell to your juniors like ऐसे करना, means like this you need to do, like this you need to do your preparation part, and that's how you will pass your examination. अगर आपने अपने juniors को नहीं बताएं, then there will be a gap in the generations, they will tend to fail more. ठीक है ना? So if you see, if there is any gap in the generations, if there is any gap in the generation, if you see this is the affected male and there is none of them they are affected. None of them they are affected. So if there is any gap in the generations, then it is what? Then it is autosomal recessive. If gap present, then it is the autosomal recessive. Lekin you passed your examination. See, you passed your examination with good marks. Okay, and once you passed, what you did, like I guess this blue one, like see this blue one. So once you passed, or this red one, so imagine whatever you want, like once you pass this as red one, so just keep you are affected. Once you are affected, or once you pass this examination, you tell your juniors like this you need to pass, or like this you need to do. You told to the juniors, and he obviously what? He or she will pass. So this will be passed to the next generations, and both Males and females, like you won't see like only females I will tell you, only males I will teach you. No, it's not like you should tell to everyone. So in the case of autosomal dominant, you will pass from one generations to the all generations. So your junior, your super junior, all of them will be passed. So if there is any disease which is presenting in this grandparents, grandmothers and your parents and you, it is what it is in a sequential and all the generations are affected. So it is what it is, this autosomal dominant in nature. Okay, it is autosomal dominant in nature. Why mother from X-linked dominant, daughter is not affected? See, there is this X-linked conditions, there will be thing which is known as homozygosity and heterozygosity. Okay, to express something it should be homozygous in nature, whereas in a female it is XX, whereas in male there is only XY. So if only one chromosome, if it is coming from female, which is this X chromosome, then it will obviously come and manifest to the patient or to the person or to the next generation, whereas in females there is 2X, one will be coming from mother and one will be coming from father, so only one will be expressed, so there won't cause any disease in females. Okay, so mother cannot give disease to them, whereas the mother will give obviously her X to this child. So that's why the male child will be affected in a case of X-linked dominant condition. Okay, so that's what. So X-linked, first you see gender. If there is any male gender affected, it is their recessive gender. So it is X-linked recessive. If it is female gender affected, it is X-linked dominant. And if there is any no gender bias, but all the generations are involved, then it is what? Then it is autosomal dominant. And if there is a skipping in generations, then it is what? Then it is the autosomal recessive. Then it is this autosomal recessive. Keep in mindset, whatever you have, it is you are having. It is not your friend or your padosi is having, that it means it is yours. So if you see in your exam, these questions will be asked, and it looks like all of the generations are being affected. See, this is the affected one, this is the affected one, and I told you these are the 3 unaffected children, whereas the someone from other family or from outside, they are getting married. So don't consider this outside peoples as you or as your family. Okay, neighbors will always stay as neighbors. Okay, so have a limit in them. So the same way, if you see, if they are affected but they are coming from outside, so they are not considered as generations. So the generation of this are this 3 and these 3 are unaffected. So it is autosomal recessive. So don't have confusion in it. Okay. Yeah, that is, if you ask me, can means in medicine everything is can. Okay, in medicine everything is can, but most commonly we are speaking, because this exam is based on the most common and the most easiest things. For example, they will ask you TB, because we are having more cases of TB in India. Okay, that's why. And the most common are this in a case of dominant, X-linked dominants, the most commonly affected, they are the females. Okay, that's it. Next, if you saw a female who is giving all his generations the disease, but when it comes to the male, it is not being given to the other generations. So what is this type of inheritance? What is this type of inheritance? If a female is transferring to all his child, whereas this male is not transferring to this next generation, it is what it is this. Yeah, good guys, it is this mitochondrial inheritance. Mitochondrial inheritance. Okay, if you have any more doubts, just make sure you are keeping with you. We'll discuss about it at the break. Okay, so it is what it is, the mitochondrial inheritance. So to know this, you just see this, all these diseases, these are this autosomal dominant and autosomal recessive diseases. If you're able to remember them, well and good. If not, just remember few things. Autosomal dominant conditions, they will involve this structural genes especially. For example, in a case of Marfan's, there will be this involvement of this elastin genes, whereas in a case of dystonia and osteogenesis imperfecta, there will be this involvement of this collagen. So if there is any structure defects, it will be usually autosomal dominant in nature. Whereas if there is any enzyme defect, it will be usually autosomal recessive, like our phenylketonuria, alkaptonuria, then sickle cell anemia, thalassemia, and especially this alpha-1 antitrypsin deficiency, and all our glycogen storage disease and lysosomal storage disease, all of them, they will be autosomal recessive in nature. Whereas few conditions it will have add-on, like sickle cell anemia, thalassemia, cystic fibrosis, hemochromatosis, and Wilson's disease. They are also autosomal recessive in nature. So if you're not having any clue, if there is any enzyme deficiency, mostly it will be of autosomal recessive nature. If there is any structural defect, it will be autosomal dominant in nature. ठीक है, इतना याद रखो। फिर इसके बाद there will be few conditions which are actually enzyme deficient, but they have this exception. So example, this G6P deficiency, this Hunter's is, yesterday we discussed it. Hunter will be having this clear cornea and they need to aim it. So when you need to aim, you will put a cross. So if you're able to see this cross, means it is X. So Hunter's disease will be having this clear cornea and a X-linked recessive inheritance. And X-linked dominant, you just remember this 4 conditions, which is this Ravi. Okay, which is Ravi, which is Rett syndrome, Alport syndrome, vitamin D deficient or vitamin D resistant rickets, and incognitia pigmenta. Okay. Yeah, good. Then about this few diagnostic techniques. If we see about this diagnostic techniques, like these are used to analyze this genetic syndromes. The first one, it is the karyotyping. Can anyone tell me what is this karyotype tells you? It is trisomy of which chromosome? It is the trisomy, good. It is the trisomy of 21, which is this Down syndrome. Good guys. Good. Dr. Diana, Anju, Preeti, Shanwas, Chiku, Aishi, Naresh, well, okay, well said. So it is what? It is this trisomy of 21, which is this Down syndrome. And next, if you see in this karyotyping method, we cannot see everything. Like we can see mota means if something is visible or gross, we'll be able to see it. Whereas if there is any small translocation, or if there is any mutation part, then we cannot find it. With this karyotyping. तब हमें क्या करना? तब हमें एक दूसरा investigations करना है. उसका नाम है FISH, fluorescent in situ hybridization. Okay, so we'll see like how about the genes, how about whether they are normal or not, or if these 2 genes, if they are getting fused together. So if there is any fusion of this 2 genes, so here these genes are separate. First see here the genes are separate, whereas if these 2 genes they fuse together, it leads to this translocation and fusion. So if we see this translocation or BCR-ABL fusion, you will see this BCR-ABL fusion in which condition? You will see in a case of CML. Remember. And next we have one more condition, which is known as what? Which is known as comparative genomic hybridization. In the case of comparative genomic hybridization, we compare with these normal intervals whether there is a loss of gene or there is a gain of gene. Remember, the yellow one, these are this normal one. Okay, whereas this red one, it is the gain. So remember, it is the red one which is gain, and the green one, it is this loss of function. Red one, it is the gain, and green is the loss of function. Right? And next, we'll move on to the next topic, which is this amyloidosis. This amyloidosis, it is what? It is simply, they are the proteins which deposited into this extracellular matrix. This is this extracellular deposition of this amyloid proteins. Okay, amyloid proteins, and usually it will be in this beta pelated sheets. It will be usually deposited in this form of beta pelated sheets. And next, this amyloid, it won't see organs. It won't see organs and deposit. It will go and deposit into the organs whichever you want. If you just go and deposit into this kidney, so it is what? It is known as waxy kidney. Okay, waxy kidney, and this will be leading to this nephrotic syndrome. Whether if it is deposited into the heart, it will cause what? It will cause this restrictive cardiomyopathy. And GIT, it may lead to this hepatosplenomegaly. And skin, the skin will be waxy thickening. The skin will be like wax thickened, like there is a thickening, right? There will be waxy thickening, and it will be easily bruisable. And neurologically, it may accumulate near to the nerves and can cause compression, which is the carpal tunnel syndrome. And there are different types of amyloidosis. Primary amyloidosis, it is this, our famous multiple myeloma, which is due to this mutation in this light chains. Of this immunoglobulins, right? And next one, it is the secondary amyloidosis. And this secondary amyloidosis means it is because of some other conditions, and they have a specific type of amyloids. If you see this type of AA type of amyloid, yeah, in the case of carpal tunnel syndrome, the nerve which is being involved, it is this median nerve, and we know this. If there is any median nerve involvement, there will be this Benedict's hand, and there will be this pointing index formations will be seen in a case of median nerve injury or median nerve compression. Okay, and next one, it is this secondary amyloidosis. In the case of secondary amyloidosis, as I told you, there will be what? There will be different types of amyloid deposition. So if you see the first one, it is AA type of amyloid, will be seen in a case of familial Mediterranean fever and other chronic inflammatory conditions. And next one, it is this ATTR. Okay, it is this transthyretin kind of one. If it is getting deposited, which is normal one, then it will be mostly deposited into the heart. If it is mutated type of TTR, if there is any deposition of this mutated type of this transthyretin one, then it lead to this familial amyloid polyneuropathy. And next, the most important one, and usually they will ask you, which of the following condition it is being associated with this beta-2 microglobulin? Beta-2 microglobulin, it is associated with this dialysis patients. So dialysis patients, they will be having this amyloidosis, especially or this peculiarly this beta-2 microglobulin. Okay, and in the case of Alzheimer's disease, you will be able to see this beta amyloid in amyloidosis in Alzheimer's disease, whereas in a case of beta-2 amyloid or beta-2 microglobulin will be seen in a case of dialysis. AA will be seen in a case of familial Mediterranean fever. Okay, and AIAPP will be seen in a case of, remember, it is type 2. It is the type 2 diabetes mellitus. Where you will see this isolate amyloid polypeptide type of amyloid deposition. And next, ACAL. We discussed there are two cells in this thyroid. There is this follicular cells and C cells which produces this calcitonin. And if there is any mutation or if there is any tumor, it is what it is, this medullary carcinoma thyroid. And there will be deposition of ACAL. Can anyone tell me what is this? What is the tumor marker you will use in a case of medullary carcinoma thyroid? Yeah, guys? You're waiting for your answers? Yeah, good guys. It is what it is, this calcitonin. So medullary carcinoma thyroid, it will be associated with this calcitonin, and to diagnose this, we'll use this calcitonin. Okay, and there will be this ACAL deposition. And we know this amyloidosis, but we won't accept it, right? Like, because you're a doctor, you tell them fever, common cold. No, I won't accept. I need to see them. I need to see the patient. But if you see a pathologist, they need to see and tell you. They need to see, and then only they will confirm you. So you will stain this amyloid. So stain this amyloid, you will use the stain which is known as Congo red. And if you stain this amyloid with this Congo red stain, and if you look under this normal light microscopy examination, you will be able to see this type of common pink color, okay, in a normal light microscope. Whereas you kept under a specialized polarizing microscope, you will see this apple green birefringence. Okay, apple green birefringence. Okay, that is the thing you need to know about. Yeah, good guys. That is the thing you need to know about this amyloidosis. Next, if you see, there is this photosensitive rash, which is especially on this space, around this space, and it is sparing this nasolabial fold. So it is what it is, this classical definition of SLE. And to diagnose SLE, there are few antibodies you will use. Which of the following antibody will use, which is both sensitive and specific? It is this anti-dsDNA antibody, and the most sensitive one, it is this anti-nuclear antibody, whereas the most specific one, it is this anti-Smith antibody. So anti-ANA and anti-Smith antibody, which is the most specific one for both, it is what it is, anti-double stranded DNA antibody. And in the case of neonatal will cry. So cry ko Hindi mein kya bolte? Rona. So Rona. Okay, so neonatal lupus, it will be having this positivity for this Rho antibodies. And if there is any psychosis, remember, psychosis P for B, it will be involving of this anti-ribosomal P antibody. So most specific, it is the Smith. Both specific and sensitive, it is double stranded DNA antibodies. Rona, if it is involving this neonates and children, it is anti-Rho antibodies. Whereas if it is involving this psychosis or neurological system, it is anti-ribosomal P antibodies. Okay, and in CVS, it may cause deposition into this cardiac valve, causing this 𝗵𝗵𝗀𝗃 endocarditis. And in kidney, it will cause this type of arrangement, which is called known as, on fluoroscopy, you will be able to see all the antibodies will be present. It is known as full house effect. It will be seen in a case of lupus nephritis. And here you will be able to see this wire loop lesions. Wire loop lesions. Okay, that's it, guys. That's what mainly from pathology perspective we need to know about this SLE. फिर उसके बाद आगे बढ़ते हैं hypersensitivity reactions. You know there are different types of hypersensitivity reactions. Type 1, it is what? It is just the simple allergy. तो allergy में क्या क्या हम include करेंगे? Allergic rhinitis, allergic dermatitis, stink attack, which is this vernal keratoconjunctivitis, and atopy like penicillin allergy. Okay, initial part of penicillin allergy, and this Cassoni test which used for this Echinococcus granulosis. Okay, the dog type one. Next one, that is what this mainly is allergy reaction, which is IgE mediated. IgE mediated. फिर उसके बाद आगे बढ़ते हैं type 2 hypersensitivity reactions. Yeah, type 2, yeah, it is mainly of blood related. Whatever is this, like blood transfusion reaction, autoimmune hemolytic anemia, ITP, all of them, they are what? They are this type 2 hypersensitivity reactions. And rheumatic heart disease, the initial part, there will be this molecular mimicry. It is also type 2 hypersensitivity reactions. And this Graves disease and myasthenia gravis, previously they are known as type 2, now it is type. Okay, and there is this syndrome which is known as Wood-Pasture syndrome. Okay, but it's antibody against this glomerular basement membrane. Okay, and also this hyperacute rejections because of this preformed antibodies. It is also type 2 one. Next, if you see this type 3, that is this Arthus reaction and reactive arthritis, and this 3-word vasculitis like SLE, PAN, polyarthritis nodosa, HSP, and PSGN. Okay, PSGN. So remember, rheumatic heart disease, it is due to this molecular mimicry. So molecular mimicry, it is type 2 hypersensitivity reactions, whereas post-streptococcal glomerulonephritis, it is what? It is this type 3 hypersensitivity reactions, which is because of this immune complex deposition. It is this immune complex deposition. So see, someone comes, you will just send IgE and it is allergy, whereas you see send this antibody against a specific receptor. So it is what? It is this antibody mediated, whereas here this there will be this antibody and someone else will come in, but what they will do, instead of attacking, what they will do, they will just sit and chit chat. There is this deposition, they will come and deposit like this. Okay, so it is this type 3 hypersensitivity reactions, whereas type 4, it is what? It is this late or this lymphocyte mediated. So this includes like our Montauk's test and Lepromin test and our famous contact dermatitis. Remember, this allergic dermatitis, it is the type 1, whereas this contact dermatitis, it is what? It is this type 4 hypersensitivity reaction. Then we'll move on to the next part. It is this rheumatic heart disease and the endocarditis. Okay, it is one of the hot topic which is being tested multiple times and more frequently. They will give you this image and they will ask you, what is the name of this body? Okay, so what is the name of this body? I'll give you 5 seconds. Think and tell me. Yeah, go Dr. Ansh. It is what? It is this ʔ body. It is known as ʔ nodules especially. Okay, ʔ nodules. And here you will able to see this type of cells and cross section. They are known as caterpillar cells. Okay, they are known as, see, it is like a caterpillar, right? This is known as caterpillar cells. It is known as, yeah, good guys, it is known as caterpillar cells. Next, if you see, there are few criteria you need to know. So to know about this criteria, you know what is the name of the criteria? It is the Jones criteria. So J for G, it is the joint involvement, and next one, it is the O, like how we made for Pompe's disease, right? Pompe's O will make them into heart. Okay, will make them into heart. So take it, जैसे हमने दिल बनाए, वैसे Jones, it is causing in rheumatic heart disease, उसको भी हम दिल बनाएंगे, तो it is what? It is this pancarditis. So Jones O for O, it causes this pancarditis. Next, it causes this subcutaneous nodules, which are usually painless, and erythema marginatum. So it is the Jones. Okay, nodules, N for nodules, and erythema marginatum, and Sydenham's chorea, and next one is the chorea. I told you, right? Chorea, Sydenham's chorea. And if there is any chorea, it will involve which of the following cranial nuclei? Yeah, guys, if there is any involvement of this chorea, yesterday we studied in anatomy, right? What is the name of the nuclei? HL, if you have already this love, yeah, it is what? It is this caudate nucleus. It is this caudate nucleus. It is the caudate nucleus. Yeah, good guys. Next, there are a few minor criteria you need to think of. Fever, polyarthralgia, there will be increased PR interval, and ESR and CRP will be raised. And there will be this valve involvement. The most common valve, we know the most common valve to be involved in a case of rheumatic heart disease. It is what? It is this mitral valve. So in a case of acute rheumatic heart disease, there will be this mitral regurgitation, whereas in a case of chronic, there will be this mitral stenosis, and we know when there is this mitral regurgitation, the blood will come back. When the blood is coming back, it will come and cause a lesion over this left atrium. It is known as 𝗵𝗶𝗀𝗀𝗀 patch. It is known as 𝗵𝗶𝗀𝗀𝗀 patch. Fine. Then here you will be able to see a cell which is known as Anischkow cells. Okay. Then about this infective endocarditis, yeah, there will be able to see this fish mouth valve as well. Yeah. When there is this mitral stenosis will be overwhelmed, there will be small opening will be left. That is known as fish mouth or this buttonhole valve. Yeah, good Dr. Ansh and Pratap. Next, if we see about this infective endocarditis, there is a criteria which is known as Duke's criteria, which we'll use to diagnosis. Okay, and the main major criteria is what it is, this positive for this blood culture, and it will be having this investigation findings, the suggestive investigations, like you do echo and you will be able to see large visitation. Then it is what? Then it is infective endocarditis. Okay, and the minor criteria include this temperature and our two phenomena, immunological phenomena and this vascular phenomena. So the immunological phenomena, it is this Roth spots and the Osler nodes. So remember, the Osler nodes, they are the painful. So Osler nodes, it will be painful nature, whereas Janeway lesions, they are painless in palms. Painless, तो इसलिए वो क्या होता है? Palm में होता है. Remember, okay? And next, how will you differentiate based on this type of lesions? So as I told you, in a case of infective endocarditis, there will be this large lesions. There will be this large lesion. Sometimes they will break into small and can cause into an emboli. So if you're able to see this large bulky lesion, so it is this infective endocarditis. Whereas if you're able to see this type of lesions which is occurring on this both side of the wall, if it is occurring on the both above and below of the wall, it is known as 𝗵𝗵𝗀𝗀𝗀𝗀 endocarditis. Today we studied in where we will see this 𝗵𝗵𝗀𝗀𝗀𝗀 endocarditis. Yeah guys, 𝗵𝗵𝗀𝗀𝗀𝗀𝗀 endocarditis will be seen in a case of SLE. Okay, will be seen in a case of SLE. Fine. Whereas in a case of rheumatic heart disease, you will be able to see small prim and friable vegetations. Good guys. Whereas there is also one more thing which is seen in a case of like tumors, like non-bacterial thrombotic endocarditis, which will be mostly seen in a case of leukemias. Good guys, you are getting it correct. Next, about this vasculitis component. Okay, about this vasculitis component, if you see, there will be a old age male who is presenting with complaints of headache. And on evaluation, you will be able to see there is this some mass which is palpable on his temporal lobe. So sometimes it will be associated with this ophthalmic nerve involvement. So there is this old age male presenting with this sensation and presenting with this pain on his temporal aspect, and there is this thickening of some structure. So it is classical feature of giant cell arteritis. And in the case of giant cell arteritis, you will be able to see there is the fragmentation. This is the elastic lamina, and there will be this fragmentation of this elastic lamina, which is especially this internal elastic lamina. फिर उसके बाद you will see this young smoker who is having these features of this blackening of his fingers. These fingers became black or becoming auto amputation in a young smoker, especially this tip of fingers and tip of the toes. It is classically seen in a case of Burgess. Remember Burgess, U for U. Remember U, the next alphabet is V, so it is the vasculitis component. And in a case of Burgess disease, there will be involvement of both arteries, veins and nerves. So this will cause occlusion of them and it will cause inflammation over it. So Burgess disease, it is this involvement of this artery, veins and nerves. Okay, yeah, good guys. Yeah, Burgess smoking, yeah. The first one you will tell them to avoid smoking. And next, if you're able to see, you will unable to see the pulse of a child, and the disease which is known as pulseless disease, it is what it is, this 𝗧𝗵𝗶𝗀𝗀𝗀𝗀𝗧𝗵𝗶𝗧𝗃 arteritis, and it most commonly involves this subclavian arteries. Okay, it will most commonly involve this subclavian arteries. Okay, just remember, it will most commonly involve this subclavian artery. So this one, which is the 𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 it is the pulseless disease. Next, you saw this polyarteritis nodosa, like it won't involve continuously, it will be having this segmental involvement. It will be having this segmentally it will involve. There will be sparing will be there. Okay, that is this polyarteritis nodosa. And remember one thing, in a case of polyarteritis nodosa, there will be this 𝗃𝗃𝗃𝗃 will be positive in almost 30% of cases. This polyarteritis nodosa, they will be positive for 𝗃𝗃𝗃𝗃. And next, You see a child with these clinical features of this cream. There will be this conjunctivitis, then there will be this erythema and hand and foot edema, and along with this maculopapular rash, and along with this mucosal involvement like strawberry tongue. All of them, they are classically seen in a case of Kawasaki disease. Just remember. And in Kawasaki disease, you will be able to see this anti-endothelial antibodies. Fine. And there is one more disease which is known as microscopic polyangiitis. Just remember, there will be, in a case of microscopic polyangiitis, there will be positive for this P ANCA. P ANCA will be positive for microscopic polyangiitis. Okay. You see a child who is presenting with features of this rash over lower limb and buttocks with this palpable purpura. A child with features of this palpable purpura, and there is this abdominal pain sometimes. Abdominal pain. All of them, they will be suggestive of which disease? Yeah guys, good. It is what it is. This HSP, which is this Henoch-Schönlein purpura. Okay. And we know in a case of vaginous granulomatosis, there will be involvement of these three. The urine will be involved, lung and the cough will be involved, and the blood vessel. Okay, so there will be this lung, kidney, blood vessel involvement along with this perforation of this nasal septum. And remember, vaginous granulomatosis is one of the granulomatosis which is having this C ANCA positivity. So C ANCA positivity will be seen in a case of vaginous granulomatosis, whereas P ANCA will be seen in a case of microscopic polyangiitis. Okay, microscopic polyangiitis will see this P ANCA. Okay. I guess you don't have any doubts. If you have any, just put up in the chat box. Yeah, fine. That's good. I will go ahead. There is few more pathology part left. We'll have around till 12:30. Okay, fine. Yeah. Break. No, we'll have a good break. Like now only we started, right? We'll take a good break. Don't worry. We'll take a good chai break. Then after that, we'll take a great lunch break. Okay. So just have some patience, because you are watching this online, so you have the liberty to do it. Okay. But have patience and orient to this. That's when we can complete all these 19 subjects in next 3-4 days. Like we have this 5-day schedule and we should complete it. Okay. There is no more extra schedules. Okay. Next, if you're able to see the next one, which is this asbestosis. Okay, asbestosis. Remember, asbestosis, it is this base of the lung. It is what? It is the base of the lung. Yeah. Once after the pathology finishes, we'll give a good break to you. Okay. See, asbestosis, it involves this base of the lung. So it will involve this base of the lung, and mainly this asbestosis, it will be what? It will be having this involvement of this pleura. It will be having this involvement of this pleura. So once there is an involvement of this pleura, it leads to the formation of this pleural plaques. It will lead to the formation of this pleural plaques. Okay. And on evaluation, if you see, you will be able to see this type of bodies which are known as asbestos bodies, also known as ferruginous bodies. And we know there is a stain which we use to stain this iron. Okay. Iron will use a stain which is known as what? Pearl's Prussian blue. So this ferruginous bodies means it has iron. So to stain this, we can use this iron stain, which is this Pearl's Prussian blue. Okay, which is what? Which is this asbestos bodies, which is dumbbell in shape, which will be dumbbell in shape. Okay, and it causes few cancers like adenocarcinoma, which is the most common one, whereas the most specifically it causes this mesothelioma. It causes this mesothelioma. And next about sarcoidosis. Sarcoidosis, it causes this non-caseating granuloma. Okay, it causes this non-caseating granuloma. We discussed in tuberculosis, it causes this caseating granuloma or caseating granuloma, whereas this sarcoidosis will cause this non-caseating granuloma, and it will be naked. So it's not like dressless or without dress. See, the granuloma, it will be surrounded by this T lymphocytes, whereas in a case of, yeah, good guys, whereas in a case of sarcoidosis, there will be no T lymphocytes here. So that's why it is known as naked granuloma. And it will be having a syndrome which is known as Löfgren syndrome. It will be having the features of joint pain, fever, and erythema nodosum. So 3 features: joint pain, fever, and erythema nodosum. And here there will be an increased level of calcium and ACE. So to diagnose this sarcoidosis, we'll use this calcium and ACE levels. Next, CD4 and CD8 count, both of them will be elevated in a case of sarcoidosis. And it has two bodies. The star-shaped one, it is known as asbestoid body or asteroid body. And next one, the circular one, which is actually this calcium deposition. It is what it is, this Schaumann bodies. Okay, it is what it is, this Schaumann bodies. Okay. And then we'll move on to this lung tumors. Like it is the hot topic because the prevalence of smoking, it is being increased very long, and you know this air quality, the air quality of Delhi is being very decreased. Then it can lead to this activation of this oncogenes and can lead to this tumor. So they can ask you in future, right? Or ask you in this upcoming examination. So you saw this type of walling like an onion peel. It is what it is, this keratin pearls. So keratin pearls will be seen in a case of squamous cell carcinoma, and it is due to the mutation of P53, and it will be having the positivity for this P63 and P40. We told, right? We need to confirm it. I'm a pathologist, right? I need to tell, yeah, this is correct. Okay. So this P63 and P40 will be positive for this squamous cell carcinoma, and it causes this paraneoplastic syndrome, which is this just this hypercalcemia. Okay. Whereas if you're able to see, there is this formation of this glands. So this gland formation will be seen in a case of adenocarcinoma. We already saw there is this EGFR1 mutation, KRAS mutation, cool lip we learned, right? And this ALK gene mutation. All of them will cause this adenocarcinoma. And this for immunohistochemistry, we'll use this napsin, MUC1 and TTF1. Napsin, MUC1 and TTF1, and it will cause this one paraneoplastic syndrome, which is known as migratory thrombophlebitis. Here there will be vein inflammation, and tomorrow if you see, it will be here, and day after tomorrow if you see, it will be here. So it will be like this. And next, if you're able to see these small tumors, cells, they're having this neurosecretory granules, and if it involves these blood vessels, and if they're transported along these blood vessels, they are what? They are this small cell lung carcinoma, and it is due to this 𝗪𝗵𝗃. And it is due to this 𝗪𝗵𝗃, okay, and it will be having this salt and pepper chromatin, and because of this involvement of this blood vessel or this penetrating into the blood vessel, we'll call them as azopadi. We'll call them as azopadi. Party chal raha, okay. So remember, party chal raha, to sabko andar to aana hai na. So this tumor cells, they try to enter into the blood cells. So it is what is known as azopadi effect, okay. Party chal raha, okay. Remember the paraneoplastic syndromes, which includes this SAADH, Cushing syndrome, and Lambert-Eaton syndrome. Okay, there are three syndromes: Cushing syndrome, SAADH, and LES. Fine. And next day itself, we discussed this Barrett's esophagus. It is what it is. Just the metaplasia, which is this intestinal metaplasia, means there is this columnar cells along with this goblet cells. हमें पता है goblet cells है, लेकिन क्या है? मैं pathologist हूँ. I'm a pathologist, and if I'm a pathologist, I need to see them visually. ठीक है? Until unless I see them visually, I won't trust them. I won't trust with Instagram chats, right? So you need to see with the stain, which is known as what? Which is known as this Alchian blue stain. It stains this acidic mucin, okay, which is present from this goblet cells. बस इतना याद रखो, ठीक है? Yeah. So normally we'll be able to see here. This is how this normal stratified squamous epithelium, and here this is this intestinalized epithelium, which is having this goblet cells and this columnar epithelium. So this is the typical Barrett's esophagus, and we know Barrett's esophagus causes which type of cancer? Yeah guys, yeah, good Dr. Shanavas. Not acid fast. It will cause which type of cancer? It will cause this adenocarcinoma. Adenocarcinoma. Remember. Next we'll move on to this disease, which is the celiac disease. You have a patient who is presenting with features of diarrhea, and you ask, what did you eat? The patient tell he ate this, any of them, barley, rye, oats, or wheat, like a chapati he ate. So after this, he's having these features of diarrhea, weight loss, malabsorption. Then you plan to do this examination. Then you found out he's having this susceptibility of this 𝗪𝗔, and you took up a duodenal biopsy. There you will be able to see this first thing, that this villi, it will become atrophic. Usually it will be like this, like a happy, like you, but it became very sad. Means that this villus atrophy, because there is this hyperplasia. This hyperplasia, it is known as crypt hyperplasia, and along with this crypt hyperplasia, there will be these small cells which will be surrounding them. They are what? They are actually this CD8 lymphocytes. So there will be this crypt hyperplasia, villus atrophy, and this CD8 lymphocytes. All of them will be seen in a case of celiac disease. So here you will be able to see few antibodies as well. The most sensitive one, it is this anti-tissue transglutaminase antibody, whereas in the case of most specific one, it is this anti-endomysial antibody. This anti-endomysial antibody, it is the most specific one, whereas most sensitive one, it is this anti-TTG antibody. It is this anti-TTG antibody, remember. Next one, if you see this next disease, it is what? It is this Whipple's disease. So if you see about this Whipple's disease, the same features of malabsorption, there will be involvement of the systemic involvement. But when you do this biopsy, you will be able to see this only one feature, which is known as what? Positive macrophages. This positive macrophages, which will be having this Treponema Whipple bacilli. So this positive macrophages, it will be especially seen in a case of Whipple's disease. Okay, that is this foam cells, which are this macrophages, they are positive. And next about this tumor, yeah, good, correct, Dr. Anjali, it is positive. Next, if you see this tumor, which is known as what? Gastrointestinal stromal tumor. And this tumor, they have love to it. Okay, if you see, it will be originated from this cells of Kajal, and it will be having this games mutation. We discussed, right? c-KIT or CD117. What are the games? We'll see the GIST, AML, melanoma, and seminoma. So here it is what? It is this CD117 and c-KIT mutation, which leading to this GIST. And what it will cause? It will cause this increase the activity of this tyrosine kinase. So treat this, will give this imatinib. And as I told you, the marker is CD117 and CD-KIT. And there is also CD34 as a marker, but the most specific one, it is the dog one. It is the dog one. Okay, it is the dog one. Okay, remember. Next, we'll move on to this few urinary stones. If you see this type of hexagonal shape, that is what it is, this cystine. And if you see this type of coffin lid, yeah, good guys, coffin lid, it is seen in a case of what? It is seen in a case of true white or triple phosphate stones. Yeah, good. Then if you see this type of envelope shaped, then it is what? It is the calcium oxalate dihydrate. Okay, whereas if you see this type of dumbbell, okay, dumbbell, it is what? It is the calcium oxalate monohydrate. Okay, so sometimes you'll be having this confusion about this monohydrate and dihydrate, right? So remember, if you're single, then what you need to have? If you're single, you need to have two things to become mingle. Okay, remember. So you need to have a good face, or you need to have a good muscular structure. So obviously, not everyone will be having a good face and charismatic face. Then you plan to build your body. So how will you build your body? You will take up this dumbbells. Okay, so you are single, that's why you are lifting your dumbbells. So remember, it is calcium oxalate monohydrate, which is having this dumbbell shaped. And once you become committed or mingle, then what you will do? You need to increase the love. How will you increase the love? You will send the text. Now you are sending your Insta and Snap. Whereas now, previously what they used to do, they used to send the letters or this envelope. So remember, between these two, you need to have a communication. So if two are there, okay, if two are there, then you need to make a communication. You will make communications with this letter, which is actually what? Which is this? What? Yeah, sure, Dr. Sirisha. Yeah, if you're able to see this communication between these two males and females, then we'll send the letter. So it is what it is, this envelope shaped crystals. This envelope shaped crystals will be useful or will be seen in a case of calcium oxalate dihydrate. So I guess you'll remember, if you're single, you need to lift weights and you need to build your body. That is the calcium oxalate monohydrate. Whereas in a case of calcium oxalate dihydrate, you need to increase the love by sending letters. That is this envelope shaped crystals will be seen in a case of calcium oxalate dihydrate. Okay, then this shapeless, not shameless, it is the shapeless ones, or this rhomboid shapes will be seen in a case of uric acid crystals. Okay, yeah, you can also remember as Mona dumbbell utata hai. Good. Yeah, okay, yeah, fine. Yeah, you can also remember like this. Yeah, going to gym, picking up the dumbbell to lift the Mona to the bed. Okay, just remember. Next, if you're able to see this type of cast, which is normally seen, it is known as what? It is known as hyaline cast. Next, if you're able to see this muddy brown cast, then it is what? It is the acute tubular necrosis. So in a case of acute tubular necrosis, you will be able to see this muddy brown cast. Next, if you're able to see this WBCs, it will be classically seen in a case of any type of nephritis. So any infection. So this is like a vehicle. Okay, as we discussed yesterday, right? What we discussed? We discussed about this SGLTs. Okay, it is like a transporters. So likewise, this cast also is also in transporter. If no one is there, it will go empty. That is what that is, this hyaline cast, which is white in color. Whereas if you are sad or if there is a necrosis, it will take up the excrete or the mud. So it will show this muddy brown cast. Next, if there is any inflammation, we know inflammation, WBC will increase. So in a case of nephritis, there will be this WBC cast. Whereas in a case of nephritic syndrome, okay, or any bleeding things will be there, it will take up the RBC. Okay, it will take up the RBC. Okay, good guys. Yeah. Next, next, if you see, if there is any clear cells are there, if there is any clear cells are there, and there is a features of this mass in the kidney associated with these features of hematuria, okay, this will be suggestive of RCC. This will be typically suggestive of this clear cell RCC. And remember, C for C, it involves this third chromosome. It is a third alphabet. It involves this third chromosome. And next, if you are able to see this type of plant cell appearance, it will be seen in a case of chromophobe RCC. And in the case of chromophobe RCC, we'll use a stain which is known as Hurl's colloidal iron stain. We'll use this Hurl's colloidal iron stain. Yeah, guys. Hurl's colloidal iron stain. And you also see there is one more syndrome which is known as Bird-Hawk-Dewey syndrome. Bird-Hawk-Dewey syndrome will be seen in a case of chromophobe RCC. And as I told you, this clear cell RCC will be having this clear cells, and there will be association with this von Hippel-Lindau syndrome, VHL. In the papillary carcinoma, it will involve this chromosome number 7, and medullary RCC, it will be seen in a case of sickle cell anemia patients. And this RCC will be having a paraneoplastic syndrome, means there will be this interleukin-induced hepatic damage. It is not because of metastasis. This interleukin-6 induced liver dysfunction. It is known as Stopffer syndrome. And if you are able to see this type of central stellate scars of RCC, it is what it is, this oncocytoma. It is oncocytoma. Okay. And now we'll do about the CNS. CNS after we'll do hematology, and mostly we'll be done with it. Okay. That's it, guys. Okay. So just have patience for a few more time. Then after that we'll take a break. Fine. If you see about the CNS tumor, mostly you need to diagnose it. If you see the first one, it is the meningioma. In meningioma, there will be this O-ling will be there. So it is what it is, this our common Samoma bodies. So meningioma, you will see what? You will see this Samoma bodies, and it will be hormonal receptor like progesterone receptor positive. And next you will see this glioblastoma multiforme. And as I told you, this glioblastoma multiforme, it will be involving this both lobes of the brain. Okay, both lobes of the brain will be involved because of the involvement of this corpus callosum. So there is an involvement of this corpus callosum, so it will transfer to this both lobes of the brain. So because of this transfer to this both lobes of the brain, radiologically you will be able to see like a butterfly. You will be able to see like a butterfly tumor, and this is due to the mutation of IDH, isocitrate dehydrogenase mutation. Next, there are two rosettes you need to know: this Homerite pseudo-rosettes and Flexner-Ventestinner rosettes. So remember, in retinoblastoma, the most common sign in a case of retinoblastoma, it is what? The whitish people, which is known as what? Which is known as leukocoria. So the similar way, retinoblastoma rosettes will be having this central white. So it is known as Flexner-Ventestinner rosettes. It is known as Flexner-Ventestinner rosettes, which is seen in a case of retinoblastoma. Whereas pseudo-rosettes will be having this pink in color. Okay, pink in color. Okay, this includes this medulloblastoma, Ewing sarcoma, and neuroblastoma. Medulloblastoma, Ewing sarcoma, and neuroblastoma will be having this Homerite pseudo-rosettes. You can remember this men are the pseudo people, right? They are the very false people. Or else if you are men, then you can remember like you won't live for yourself. You will live for the people in your heart. Obviously in your heart there will be two pink peoples. One is your mother and other one is your girlfriend. So it is what? So men, they are the pseudo people, they are false people. If you are female, remember this. If you are male, remember then that this means they won't live for their life. They will live their pseudo life for their mother and their partner. Just remember these two things. It will be wind your confusion off. Next, you will be able to see this type of bodies or this type of two segregations where there is only in between there is just cell bodies and sides there is this cell nucleus. Okay, this segregations will be seen in a case of classical schwannoma, and you will be able to see one more bodies which are known as verrucate bodies. we will see one more bodies which is known as verrucate bodies in a case of schwannoma. Yeah, good guys. Next, if you're able to see this type of two things, this chicken wire calcification and this type of fried egg appearance, both of them, they are classically seen in a case of oligodendroglioma. They are classically seen in a case of oligodendroglioma. Fine. Next, we are moving ahead to this hematology section. There is this three parts in hematology: anemia, leukemias, and lymphomas. Okay, if you're done with it, almost we are done. Okay, then anemia, we know the most common type of anemia kya hai? It is this iron deficiency anemia or this nutritional anemia. Usually they will describe there is a female with features of fatigue and unable to do walk. Okay, now she's complaints of shortness of breath. Previously she used to climb 4 stairs without doing it, without having any difficulties. Now she's having difficulty on uphill. So you did a peripheral smear examination, you will able to see this type of cells which is known as pencil cells. They will ask you where you will see these pencil cells. Then your answer should be what? Then your answer should be, it is what it is seen in a case of microcytic anemia, especially this iron deficiency anemia. Iron deficiency anemia. बस फिर उसके बाद आगे बढ़ते हैं. There are few more microcytic anemia. One is the sickle cell anemia. The sickle cell anemia happens because of glutamate goes. ठीक है, glutamate goes and valine welcomes. Valine welcomes. ठीक है, glutamate is being replaced by this valine at this beta 6th position. So the RBC will become this shape which is known as sickle shape. So it is the sickle cell anemia. And this sickle shaped RBCs, it won't stay like this. It won't stay like a normal us. It will be like a marriage child. Like if you see in a marriage, right, it means that there will be small childs, they will be roaming around. There will be no reason why they are roaming. Likewise, this sickle cell RBCs, they will just roam around, and when they see these small arteries and small capillaries, they will join and they will occlude the vessel. So it will cause what? It will cause this dactylitis. They will cause inflammation because on the fingers, because it causes obstruction over it. And next, it will go and occlude the spleen. Becerra spleen. Okay, what he did? Nothing, right? So it will go and occlude the blood supply to the spleen, and it can cause autosplenectomy. Okay, बस इतना याद रखो. And at X-ray, you will be able to see there is an appearance which is known as heron appearance and fish mouth vertebra. And usually we know the most common cause of osteomyelitis. हम पढ़ेंगे. It is what it is, this Staph aureus. Whereas in a case of sickle cell anemia, right, it is what it is, this salmonella. It is this salmonella. फिर उसके बाद they will ask you how will you differentiate this iron deficiency anemia from anemia of chronic disease. ठीक है, याद रखो anemia of chronic disease आपके पास सब कुछ है, लेकिन आप सबको बोल रहे हैं मेरे पास कुछ भी नहीं है. ठीक है, जो जैसे होते हैं ना कि like there will be a guy every in their group in their class, एक पूरी रात भर पढ़ती है. ठीक है ना, अगर पूछोगी तो कितना पढ़ा है, then what they will tell, no, मैंने तो कुछ नहीं पढ़ा, बुक भी नहीं छुआ हूँ, like I never touched the book, like, but they will top in the examination. Likewise, this anemia of chronic disease, they have this iron, they don't need any hunger. Okay, they won't need any hunger. So if you see, there is this, they studied, so their serum ferritin, their reserve will be more. Okay, so they don't be having any binding, उनका इच्छा ही नहीं पड़ेगा, मतलब they won't be having this appetite for study more. So their transportin saturated and binding capacity will be decreased. Okay, whereas their hepcidin will be increased because there is some chronic disease is going on. So because of this chronic disease, this hepcidin will be increased. But just remember one thing which is same in the case of iron deficiency anemia and in anemia of chronic disease, both percentage saturation will be decreased. Percentage saturation will be decreased. Okay, क्योंकि इतना गलती करोगे तो means you will get less percentage, like instead of getting 95 you will get 92, right? So that is what, so there will be decrease in percentage. Okay, whereas in a case of iron deficiency anemia, there will be decreased ferritin. So because of that you want to read, so there will be increased transferrin and increased TABC, and there will be a decreased hepcidin. There is no inflammation. तो उसके बाद आगे बढ़ते हैं. Okay, then the master regulator of iron metabolism क्या है? Hepcidin. Then about IDA, it is also associated with the syndrome which is known as Plummer-Vinson syndrome. If there is a features of this koilonychia, there is a features of this esophageal webs, all of them it is related to this Plummer-Vinson syndrome. Next, thalassemia में क्या देखेंगे हम? Target cells देखेंगे. There are two types of thalassemia, alpha, beta. Alpha due to this chromosome 16 deletion, whereas beta it is due to this chromosome 11 mutation. Okay, and in the case of thalassemia, remember it is thalassemia. There is thalassemia. अगर thalassemia है तो क्या है, there will be a less Menzer index, so lesser than 13. So in the case of thalassemia, there will be a less than 13 of Menzer index. Then there will be a thing which is known as paroxysmal nocturnal hematuria. It is because of this absence of CD55, 59. So the same P ka ulta karo, it will be 9. So if you make P in a vice versa, it is the 9. So remember, it is CD 55 and 59. Okay, 55 and 59, and it is due to this defect in this PGA. Okay, and this, if there is loss of this सेंट्रल पेलर, यूजुअली देखो इसके अंदर जो बीच में सेंट्रल पेलर है, अगर इफ देयर इज एनी लॉस ऑफ सेंट्रल पेलर, विल कॉल देम एज क्या, स्पीरोसाइट्स. उसको क्या बुलाएंगे, स्पीरोसाइट्स. या दैट इज, या दैट्स गुड डॉक्टर डयाना. इट इज व्हाट, इट इज दिस MCV by, like that is this Menzer index will divide this MCV by this total RBCs. Yeah, good, that's correct. Then hereditary spirositis, one condition which shows the spirocytes. The most common one, it is this ankyrin, and the most specific one, it is the spectrin. And here there will be increased osmotic fragility. And this spirocytes can also be seen, or the most common cause of the spirocytes kya hai? It is this autoimmune hemolytic anemia. And there are two types of autoimmune hemolytic anemia. One is warm, another one is the cold. Okay? G for garam, G for warm. So IgG will be used in the case of warm, garam wala. Okay? And then this IgG1 will be involved in a case of two conditions, which is this Evans syndrome and CLL. Evans syndrome and CLL will be seen in a case of warm autoimmune hemolytic anemia. So warm matlab garam, garam, garam. So it is IgG. Whereas cold autoimmune hemolytic anemia, it classically involves IgM, and it includes this mycoplasma and malignancy and other infections. Okay, itna yaad rakho. Next, our classical yesterday also we studied, right? This is this vitamin B12 deficiency causing this megaloblastic anemia. Okay, the car organism which is this 𝗪𝗚𝗏𝗏, it can also lead to this decreased absorption of this vitamin B12 and can cause this megaloblastic anemia. Okay, itna yaad rakho. And in a case of megaloblastic anemia, you will able to see this classical hypersegmented. It is not multinucleated, it is this hypersegmented neutrophils. फिर उसके बाद usual से बड़ा वाला, it is known as macroovulocytes, and there will be one more bodies which is known as �ᵗ-Jolly's bodies. �ᵗ-Jolly's bodies. We know vitamin B12, it is helpful in DNA formation. So in a case of vitamin B12 deficiency, there will be a improper DNA formation which is known as �ᵗ-Jolly bodies. और हम diagnose करने के लिए हम क्या क्या देखेंगे? We'll use MMC level and homocysteine levels. Both of them will be increased in a case of vitamin B12 deficiency. फिर उसके बाद आते हैं G6PD deficiency. We know G6PD, it is a part of 𝗏𝗵𝗶𝘀 shunt. ठीक है? And if there is a history of anti-malarial or fava beans consumptions, there will be increased level of, there will be what? There will be this increased level of this free radicals, and it will lead to this type of bodies which is known as Heinz bodies. And on peripheral smear, you will be able to see this type of cells. They are known as what? Bite cells. फिर उसके बाद the two more topics, leukemia and lymphoma. Leukemia means जब तक blood का tumor blood में रहेगा, इसको बोलेंगे leukemia. If the blood tumor, if it is spreading to this vital organs or to the organs, then we'll call them as lymphoma. Okay. First one, it is what? It is all. ठीक है? सबको क्या पसंद है? सबको बच्चा पसंद है. ठीक है? So means like our बच्चा पसंद है और बचपन पसंद है. Okay. So everyone, they like the children's, right? They like the children's. Like, so the most common type of leukemia in children, it is what? It is this ALL. Next, if you're able to see this ALL, they will ask you which of the following is the good prognosis. If you know this good prognosis, you can tell which is worst or this poor prognosis. So the good prognosis, it is what? It is the hyperdiploidy or female and translocation 12-21. So here you will be able to see these are this lymphocytes which is uniform. Okay, which is uniform. Okay, remember. So most common type of leukemia in children क्या ALL. Okay, this ALL. Okay, फिर उसके बाद AML. Okay, AML में there are different types of leukemias. There are different types of classifications. So आपको याद रखना what are the translocations. See AML M2 it is known as what? It is be causing this thing which is known as scleroma, and it will be having this translocation of translocation 8-21. Remember, it is 8 and 21. It is 8 and 21. Whereas M3, which is known as what? PML RARA fusion. PML RARA fusion, which will be having these rods. They are known as what? They are known as OR rods. And what is the name of the cells which is having these OR rods? They are known as Svogod cells. So Fagot cells and R rods will be seen in a case of AML-M3, and it is due to the translocation of 1517 or this PML-RARA fusion. Okay, and in the case of M4, multiple 4 into 4, it is what it is, inversion 16 involved. Okay, so AML, it is this one. So usually in the case of ALL, it will be the children, they will give this history and they will give this peripheral smell. They will ask you which of the following is a good prognosis or identify the diagnosis. Whereas in the case of AML, they will ask you, you will able to see these R rods in this picture in a child who is presenting with features of bone pain and anemia. Okay, and now what is the translocation you will see? So the translocation you will see in the case of AML-M3, it is what it is, translocation 1517, which is this PML-RARA fusion. It is the PML-RARA fusion. फिर इसके बाद आगे बढ़ते हैं. Next one, it is the CLL. CLL mostly it is seen in a case of elderly patients, and remember the CLL will be positive for 5 and 23. CLL will be positive for 5 and 23 positive. And here there will be two features. There will be this massive splenomegaly and along with this lymph node involvement. So how will you differentiate the CLL and CML? It is the lymph node. In the case of CLL, there will be lymph node involvement, whereas in the case of CML, there will be no lymph node involvement. Okay, and there will be this syndrome which is known as Richter syndrome. Richter syndrome, it is what? Yeah, you will see this garden party appearance in a case of CML. Okay, in the case of CML, you will see this garden party appearance. Next, in the case of CLL, what you will do? What you will see, there will be this syndrome which is known as CLL. Sometimes this CLL will become what, very small cells, and in it, then it can transform into DLBCL. It is known as Richter's transformation. And if the CLL, it is being associated with this autoimmune hemolytic anemia, it is known as Evans syndrome. It is known as Evans syndrome. Okay, and we know in the case of CLL, there will be a component which is absent, which is known as what? Which is known as vimentin. Okay, vimentin. So we know this vimentin, it is helpful for the integrity of the cells. Okay, अगर आप एक सेल को लेकर स्लाइड के ऊपर रखोगे, it will be integral like this. लेकिन because of this vimentin, it will be like this. So when you put this cover slip, this cell will be smudged. ठीक है, ये टूट जाएगा. So this टूटे हुआ सेल, इसको बोलते हैं smudge cell. Smudge cell. Okay. Then in CML, you will able to see, I told you will able to see this massive splenomegaly and lymph node will be absent. And here this catch point, which is this T92, translocation 922, which is this BCR-ABL fusion. Okay, Philadelphia chromosome. Okay, and there will be increased all the lineages which causes this garden party appearance. And there is this one more tumor which is happening in the plasma cells, which is this multiple myeloma. Usually there is this old age patient with sclerotic knot. There will be this lytic lesions on the skull and on the vertebra, and there is the features of this anemia. Okay, and there will be features of this crab. Okay, there will be this hypercalcemia, there will be this renal features, and there will be this anemia. And in blood, you will be able to see there is this immunoglobulin deposition leading to this type of cells. There will be this grape cell, there will be this moat cell, okay, moat cell, and intranuclear Dutcher body and intracytoplasmic Russell body. So Dutcher body, Russell body, moat cells, all of this thing will be seen in a case of multiple myeloma. Okay, and multiple myeloma, you will see this translocation 1114. Fair? Okay, then if you are able to see this type of cerebriform cell will be seen in a case of T cell type of non-Hodgkin's lymphoma, which is what? Which is this Sézary syndrome. They are known as Sézary cells, will be seen in a case of Sézary syndrome. Okay, where there you will be able to see this subsets which is known as Munro's microsubsets. Okay, I will ask in dermatology. Okay, Sézary syndrome. A good Dr. Puneet. Iske baad we'll come on to this final part, and there is few extra age left. Okay, in final part we'll see this Hodgkin's lymphoma. Remember, Hodgkin's lymphoma, there are two types: classical and non-classical. Classical means, for example, what is this? What is the classical things seen during FMG preparation? Depression. Okay, depression, demotivation, lot of problems and only problems. Okay, these are the classical features of an FMG aspirants. Okay, there is some atypical patients will be there, right? Like there will be few people will be jolly during FMG preparation, jolly during or happy during these FMG results because they didn't pass. They have 6 more months, and they are what? They are this atypical persons. So if you put our efforts, you'll be into this typical line, and they will come out as pass person. Okay, that is what. So in the case of Hodgkin's lymphoma, it will be classically, it will be positive for the CD15 and CD13. okay, CD15 and CD30, okay, and there are different types. There are nodular sclerosis, mixed cellularity, lymphocytic lich and lymphocytic poor. All of them they will be having this classical of CD15, फिर उसका दो टाइम, it is 15 plus 15, it is CD30. So 15 and 30 will be positive in a case of classical type of RS cell, which is this classical Hodgkin's lymphoma. Okay, here the most specific one, it is the OX5, and non-classical, it is the nodular lymphocytic predominant. Here there will be this CD15 and 30. ठीक है, both of them it will be negative in nature, our atypical guys. Okay, so अगर atypical है तो उनका तो कुछ ना कुछ चाहिए ना, तो they'll be having this they'll be having this biased things like all of enjoyment stuffs like sutta, daru, ठीक है ना, so ganja. So like if they have these atypical things in their life, so it is what it is, the atypical, it is the CD20 and 40. It is not other part of life, if it is having, it is okay, but during preparation you should be oriented. ठीक है ना, तुम्हें लड़ना है तो लड़ने के लिए क्या चाहिए, तुम्हें एनर्जी चाहिए, और तुम्हें क्या चाहिए, उसके लिए जिद चाहिए. तो just keep on fighting for it with this typical features of this depression, problems, everything, but your efforts, your consistent efforts, if you are doing, then you will come out of this FMGE examination. That is my point of view, and that is the thing which actually happens. Okay, so in a case of non classical, I told they will go for even movies. So movies क्या मिलेगा, movies में popcorn मिलेगा. So in a case of non-classical, we will be able to see this popcorn cells. ठीक है. Next, in a case of non-Hodgkin's lymphoma, there are different types. Here you need to know about this translocation. So remember, mantle cell, it will be positive for this vitamin D1. ठीक है. Whereas this follicular, it will be positive for this positive for this BCL2. Okay, so then you want to know about their translocation. तो translocations के लिए याद रखो 11, 14 और 18 means 11, 14 and 18. So first see, first mantle के लिए पहले दो दे देते हैं. ठीक है, you give first two for this mantle, so it is 11, 14. फिर बीच में जो भी बचा, it is what it is 14, FF14, FF follicular. So 14 follicular, it is what it is 14 and 18 will be seen in a case of follicular lymphoma. फिर margin में क्या क्या है, margin में it is 11 and 18. अगर margin में 11 and 18 है तो the marginal lymphoma will be having this translocation of 11, 18. ठीक है, बस इतना याद रखो. And this marginal one, it will be positive, negative for both CD5 and CD23. फिर उसके बाद आते हैं, there will be this African child who is presenting with this lymphadenopathy and this classical 𝗧𝗵𝗶𝗀𝗀. Where you will see this 𝗧𝗵𝗶𝗀𝗀, guys? 𝗧𝗵𝗶𝗀𝗀 appearance in lymph node biopsy. कौन से lymphoma देखोगे? Already I got the answers. It is what it is, this Burkitt's. Yeah, good, Dr. 𝗓𝗵𝗶𝗀𝗀. It is what it is, this Burkitt's lymphoma. Okay, and we know this Burkitt's lymphoma, it will be having this association with this Epstein-Barr virus, and B for B, a B को 8 बना दो. So it is this 8-14 translocation, and there will be this proliferation index which is known as 𝗚𝗏67. It is 100%, and it will be showing this 𝗧𝗵𝗶𝗀𝗀. Whereas this 𝗚𝗏, the 𝗚𝗏 is all the FMGs, whereas the stars are you, like macrophages, who is fighting for your life and fighting for this FMG life. So the stars are these macrophages, whereas this 𝗚𝗏, it is what it is, this tumor cells. Okay, it is the tumor cells. Next, if you are able to see this hairy projections into your cells, it is what it is, this hairy cell leukemia, or हमें पढ़ा है, it is what it is, positive for this BRAF cell, and we know annexin 5 is studied in apoptosis, whereas annexin A1, it will be positive for this hairy cell leukemia. बस these are the main contents you need to remember about this lymphoma. फिर थोड़ा exercise देखते हैं, बस उसके बाद break ले लेते हैं. So if you are able to see this type of dye, okay, triphenyl tetrazolium chloride, you will see to diagnose this MI. Okay, अगर means this will go and bind to this LDH. It will bind to this LDH, because usually हमने पढ़ा कि in a case of cellular injury there will be reversible, irreversible. In a case of reversible cell injury there will be no damage to the cell membrane. लेकिन जब irreversible cell injury होगा तब cell membrane टूटेगा. अगर cell membrane टूटेगा तो उसका content बाहर आएगा. One of the content is what is the enzymes, which is this lactate dehydrogenase LDH. So this dye will go and combine with this LDH, and when they will be combining, they will be cushy. When they will be happy, they will show up the color, that is the white color. Okay, fine. Remember. Okay, good. Okay, fine. Yeah, we'll try to. We'll have a short break, and after that we'll continue it. Don't worry. Okay. Yeah, we'll have a short break in the time. Don't worry. Fine. Next, about this blood test, if you see, there will be In a case of inflammation, there will be the increase in cytochrome C and annexin 5. Cytochrome C and annexin 5. And about this programmed cell death, it is what? It can be caspase dependent and caspase independent. In a case of caspase dependent, we know it is the apoptosis. And if it is caspase dependent but it is having inflammation, it is what? It is this pyroptosis, which is having this C11 involvement. Okay. Whereas in the case of apoptosis, there will be this inflammation will be absent and it will be having this all caspases, caspase 3, 4, 7, 8, 9 and 10. Okay. Caspase 3, 4, 7, 8, 9 and 10. Fine. And about deposits, you want to know, if it is lipofuscin, it is the lipid, it is what? It is a wear and tear pigment, and for staining lipids, we can use this pigment or stain, which is the oil red O. Hemosiderin is the iron containing pigment. We'll use this blue stain, which is this Pearl's Prussian blue. Copper will use two stains, which is the rhodamine and rubionic acid. Calcium will use this two stain, which is this vancomycin and alizarin redness. For melanin, we'll use this mesenphentana, whereas meson trichrome will use for healing or during this granuloma formations. Okay. Then for calcium, we'll see two things. Calcium, there will be dystrophic calcification and metastatic calcification. Remember, dystrophic calcifications happens in dying tissue. So here it happens in dying tissue. The calcium will be normal here. An example of this, it is this our favorite 𝗧𝗵𝗶𝘀 bodies. Okay. Papillary carcinoma thyroid, serous cyst adenoma of ovary and meningioma. Okay. Then metastatic calcification, it is usually seen in a case of normal tissue. Here, why it is deposited into the normal tissue? Because there will be increased calcium, and it is seen in a case of RCC, milk alkali syndrome, and multiple myeloma. So remember, this multiple myeloma, one of the criteria, it is hypercalcemia. Okay. Then uske baad Turner syndrome, there will be this 45XO, and there will be the features of lymphadenoma. Okay, lymphedema, there will be swelling around the neck. Then uske baad Down syndrome. In the case of Down syndrome, there will be this, it happens because of this meiotic non-disjunction. It happens because of this meiotic non-disjunctions. Yeah. If for calcium, we'll use this most common stain, which is this vancomycin stain. And next, about this Robertsonian translocation, it will happen in most old age patients. There will be this Robertsonian translocation. It is the translocation 14 and 21. And the most common type of leukemia in Down syndrome, it's also ALL, and it is more specific if they ask, it is the AML-M7. Okay, more specific it is AML-M7, and most common it is the ALL. Okay, and Klinefelter, the chromosome number is 47XXY. Okay, which will be having this mental retardation, and heart you will be able to see this mitral valve prolapse, and there will be this increased risk of leukemia, and there will be enlargement of breast in males, which is known as gynecomastia, and there will be presence of Barr bodies in males. Okay, remember, and evaluation you will be able to see, because of this there will be decreased testosterone and increased LH and FSH. बस इतना याद रखो. And few trinucleated repeat disorders, Fragile X syndrome, it is the most common one. It is the CGG repeats, whereas Friedreich's ataxia, though A hai, so it is GAA. Myotonic dystrophy, remember it is this CTG. CTG will be seen in a case of myotonic dystrophy. Or Huntington's chorea, agar hunter hai, so he need a cage. Okay, he need a cage. So it is what? It is the CAG repeats. The same for spinocerebellar ataxia. So remember, it is Friedreich's ataxia, it is GAA. Whereas in a case of spinocerebellar ataxia, it is CAG. Okay. Then Kennedy's disease, it is the CAG repeats. Fine. Then about few more receptors. This TLR receptors means T cell receptors, it is toll-like receptors, it is for the bacteria. Lecithin, lecithin is present in the fungal walls, it is for the fungus. Rig-like, it is for this virus. Rig-like, it is for the virus. And node-like receptors, it is for the NFR, and it is for this necrotic cells. And in the case of inflammatory bowel disease like Crohn's disease, it will be having a mutations for this node 2. It will be having this mutation for this node 2. Yeah, good, Dr. Anjali. Next, about this bleeding disorders, just remember, in the case of hemolytic uremic syndrome, there will be hemolysis, uremia, and syndromes. Like, why there is hemolysis? There is this clumping, there is formation of clot, and RBC will be trapped. So this lead to this breakdown of the RBC. So there will be a hemolysis. So because this, there will be formation of clot, there will be what? There will be usage of the platelets leading to thrombocytopenia. and they will come and affect the renal. So it is known as hemolytic uremic syndrome. Because of this, there will be increased uremia levels. Okay, and this Bernard-Soulier syndrome, remember it is GP1B. Bernard-Soulier syndrome पहले आता है, तो GP1B or 9, like it is what? It is the Bernard-Soulier syndrome, whereas GP2B, it is what? It is the Glanzmann thrombasthenia. It is the Glanzmann thrombasthenia. And hemophilia, we studied like it is a X-linked recessive disorders. Hemophilia A, it is 8. B, it is because of the factor 9 deficiency. C, it is because of the 11. So remember, it is 8, 9, not 10, it is the 11. So 8, 10, 11. 8, 10, 11. 8, sorry, it is not 10, it is 8, 9, 11. Okay, then if you see this von Willebrand deficiency, it will lead to this two things. It will lead to this platelet adhesion defect. Along with this, it also decreases the factor 8. It decreases the factor 8. So there will be BT also will be enlarged, means bleeding time will be more, and APTT also will be more. Fine. And there are few immunodeficiency diseases. So there is one thing, it is VAS. VAS means a past. So then you will tell in past, you will tell boy. Okay, so when you see your X, you will tell boy. So it is bi. Okay, so it is what? It is the bleeding, infections, and eczema. So it mostly the child with bleeding, infection, eczema. The next one, it is the Dijart syndrome. Will be having this mnemonic of catch. There will be this cleft lip or cleft palate and cardiac anomalies, abnormal faces. There will be this thymus anomalies, and it will be involving this 22nd chromosome. And SCED, we know it is due to the deficiency of adenosine deaminase. ठीक है. Then the final one, it is this blood bank. अगर आपको blood bank में याद रखना है, so remember PRBC, it will store it as 2 to 6 degrees, and usually it is stored up to a day of 42 days. तो हम लेकिन mostly हम 35 days के लिए रखते हैं. Okay, because we have the availability of this only. Then platelets usually will keep in room temperature and with constant agitation. Okay, and will keep at room temperature of 20 to 25 degree Celsius. तो अगर हम room temperature में रखेंगे तो इसका validity बहुत कम होगा. तो it is what? It is for just 5 days we can keep them. As this fresh frozen plasma and cryoprecipitate, हम उसको deep freeze करेंगे at 18 degree temperature, तो हम 1 साल तक उसको रख सकते हैं. But remember, in question they will ask you, you got a fresh frozen plasma, okay, which is stored for 8 months, okay, stored for 8 months to your patient. Now the patient discharged before telling you. Now you have this thawed fresh frozen plasma, means previously it was freezed. Now what you are having, it is not freezed one, it is being converted into the normal temperature. Now they will ask you, as a intern, what you will do, you will bring back to the blood bank and keep it for 2 more months and use it later, or you will discard it. What will be your answer? You may think that there is 2 to there is 4 more months left, right? But no, once this deep freezed plasma or this cryoprecipitate, if they thawed, means if they brought to the normal temperature, we cannot keep them back. Okay, so if it is thawed, then we need to dispose them for sure. Okay. Yeah, Prader-Willi also, there is the chromosome 15 involvement. There will be this paternal deletion. Okay, just remember. Fine. Yeah, that is there. Yeah, it is the discard. Yeah, guys, you are getting it absolutely correct. Fine. And usually this PRBCs will be stored in, previously it is stored in this ACD, which was for just 21 days. We added this energy particle, which is this adenosine. So now it can withstand for 35 days. We have more improved one where we can store for even 42 days, which is this SAGM, which is having this osmotic maintenance. Okay, that's it, guys. That's it for the pathology part. We'll have a break for 20 minutes. Okay, we'll have a break for 20 minutes. We'll meet up at 12:30. Okay, we'll meet up at 12:30. Okay, and just one thing, if you have the hope and if you have the will to do it, you can do it and you will do it and you will come out with flying colors. Whatever doubts you have, you put in the comment section. We'll take up after the break. Okay, that is my thing. Okay, if any doubts, please let me know. I'll be happy to hear you out. Okay, we'll catch up at 12:30 and after break we'll discuss it. Okay, fine, guys. Hello doctors, welcome back to the microbiology part. Like before attending the sessions, like make sure you are having this PDF, and we have shared this PDF into your groups, into the Dr. 𝗵𝗶𝗀𝗀 channel. So you can make available this PDF, and you can, if you want, you can print and keep it. Okay, mostly whatever the PDF will be shared hereafter, it will be mostly compiled so that you can watch this video and you can annotate it as even. Okay, so again, welcome back to this microbiology part of this Game Changer series, and this is again your Dr. 𝗧𝗵𝗶𝗀. Fine. With this, we'll move on to the microbiology part, and about the break part, we'll have a discussion. So we have some studios timings and things. So whoever need a break in between, just have a small break and come, and you watch the leftover part once at the session ends. Okay, that will be the help from my end that we can do. Okay, don't worry, but stay motivated, stay calm, that you can do it, and have things and have good things in your prayer and pray for it. You will get it sure. Okay, that is the main thing. And if you face any technical issues, please let me know. We'll start up with it. Fine. I guess there is no any technical issue. Like I couldn't see any comments. I will catch up, or we'll start up with the thing. Okay, fine. First, we'll start with the microbiology. If you see about this microbiology part, there are few things you need to know. Like first, the most important one in microbiology, it is what it is, the mycology part. Okay, if you don't know anything, just study microbiology and go. If you want to score good marks, you read this PDF and go. Okay, so in this PDF, we'll be having this in sequential arrangements. There will be this general microbiology, followed by this bacteriology and our important microbiology, and followed by this few images and few things about this parasitology. Okay, and the expected time for this session, it is what it is, 1 hour 45 minutes or 1 hour 30 to 1 hour 45 minutes. That is the expected time that we should complete it, and this will help your revision. And during attempting your GTs or before giving your GTs or subjective test, make sure you are reading this PDF, because most of your questions will be from this PDF, and there will be few extra questions as well that you can use your main notes to solve them up. Okay, we'll start. Yeah, good Dr. Anjali, good Dr. Shanvas, yeah, good Dr. The Creations. Fine. We'll start with the first. If you see, there are different methods of sterilization. In the previous examination, the previous FMGE examination, they asked you this instrument. It is the plasma sterilization. How they asked is that what is the component you will use for this plasma sterilization? Okay, the answer was what? Hydrogen peroxide. So hydrogen peroxide. Hydrogen peroxide, right? And next, there are few more instruments which is used for this sterilization. So first, it is what it is, this hot air oven. Next one, it is this autoclave. So what is the main difference? Both of them, they will heat and do sterilization. Whereas this autoclave, what it will do, it will be sterilizing under the pressure, and it will be using the stream. Okay, it will be the wet type of sterilizations. So this dry heat sterilization, also known as hot air oven, it is mostly done under this 160 degrees Celsius for 2 hours. Okay, and what are the materials will we use? Usually our glasswares like petri dishes, our usual surgical instruments, liquid paraffins, and others. Okay, so all of these glasswares and the surgical instruments, liquid paraffin, all of them, it will be sterilized by this hot air oven. And if you see, if you do sterilization itself, then you should have control, right, whether you did it correct or not. So for this control, we'll use this Clostridium tetanispos and Bacillus subtilis. So we'll keep around this. For example, you are keeping this instrument inside. I will be having a tape. I'll put them here, and I will keep inside this hot air oven. So once it exposed to this 160 Celsius for 2 hours, then what will happen is that this color of the tape, it will change. Color of the tape, it will be changing. Okay, just excuse me. So the color of the tape, it will be changing. Sorry. Next, if you see about few more methods, like for example, pasteurization. Okay, the pasteurization, usually what we'll do for the milk. There are two methods of pasteurization, where you will hold for longer time. Where you will hold for longer time, it is known as Holder's method. So it is done at 63 degrees Celsius for 30 minutes. अगर आपने flash एकदम से, देखिए, if you did for just 20 seconds for 72 degrees Celsius, and you are exposing them into the cold. Okay, you are exposing them into the cold, or you are cooling it to 13 degrees Celsius. So we were like cooling like a flash, like for 20 seconds, and you were rapidly cooling into 13 degrees Celsius. So it is what? It is this flash method. Okay, it is the flash method. Next, about few more methods, which is this inspissation and tyndallization. Inspissation, it is done at 80 to 85 degrees Celsius. In speciation, it is done at 80 to 85 degrees Celsius. And remember, it is done for 30 minutes for 3 consecutive days. For example, you did on Tuesday at 2 p.m. for 30 minutes, and next tomorrow you do at Wednesday 30 minutes at 2 p.m. for the same for 30 minutes. So the same you will do for one more time. So it is the inspissation. Whereas tyndalization it is the 100 degree, ठीक है, 100 डिग्री सेल्सियस पर 20 मिनट और 3 दिन के लिए. So 100 degree Celsius for 20 minutes and for 3 days. Fine. And next one is with the moist heat. So all of them, like if you see this dry heat, it is what? It is this hot air one. Or this moist heat, which means the stream. Like you will heat up the water. How is your idli is making, right? You will stream it. Your momos, how it is making, right? Likewise, the same will be in autoclave. Okay, the same will be in autoclave. Like there will be water and there will be streams. The stream will come and start sterilize. And usually this streams, there will be under pressure. Okay, there will be under pressure like you during the examination one. So it will be done at a temperature of 121 degrees Celsius for 15 minutes. Remember, it is for 15 minutes and 15 psi. 121, 15 minutes, 15 psi. Whereas this dry heat 160 degrees Celsius for 2 hours. Pasteurization, it is hold it for longer. So 63 degrees Celsius for 30 minutes. Flash method 72 degrees Celsius for 20 seconds, followed by cooling into 13 degrees Celsius. So this is the thing. Whereas if you use this moist heat like autoclave, this is like pressure cooker. Okay, if you use this autoclave, mostly it will kill all of the organisms. But to kill this prions, which is most smallest and antigenic particle, there you need to expose them for 134 degrees Celsius for 1 to 1.5 hours. Remember, it is 1 to 1.5 hours for killing of prions. Remember, बस इतना याद रखो. ठीक है, so dry heat, then pasteurization, then tyndalization, inspissation, followed by this moist heat, which is this autoclaving, and this one, which is this plasma sterilization. Plasma sterilization uses this plasma, and this plasma will be generated from this hydrogen peroxide. बस इतना याद रखो. Then we use some controls, like I told you, right? We need to check them. So we use them controls, like for example, for autoclave, we'll use this bacillus, which is known as 𝗬𝗵𝗶𝗀𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃𝗏𝗃 फिर हॉट एयर हेवन के लिए हम यूज करेंगे द क्लोस्ट्रिडियम टोटनी एंड बेसिलस सबटिलिस, क्लोस्ट्रिडियम टोटनी एंड बेसिलस सबटिलिस यूज करेंगे. फिर उसके बाद फॉर आयनाइजिंग रेडिएशन, सो देयर विल बी फ्यू थिंग्स लाइक फॉर एग्जांपल इफ यू सी द सिंगल यूसेज syringe, okay, you cannot put them into very hot, right? They are made up of plastics, they will become weak. So in such conditions we'll use this ionizing radiations like X-rays and gamma rays. So in such cases what we'll do, we'll use a control which is this radiation. Remember, it is a radiation, so make this R and cut this one, it is the P, so it is the 𝗵𝗵𝗀𝗀, okay, Bacillus 𝗵𝗵𝗀𝗀. Next one, this is the ethylene oxide. So somewhere you use this, for example you are sterilizing the OT or a big instrument, there you will use this ethylene oxide. So there you will use what? There you will use this ethylene oxide. So gas, these are ethylene oxide, it is a gas. अगर आप gas को use कर रहे हो, so it is what the control you will use, it is the Bacillus 𝗵𝗶𝗀𝗀𝗃, Bacillus 𝗵𝗶𝗃𝗃 and Bacillus subtilis, Bacillus 𝗵𝗶𝗃𝗃 and Bacillus subtilis. Fine. And can anyone tell me what is the temperature you will use in a case of usual autoclave? What is the temperature you will use? It is what? It is the 121 degrees Celsius for how many minutes? It is for 15 minutes. Under how many psi? It is for 15 minutes and 15 psi. Yeah, good Dr. Aishi. No, it is for prions will use 134. Yeah, good Dr. Shanwas Khan. Good Dr. Diana. Yeah, it is good. Yeah, fine. Okay, Aishi, that does like, sorry, don't get confused. Okay, for prions will use 134. Okay, it is in certain situations, whereas usually we'll do at 121 degrees Celsius for 15 minutes under pressure, which is this 15 psi. ठीक है, इतना याद रखो. फिर उसके बाद आगे बढ़ते हैं. There are few methods of this bacterial transference of this resistance. कैसे ट्रांसफर होता है? एक for something it will take from its own. So if it is taking from its own, okay, so it is known as transformation from the environment. If it is taking by own, it is known as transformation. Or if you are using a vector, it is delivering something. Okay, you are using blink kit and 𝗧𝗵𝗶𝗀. So if you are using it and delivering, so using this bacteriophage, okay, It is what it is, transduction. It is known as transduction. Next, if you are using this 𝗃𝗁, then then it is the conjugation. If you are using the 𝗃𝗁, it is this conjugation. Next, if you are using this electrical shock, इसको बोलते हैं transfection. Okay, transfection. So इतना याद रखो. Transformation, it will take up from this environment. Transduction, remember this duction, it is the most important point. It is the usage of this bacteriophage. It is used by this bacteriophage. Then conjugation, you will use this conjugation 𝗃𝗁. Okay, using this conjugation 𝗃𝗁. So remember this, all of the methods. फिर उसके बाद आगे बढ़ते हैं bacterial growth curve. Usually, like bacterial growth curve, it is also like us. Usually, we don't know any content. Then what we'll do? We'll start increasing. Okay, we'll start multiplying. We'll start purchasing the notes. ठीक है, पहले हम क्या करेंगे? Notes का count बढ़ाएंगे. ठीक है, notes का count. अभी तक हमने पढ़ाई नहीं किया. ठीक है, just initially it will be resting, which is known as what? Lag phase. Lag phase में हम कुछ नहीं कर रहे हैं, हम बस मजा ले रहे हैं. फिर उसके बाद then this is the log phase. So lag है. फिर उसके बाद क्या हुआ? Log हुआ. फिर उसके बाद stationary. फिर उसके बाद decline. ठीक है, तो देखो, so in initial phase, the lag phase, you are not studying. Okay, you don't have a notes itself. But at some point you thought like, okay, I need to study now. Then what you do? You start collecting the notes. So here, if you see, there is an increase in number of living bacteria, which is seen in a case of log phase. फिर उसके बाद जैसे आपने notes count किया, फिर उसके बाद क्या करना? आपको पढ़ना चाहिए. तो when you start reading, you will be flat. क्योंकि पढ़ेगा भूलेगा, you will read this thing, but you will tend to forget. You will read, it will tend to forget. So likewise, it will be a stationary phase. So, but you know, with this reading and forgetting, likewise only you will clear your examination. Okay, you will clear your examination. Okay, you will clear your examination. फिर उसके बाद हमें क्या करना? हमें भूल जाना. So there are three phases: lag phase, log phase, stationary phase, and this phase of decline. So initially there will be no increase in number. Then followed by this, there is a log phase where there is an increase in number. Okay, then stationary phase, there will be a stagnant of this number because there will be living bacilli, and this dying bacilli, it will become at a normal level. And one phenomena which takes place at this stationary phase, it is what? It is this spore formation and antibiotic synthesis. Antibiotic synthesis happens in this stationary phase, and following which there is this death of this most of the bacilli because they will become toxic and it will be died. So it is known as what? Phase of decline. So you will read, you will forget, you will remember, and you will forget. That's it. Okay, and you will pass the examination. Next, about this culture media, like if you can just write this culture media into your sticky notes and stick to your wall or stick to your library table. That will be more helpful than anything else in the world. Okay, fine. If you see this first one, it is Mycobacterium tuberculosis. We know Mycobacterium tuberculosis will use this media which is known as LG media, and recently we'll use some more advanced media which is known as what? Bactec media. They are rapid medias, like like it will give your reports within few hours. Okay, few hours instead of days. Next one, if you see this Staph aureus, the media which is used for this Staph aureus, it is the mannitol salt agar. So MSA. So it is this mannitol salt agar for this SA, which is Staph aureus. Okay, then the Streptococcus pyogenes, it will use this blood agar, because हमें पता है कि Streptococcus pyogenes क्या है? It is a group A beta hemolytic Streptococcus. अगर beta hemolytic है, if it can break a blood, then which media will give them? Will give them the blood media. So we'll use them crystal violet blood agar. Then if you want to transport this pyogenes, we'll use this medium which is known as Pike's media. A good doctor actually, a good Dr. 𝗏𝗏𝗏𝗏. Then if you see about this next bacteria, which is this Neisseria meningitidis. So Neisseria meningitidis will use this medium which is known as Sayre-Martin medium. And for Corynebacterium, like Corynebacterium diphtheriae, okay, we need to do two things. Corynebacterium diphtheria patients, it will be presenting with this pseudomembrane bull neck, and you need to do two things. You need to make a clinical diagnosis, followed by which you need to make a rapid diagnosis, and you need to make a confirmed diagnosis. To make any rapid diagnosis, like a water, it should flow. So to use in a case of rapid diagnosis, we'll use watery medium. Okay, that is this low plus serum slope, which is used for this early diagnosis. Whereas to confirm the diagnosis, we'll use this potassium telluride agar. So remember, Corynebacterium diphtheriae, low plus serum slope and potassium telluride agar. Low plus serum slope and potassium telluride agar. Staph aureus, SA. So MSA, mannitol salt agar. Streptococcus pyogenes, it breaks the blood. So it is what it is this blood agar, which is this crystal violet blood agar. Okay, Neisseria meningitis, it is what Thayer-Martin medium. Thayer-Martin medium. And for Bacillus cereus, you just remember two mnemonic, which is 𝗵𝗵𝗶𝗵. 𝗵𝗵𝗶𝗵. So these are the two media which is used for this Bacillus cereus. Next, Clostridium. Remember, Clostridium, C for C, it is used for 𝗚𝗵𝗶. Okay, cefoxitin, cycloserine, fructose agar. Okay, that is Clostridium one. Clostridium, it is 𝗚𝗵𝗶. Next, Bacillus anthrax. Bacillus anthrax, it is a plate. Okay, I'll tell you one mnemonic for it also. It is the Bacillus anthrax, it is the plate. Remember, it is a plate. So Bacillus anthrax, it is the plate medium we'll use. Then Shigella. Shigella will use Shigella and Salmonella agar, DCA and XLD. So all of this agar will use for Shigella. For Salmonella, we'll use this Wilson and Blair medium. Okay, Wilson and Blair medium. Okay, then about influenza. Okay, we'll use this Fields agar with Leventhal medium. And for Vibrio cholera will use this TCBS medium. And as for the transport of this Vibrio cholera stools, we'll use this medium which is known as VR medium, also known as Carey-Blair medium. Yeah, good Dr. Aishi. Okay, good Dr. Ansh. Then Bordetella. So for Bordetella, we'll use this same B for B, Bord. Okay, we'll use this Bordetella medium. Okay, Bordetella medium. Next, for Pseudomonas, we'll use this Cetrimide agar, where it will show out pigments. Then for brucellosis, we'll use this Castaneda medium. Okay, Castaneda medium, it is like this. It will be having both components. It will be liquid and it will be having the solid. So it is this Brucella. It is the Brucella medium, which is this Castaneda medium. Then for Campylobacter, we'll use this agar, which is known as Scirrhous agar. For Leptospira, it is this FMGE medium. So can anyone tell me what is the name of the disease which is being caused by this Leptospira? It is also known as Weil's disease, which is what? Which is the leptospirosis. Yeah, guys, it is the leptospirosis, also known as Weil's disease, which is spread due to the rat urine during the flood. Yeah, good, Dr. Diana, Dr. Anjali, Dr. Manch. Okay, really well. Okay, well played. Fine. Then if you see next, this is what? This is this Legionella pneumonia. So remember Legionella. So Legionella, it causes this atypical pneumonia like diarrhea along with this pneumonia. So we'll use this Bice medium. Okay, it will use this Bice. We'll use this Bice medium. Remember. And what are the Bogdorferi will use this BSK medium. Yeah, it produces this atypical pneumonia. Next, Leishmania will use this triple N media. Okay, we know this Leishmania don't have any. It causes what? Leishmania don't have any, causes Kala Azar. Okay, remember. Next, about this few antigens and few tests. If you see the first one, it is known as super antigens. Usually, the T cell, it will get info from this MHC2. Like there are, like we know, like if it is CD4 type of T cells, it will get from this MHC2. If it is CD8, then it will be get from this MHC1. Okay, so we know this mnemonic. At end, it should be 8. So if it is 4 into 2, it should be 8. 8 into 1, it should be 8. Okay, so it is what it is usually. So MHC2 type of antigen presenting cells, वो क्या करेगा? It will present this antigen ले लो करके it will give to this T cell. Whereas in some special situations, it won't give just this antigen. Okay, whereas before binding to this antigen, this super antigen वो gap को fill करेगा. ठीक है? Okay, it will fill up this gap. ठीक है? So it will fill up this gap. So it is what it is, the super antigen. Means without even presenting to the antigen, the body will start reacting. Okay, it is known as what? It is known as super antigen. So which of the following means diseases will be having this super antigens? The usual route क्या है? मतलब usual route, it is giving this from MHC to here. But whereas there is small component which is coming in between and stimulating the cell. So it is what it is, the super antigen. So this will be seen in a case of toxic shock syndrome, in a case of Staph aureus. Toxic shock syndrome in the case of Staph aureus. Then streptococcal pyogenic means pyrogen. I told you, it means pyrogen means the fever causing exotoxin. It is by the Streptococcus pyogenes. Then CMV and EBV also causes the super antigen, and the fungus Malassezia furfur, it also has this one. And Streptococcus pyogenes, which is having one more toxin, which is what? Which is erythrogenic toxin. It is also a super antigen. Yeah, good Dr. Anjali, good Dr. Shanavas, yeah, same, yeah. So just remember the main one, it is this toxic shock syndrome, okay, and another one is this pyrogen exotoxin and malassezia fever, CMV and EBV, okay. Then about a few heterotropic antigen tests. For example, what is heterotropic antigen test? Okay, heterotropic antigen means there is antigen mismatch. Okay, there is antigen mismatch. Okay, so instead of recognizing as this antigen, like it is recognized as this antigen. So for example, instead of it is used for diagnosis of X disease, but this X disease antigen, it is looks similar to this disease of X dash. So this same antigen can be used for the diagnosis of this X dash disease. So we don't need to synthesize new antibodies for it. So that's why it is this a heterophilic antigen. The antigens are a bit different, but the antibodies thinks it is same. So it will synthesize same type of antibodies. So one of them, it is what it is, this 𝗵𝗵𝗀𝗀 reaction. So remember this 𝗵𝗵𝗀𝗀𝗀 reaction. It is for diagnosis of this rickettsial infection. So remember, it is 𝗵 for rickets, 𝗵𝗵𝗀𝗀𝗀𝗀 reaction for this rickettsial infection. Then Paul Bunel. Remember, Paul is a mono guy, a single guy. So remember, Paul Bunel test is used for this infectious mononucleosis, also known as kya? What is the other name of infectious mononucleosis? Yeah, guys, it is what it is known as Cushing's disease, and we know this infectious mononucleosis, it will caused by this Epstein-Barr virus. Yeah, good Dr. Anjali. Fine. Next, if you see this cold agglutination test, a few tests you need to know. Cat, mat, sat. Okay, cat, mat, sat. Cat, sat on mat. Okay, so remember it is cat, sat on mat. Okay, fine. Okay, see, then there are few tests like neutralization test and agglutination reaction. So neutralization test means like to neutralize its antigens, we'll use this test which is known as 𝗔 test. Like for example, if the child is susceptible to diphtheria or not, okay, whether the child is susceptible to diphtheria or not. So in such cases, we'll do a test which is known as 𝗔 test. If that 𝗔 test becomes positive, then the child is susceptible to the diphtheria. Okay, if the child is susceptible to the diphtheria, then we should vaccinate them. Okay, then if you see this Naegler's reaction, then it is what? Naegler's reaction, it is seen in a case of Clostridium perfringens. I will show this Naegler's reaction soon. Then about this agglutination antigen means here the antigen plus antibody, they will make a complex. Okay, this includes our Widal test which we use for our typhoid fever. Then see CAT, which is this cold agglutination test which is used for this mycoplasma. Okay, we already saw, right, where in a case of autoimmune hemolytic anemia, there are two hemolytic anemia, garam wala, warm wala, which is IgG wala, okay, which is seen in a case of CLL, whereas in a case of Thanda wala, which is cold autoimmune hemolytic anemia. Okay, remember it is the same cold. So remember it is what? C cold agglutination test, it is the mycoplasma, the same. Okay, then about the standard agglutination test, it will be done in a case of Brucella. So Brucella, that is the standard agglutination test. Can anyone tell me what is the name of the media we'll use for brucellosis? Yeah, guys, tell. Yeah, what is the name of the media we will use for this Brucella? Answer? See guys, for brucellosis, I told you, for Brucella we'll use this medium which is known as Castaneda medium. Which is known as what? Which is known as Castaneda medium. So likewise, they will ask you in the questions, very random questions they will ask in the examination. So make sure you are remembering it. Fine. Next for this microscopic agglutination test will be seen in a case of leptospira, and we know leptospira, it is what? It is the Wales disease. And what is the media we'll use for this leptospirosis? See, the media we'll use for this leptospirosis, it is this FMGE media. It is this FMGE media. A good Dr. Shanavas Khan will use this FMGE media. Fine. A good Dr. Aishi and Shanavas. Fine. Then we'll move on to this final part, which is this bacterial toxins. There will be around one question in each alternate exams, or even one questions in each NEET PG or FMG examinations. Fine. If you see the first one, it is what? It is this elongation factor. It is the elongation factor 2, which is a protein synthesis inhibitor. Remember, it is elongation factor 2. So whatever the disease or whatever the organisms, unke naam pe ye 2 hoga. Okay, there will be this names contained into this organism which causes this protein synthesis inhibition. This include first one, ठीक है, diphtheria. Dip का मतलब कितना है, dip का मतलब die, so it is die, so it inhibits elongation factor 2. Pseudomonas, so it is pseudomonas, do matlab it is 2, so 2 pseudomonas and diphtheria, it will inhibit this elongation factor 2. फिर उसके बाद आते हैं 60S. Remember this 60S ribosome, S for S, it will be seen in a case of Shigella, and the Shigella like introcates this 𝗏𝗏𝗏𝗏. 𝗏𝗏𝗏𝗏 also will be having this type of protein synthesis incubation. So Shigella and 𝗏𝗏𝗏𝗏 will be having incubations to this by 60S ribosomal protein incubation. फिर उसके बाद आता है neurotoxins. There are 2 neurotoxins you want to remember of. One is this Clostridium tetani and Clostridium botulism. Okay, you know this Clostridium tetani will incubate the release of GABA glycine. Yeah, good Dr. Anjali, good Dr. Aishi, like ever correct. If you see this neurotoxins, the Clostridium tetani, it will incubate this gamma and glycine, whereas this Clostridium botulism, it causes this incubate the release of acetylcholine. We know this GABA and glycine, they are this inhibitory neurotransmitters. That's why this neurotoxins in tetani, they will be having this lot of spasms, whereas in the case of Clostridium botulism, the child will be very much flaccid in nature. So what it will be, because there will be no contraction, because there will be no acetylcholine release. Fine. Remember. Next about this CAMP inducers. Remember this CAMP as a mnemonic. So C for cholera, A for anthrax, C for cholera, A for anthrax, and remember this split or make this M into E. So it is what? It is the ETEC. Next one, this for P, it is the pertussis. So it is the pertussis. Yeah. In the case of botulinism, it will cause this flaccid paralysis, whereas tetanus causes this spastic palsy. Okay, remember. And next about this cytokines. Okay, cytotoxins, it includes this Staph aureus and Clostridium perfringens. Okay, mostly they won't ask about this cytotoxins, whereas they will ask you about this CAMP one, about this EF2 one. These are the most important one in this most important ones. Fine. Next, we'll look at just a minute, guys. Do you have any doubt in it? Do you have any doubts, guys? Am I going very much fast? Answer the chat section. Am I going much fast? Or is it a doable pace? Yeah, okay, perfect. Okay, good Dr. Anjali, good Dr. Ambika. Yeah, I guess I'm going fine. Like microbiology, it will be bit raw. Like today, the 3 subjects like pathology, it will be bit conceptual, whereas microbiology and pharmacology, it will be bit raw on initial aspects. But once you read for multiple times, you will get through it, because there will be more marks from this aspect. If you see pathology, there will be 15 to 18 questions will be there. 15 to 18 will be there. The same for micro, and pharma, it is more than that. So if you read these 3 subjects, you will be more than 50 marks ahead of anyone in this race. Okay, that's it. Yeah, good Dr. Harsh. Like good to hear Dr. Shanvaska. Yeah, good Dr. Ambika, good Dr. Anjali. Fine. With this understanding, we'll move on to the next part. Okay. First, we need to differentiate this Staphylococcus aureus from this rest. Yeah, Parul, like it will be feel like that only. Like microbiology, pharmacology, pathology, you will always have these confusions whether you studied this thing or not. Okay, make sure you are revising your own notes on daily basis, and make sure you are reading this PDF. Like once you are done with this one, it is just hardly 13 pages of microbiology and around, I guess, 17 to 18 pages of pathology. If you read them, like it will give you a boost up, like yeah, I do remember something, I do able to connect these things. Just take them as your short notes, because during at the end and peak of your preparation, you cannot read the bulky notes. So make sure you are taking printout of it and keeping it with you, and keep on adding stuffs to it. Okay, that is the best way to improvise your course. Okay, yeah, we'll move ahead with this first part, which is this Staphylococcus and Streptococcus. If you see about this Staphylococcus, like the Staphylococcus, it will be positive for this both catalase and coagulase. The Staphylococcus will be positive for this both catalase and coagulase positive, and we know it is a normal flora in the nose. Okay, he asked in the recent examination which of the following is the normal flora. It is one of the Staphylococcus which they have been asked. Okay, and we know if there is any, if it is normal flora and whatever the infection around the skin, okay, it is the most common cause. So it is the most common cause for skin and soft tissue infections, and it is also the most common cause for this acute endocarditis and acute osteomyelitis. Acute endocarditis and acute osteomyelitis. And what are the virulence factor? Like how, with which it will cause disease? It includes this protein A and this leukocidin. Protein A and leukocidin. Protein A and leukocidin. Just remember this two virulence factor for sure. Then if you are able to see, they will give this image and they will ask you whether this organism is gram positive or gram negative. What will be your answer? Whether this organism is gram positive or gram negative. Yeah, it is the organism, it is what it is, blue in color. Okay, it is blue in color or around this purple in color. So it is what it is, gram positive in nature. It is gram positive. It is gram positive. Okay, and if it is in this type of grapes cluster, so it is what it is, this Staphylococcus. Yeah, good, Dr. Diana. Okay, then I told you what is the agar which used for this Staphylococcus? SA, remember us, MSA. So it is what is this, mannitol. Staphylococcus, remember us, MSA. It is the mannitol salt agar. Yeah, good, Dr. Ambika, good, Dr. Parul. So it is what it is, this mannitol salt agar. Fine. Then फिर उसके बाद आगे बढ़ते. There are few toxins which are being released from the Staphylococcus aureus. This include this enterotoxin causing this food poisoning, toxic shock syndrome, and Staphylococcus scalded skin syndrome. Staphylococcal scalded skin syndrome, which is caused by this exfoliative toxin or epidermolytic toxin. So these are the toxins. This include food poisoning toxin, toxic shock syndrome toxin, and staphylococcal scalded skin syndrome toxin, and this exfoliative or epidermolytic toxin. Fine. And diagnosis, I told you, we'll use this mannitol salt agar, where it will produce this golden yellow colonies. So we told it is aureus. Aureus means gold. So it produces this golden yellow colonies. And the selective media is what? It is mannitol salt agar. Okay. And if there is any resistance to this, it is due to the resistance over this change in the gene, which is this 𝗵𝗶𝗀 gene. It is due to the change in the 𝗵𝗶𝗀 gene. Yeah, good, Dr. Anjali. It is the 𝗵𝗶𝗀 gene. Right. Next, about this Streptococcus pneumoniae. If you see this Streptococcus pneumoniae, it occurs in pairs. It is known as what? It is known as diplococci. Okay, you can see, right? 1, 2, 1, 2, 1, 2. So it is occurs in a diplococci, and remember, it is what it is, capsulated. It is capsulated. It is diplococci and it is capsulated. And we know this name is itself, it is Streptococcus pneumonia. What it will cause? Obviously, it will cause lobar pneumonia, and it is the most common cause of meningitis and for this otitis media as well. And on cultivation, it will produce this 𝗃𝗻 coin colonies. It produces this 𝗃𝗻 coin colonies on blood agar. And then we need to split them, this Streptococcus, into different parts. This Streptococcus pneumoniae will come under this alpha hemolytic Streptococcus. It will come under this alpha hemolytic. Whereas this, there are two beta hemolytics. One is this Streptococcus pyogenes and another one is this Streptococcus agalactiae. Okay, yeah, good, Dr. Anjali. One is this Streptococcus pyogenes and another one is Streptococcus agalactiae. So, but how will you differentiate? We'll differentiate based on their group. We'll differentiate as group A beta hemolytic and group B hemolytic. So, group A beta hemolytic Streptococcus, it is what it is, this Streptococcus pyogenes. It is Streptococcus pyogenes, and how will you group? It is based on this sensitivity, which is known as what? Bacitracin. So bacitracin sensitivity, you will separate them into group A and group B. Okay, and they will be test positive for a test which is known as PYR positive. And what are the tests which is being caused, or the disease which is being caused by the Streptococcus pneumoniae, Streptococcus pyogenes? It is what it is, this erythrogenic toxins which causes this pharyngitis, skin and soft tissue infections. And we know it causes one fatal disease. It is what is this acute rheumatic fever, and in long run it can cause this PSGN. So there will be a history of, there is a child who has had a sore throat 14 days back. Now he is presenting with features of some murmur, which is due to this mitral regurgitation. So what will be the diagnosis? It is what? It is this acute rheumatic heart disease. Okay, previously it should be acute rheumatic fever followed by this acute rheumatic heart disease. And if there is any cola color urine in a case of child with a history of 14 days previous infection, so it is what it is, this post streptococcal glomerulonephritis. So it is Streptococcus pyogenes which causes pharyngitis, which is leading to this rheumatic fever, rheumatic heart disease, and post streptococcal glomerulonephritis. Okay, and as I told you, it is a beta hemolytics. So what we'll use? We'll use this crystal violet blood agar as a selective media. as a selective media. Okay, and for transporting this, we'll use this media which is known as what? Which is known as spikes media. Okay, so we'll use for diagnosis, we'll use this crystal violet blood agar, and for transporting we'll use spikes media. And we know, is this gram positive organism or gram negative organism? It is in purple color. It is in purple color. So it is what? It is purple peoples. They are what? They are positive peoples. So gram positive. So it is purple in color. फिर आगे बढ़ते हैं. Next we'll move on to this disease, which is what? Which is this? Yeah, good Dr. Diana, good Dr. Anjali, good Dr. Parul. Yeah. Then we'll move on to this next disease, which is this Bacillus anthrax. This Bacillus anthrax patients, they will be having this two typical history. Either there will be formation of this 𝗧𝗵𝗶𝗀. Along with this history, either they will be exposed to animals, okay, or they will be exposed to the wolves. Okay, they will be exposed to this wolves, which is this pulmonary anthrax. Okay, and it is what? It is this gram positive, and it is a spore forming organism, and it is having the central spore which looks like a bamboo stick. Okay, remember, it looks like a bamboo stick. So remember, just recently the Halloween went, right? So remember, there is a child who want to dress like a witch. Okay, it is WITCH, witch. Okay, so witch, obviously witch means it is a old age female, right? So she'll be having this clumsy hair. She'll be having what? She'll be having the clumsy hair. She'll be having the clumsy hair which is looking like a Medusa head, means like a snake's head. So she'll be having what? She'll be having a Medusa head, and followed by which she is old age, as I told you, she needs some sticks for the support. Okay, so she needs some stick which is this bamboo sticks, and if you see she is witch, she need to tell some mantras. Okay, mantras. So she will tell some mantras by this beads. So she'll be having this string of beads or string of pearls. Okay, and as it is a small child just dressed for this, she'll be having its long gown. Okay, it's like a tree, like a tree. So it will be showing this inverted fir tree appearance, inverted fir tree appearance. And obviously she is doing for this fun and chocolates, right? Where she will collect the chocolates, she'll be having a plates. She'll be having a plate to collect it. So the media which we use, it is this blood media. Okay, remember? So she'll be having this Medusa head. So Medusa head colonies, and she will be able to see this appearance which is known as inverted fir tree appearance, also known as Christmas tree appearance, which is on this gelatin stab, and on penicillin agar, she will be able to see the string of pearls appearance, string of pearls which she is holding, and then this selective media will use with the plate media to collect the chocolates. Should be having a plate or cup, right? So it is what it is, this plate media. फिर उसके बाद then there will be this central pores which is looking like a bamboo stick. Okay, and there are two anthrax, as I told you. There is this cutaneous anthrax and pulmonary anthrax. Cutaneous anthrax, they will tell this is this hide porter. So there is this worker who is carrying this hides of these organisms, or carrying this organism on the shoulder, and now presents with this 𝗧𝗵𝗶𝗀. So it is what it is, cutaneous anthrax. Whereas pulmonary anthrax, this wool charter, means they are working in this wool industry and having this pulmonary like pneumonia features. It is what it is, this pulmonary anthrax. Yeah, good Dr. Naresh, good Dr. Parul, and good Dr. Aishi. Good, well done. Okay, fine. Next, if you see, if there is any toxin generated, we will use this drug which is known as 𝗧𝗵𝗶𝗀, which is used to neutralize this anthrax toxin. Good Dr. Aishi, good Dr. Anjali. Fine. Next, if you see about this listeria, remember listeria, it will be using this L and T. Remember, it shows this tumbling motility. Tumbling motility will be seen in a case of listeria. Okay, then what is this tumbling motility? Means it will be motile at 25 degrees Celsius, whereas it became non-motile at 37 degrees Celsius. They will give this and they will ask you at which temperature this listeria will show this tumbling motility. It is what it is, 25 degrees Celsius. And what is the thing? What is the agar you will use for this? You will use this 𝗏𝗏𝗀 agar. You will use this 𝗏𝗏𝗀 agar. Okay. Then about this gram-negative infections. Okay, there will be this few differentiating factors in the meningitis case. In meningitis, there will be the classical features of headache. There will be photophobia. They will give the history. There is a history of headache, photophobia, and there is this phonophobia. On evaluation, you will able to see this presence of neck stiffness. Okay, neck stiffness. Okay, and they only will tell he is diagnosed with meningitis. Okay, and on evaluation, you will able to see this gram-positive organism or gram-negative organism. This is where the diagnosis turns the point. If you are able to see these gram-negative organisms, then you will think of two organisms. One is this Neisseria meningitidis, and the another one is the 𝗵𝗵𝗶𝘀 influenza. 𝗵𝗵𝗶𝘀 influenza. Whereas if you just given gram-positive one, a good Dr. Diana Parul, then if just this gram-positive one, then it is what? Then it is the Streptococcus pneumonia I will think of. So if the history given of meningitis and there is this along with this gram-negative bacilli and the presence of rash, this rash will be present in a case of Neisseria meningitidis. Okay, it is a gram-negative capsulated organisms, and because it is negative, it secretes endotoxin. Okay, and it is be presented with this nuchal rigidity and the typical feature of rash, and it will cause one complication in the adrenal gland. Remember this Neisseria, it always produces some complications, whereas this Neisseria meningitidis, it causes meningitis along with complication in the adrenal gland. Okay, it is what it is known as Frederickson syndrome. Okay, it is known as Frederickson syndrome, which is what? Which is this adrenal crisis. Adrenal crisis. And as a selective media, it will use this Thayer-Martin medium. Okay, Thayer-Martin medium. Okay, and it ferments. It is just meningitis. Okay, it is just meningitis. So it will ferments both mannitol and glucose. So remember, it is M also there, G also there. It ferments mannitol and glucose. Okay, remember. And we can make vaccine against this capsule. We can make vaccine against this capsule. Okay, and it is really most prevalently seen in a case of patients who is presenting with deficiency of MAC. We know in a case of complement pathway, there is one thing which is known as MAC, which creates spore and destroyed. Are also known as membrane attack complex, which is formed by which components? It will be formed by C5b2c9. Okay, it is formed from this C5b2c9, and if there is any deficiency of this complements, this leads to this. This leads to what? This leads to what? This leads to this Neisseria meningitidis inflammation. Okay, Neisseria meningitidis inflammation. Next, if you see this Neisseria gonorrhea. So in a case of Neisseria gonorrhea, if you see this Neisseria gonorrhea, it will be having this kidney shape, and it also will be what? It also will be gram-negative, having this outer membrane proteins. So gram-negative along with this outer membrane proteins. But see, this is only G. There is no M. So it will what? It will ferment just glucose. It won't ferment. It won't ferment what? It won't ferment this mannitol. Okay. I guess things are clear. Yeah, good, Dr. Diana. Yeah, good. Yeah, fine. Then if you see, it will cause what? It will cause urethritis. I told this Neisseria types, they will cause infection. So Neisseria meningitidis, it causes infection in meninges, and it causes complication in the adrenal gland, which is what? Which is this Waterhouse-Friderichsen syndrome. Okay. Whereas in a case of Neisseria gonorrhea, what it will do? It will do this urethritis, and it will cause complications around the liver, which is known as what? Which is known as 𝗵𝗵𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀 polyhepatic adhesions. It is known as FMGE syndrome. Okay, then finally, if you see this complication, it can lead to this perineum, which is known as water can perineum, which causes this fistulae and sinuses in the urethra. Because it causes urethritis, it causes this water can perineum, and it causes one more complication or one more syndrome around this liver, where there is this perihepatic adhesions showing this violin string appearance. Violin string appearance. It is known as what? It is known as FMGE syndrome. It is known as FMGE syndrome. Next, it is the 𝗵𝗵𝗶𝘀 influenza. It is the 𝗵𝗵𝗶𝘀 influenza. As I told you, the same Neisseria, they will use the Thayer-Martin media, and the transport media it will use, it is the Stewart's media and Ames media. You will use what? You will use the Stewart's media and Ames media. So Stewart's media and Ames media as a transport media you will use for Neisseria gonorrhea. Where you will use this Pike's media as a transport media, guys? Where you will use this Pike's media? Will use in a case of Streptococcus pyogenes. Good. Then where you will use this Cariblair media or VR media as a transport media? You will use in a case of Yeah, you will use in a case of which disease? You will use in a case of Vibrio cholerae. We will use in a case of Vibrio cholerae. Good Dr. 𝗓𝗔𝗓, good Dr. Harsh, good Dr. Parul. Good, good, well. Then as I told you, 𝗵𝗵𝗶 influenza, it is also a gram-negative organism, and along with this there is a presence of capsule, and it will show a phenomena which is known as what? Which is known as satellitism. Which is known as what? Satellitism. So see, this is the growth of this colony, which is this 𝗃𝗬𝑠, and it would grow in the center. It will grow adjacent to this 𝗃𝗬𝑠. So it is known as this phenomena which is known as satellitism. It is known as satellitism. Okay, हो गया. फिर इसके बाद आगे बढ़ते हैं. Next, about the next disease, which is this typhoid. Typhoid, we know it is caused by this Salmonella typhi and some other variants like Salmonella typhi A and B. Sometimes it causes also. The features include this step ladder pyrexia along with the features of rose spots and relative bradycardia. In the previous FMGE examination, they asked where you will see this relative bradycardia. In typhoid, we'll see. In brucellosis also, we'll see this relative bradycardia. Yaad rakho. Then, about diagnosis of this typhoid, they will ask you in first week what you will do. See, in first week, we'll do the blood culture. So you can remember it's BASO. Okay. So first week we'll do blood culture. Second week we'll do this agglutination test, which is this Vidal test. And third week we'll do this stool culture. And fourth week we'll do the urine culture. So first week it is BASO. First week we'll do this blood culture. Second week we'll do what? Agglutination test, which is this Vidal test. Third week we'll do the stool culture. And fourth week we'll do the what? We'll do the urine culture. Yeah, good Dr. Ambika. Okay. Yeah, hi Sheikh Ahmed Wali Sheikh. Hi. And for this typhoid, we'll use this media. What is the name of this media? That is what it is, this Wilson-Blair media, which produces this jet back colonies in a case of typhoid or Salmonella infection. Fine. And next, you say a patient who is presented to you after an RTA. The patient presented to you after an RTA, and while pressing his limbs, you will be able to see crepitus present. Crepitus are present. So after RTA, crepitus present along with this discoloration. So ये क्या? It is what it is, this typical case of gas gangrene, and we know this typical case of gas gangrene is caused by this Clostridium perfringens, because this Clostridium perfringens will be having this enzyme which is known as lecithinase, and this lecithinase will digest the tissue and causes this type of feature of this necrosis, which is known as what? Which is known as gas gangrene. Okay, and this Clostridium perfringens will show different types of reactions. Okay, remember as ENTR. Yeah, good Dr. Vivek, good Dr. Anjali, good Dr. Bogle, and good Dr. Again Vivek. Fine. Next, if you see, it will produce this reaction which is known as NTR reactions. Like the first one, it is the Nagel's reactions. Next one, it is T for target hemolysis, and next one R for it is what it is this R for reverse camp test. It is the reverse camp test positive. Right? So it will show this stromy fermentation of this litmus milk. So it is known as what? It is known as Nagel's reaction. Next, it produces this target hemolysis. So target hemolysis will be seen in case of Clostridium perfringens. Next, you will see this reverse camp test. So this is the usual camp test which is done for this group B Streptococcus, which is what? Which is this Streptococcus agalacticae. Whereas here you will use this Clostridium perfringens to do this reverse camp test. So reverse camp test will be positive for this Clostridium perfringens. And there is one more family. Okay, one more family of Clostridium organism, which is this Clostridium difficile. Like when you complete your FMGE examination के बाद आप क्या करोगे? Internship करोगे. Like if you already done your internship, that is well and good. If you do internship for the first time, then there will be two departments, the medicine department and a surgery department. And in those two departments, there will be one or two chronic patients will be there. Chronic patients will be there, and their files itself look like a FMGE Solutions 9th edition book. So it will be that much big. So if you once you see on scrolling it, you will find all the antibiotics has been given to the patient, and now the patient is complaining of diarrhea. Okay, now the patient is complaining of chronic patient on antibiotic, now complains of diarrhea. Okay, what is the diagnosis you will think of? You will think of this Clostridium difficile induced diarrhea. You will think of this Clostridium difficile induced diarrhea, and to treat this infection you can give either oral vancomycin or fidaxomicin. Sorry, You can use either oral vancomycin or fidaxomicin. So this is the formation of the pseudomembrane over this colon. So it is known as what? It is known as pseudomembranous colitis. Pseudomembranous colitis. And on HP investigation, you will able to see the formation of this volcano eruption. So this type of volcano eruption will be seen in a case of Clostridium difficile infections, and to treat this will give fidaxomicin and oral vancomycin. तो हम ये 2 ड्रग्स देंगे, इतना याद रखो. फिर उसके बाद आगे बढ़ते Corynebacterium diphtheria. As I told you, this Corynebacterium diphtheria, it causes a condition which is known as what? Diphtheria. Okay, and this diphtheria, it will inhibit like diphtheria die. So it will inhibit this elongation factor DO. Okay, and this diphtheria will look like this appearance, which is known as what? Chinese letter pattern. Chinese letter pattern. There are different types of diphtheria. Okay, there are different types of diphtheria. One is known as fascial diphtheria, which causes this pseudomembrane presence, and there is this myocarditis, okay, which causes this circulatory failure, and but the most severe type, which involves this larynx, and because of the larynx, the child is unable to breathe and leading to this death of the child. So this is this Chinese letter pattern where you will see, and when you zoom it out, you will able to see around this end of this Chinese letter, you will able to see there are presence of this granules. This type of granules, we'll call them as what? We'll call them as metachromatic granules, also known as volatile granules, also known as Bob's nest granules. So this type of granules will be seen in a case of Corynebacterium diphtheriae, and we know how to see this stain. So if we need to see iron, which stain you will use? So to see iron, we'll use pearl special brew. To see copper, we'll use rhodamine and ribionic acid, and to see calcium, we'll use Van Gogh stain. Likewise, to see these granules, we'll use a stain which is known as what? Albert stain, which is used to stain these metachromatic granules, are also known as Babes granules. Okay, and for diagnosis, we can do 2 methods. One is known as low-flush serum slope. So low-flush serum slope, it will provide growth. It will provide the growth within just few hours. Okay, so it is used for this earliest diagnosis. Whereas we need to confirm the diagnosis. For that, we'll do this method from this potassium telluride agar. Okay, for the confirmed diagnosis, we'll use this potassium telluride agar. Fine, and we know this produces this toxin. Okay, and to detect this toxin, we'll use this test which is known as what? LX gel test. And this LX test, we'll line up the toxin, and if it is toxin present, then it will produce this neutralization like a X. Okay, X neutralization present in the case of LX gel precipitation test. A good Dr. Diana and good Dr. Murugesan. Fine. Next, we'll move on to the next part, which is this Clostridium tetani. I told you this Clostridium tetani will cause what? Will cause spasms. Will cause the spasms. And this Clostridium tetani, it will incubate this GABA or glycine. As I told you, both of them what? Both of them, they are this incubatory neurotransmitters. Okay, and it is aerobic bacteria. Okay, and it is having this terminal spherical drum shaped. Okay, drum shaped shape. Okay, remember. And as it is anaerobic, we'll use this media which is known as what? Robertson cooked meat broth. We'll use this Robertson cooked meat broth. Yeah, good Dr. Anjali. Yeah, that is GABA and glycine. Good. Then this can be 2, like proteolytic and saccharolytic. Means if the meat is become black, then it is a proteolytic type of Clostridium tetani. Whereas if it is turning into pink, it is what? It is this saccharolytic, which will be mostly because of this Clostridium perfringens. Because of this Clostridium perfringens. Okay, so this is the Clostridium tetani. And with this, we'll move on to this rickettsial infection. Do you have any doubt till now? Yeah, okay, good Anjali. Yeah, in a case of tetanus, you will see filtry appearance because it is anaerobic bacilli. So if you see this gelatin stab, what it will do? This is the gelatins, and the organism which is anaerobic, it will grow more on the basal side. So it will produce this pear-tree appearance. Whereas if we see about this Bacillus anthrax, in the case of Bacillus anthrax, I told you it is what? It is the aerobic bacillus. So it will grow more on this side, less on here. So it will make like this. So it is known as inverted fir tree. Inverted fir tree appearance. Remember. Next we'll see about this rickettsial infections. If you see about this rickettsial infections, like it is a bit hard to remember. For this also you make a table and stick to your walls or stick to your library table, right? And this rickettsial infections, how will you remember? Like you need to remember about this disease caused and organism and the vector. Okay, so remember this epidemic, remember this 𝗏. Okay, remember this 𝗏. So epidemic typus, P for P, it is caused by this 𝗏𝗏. It is caused by this 𝗏𝗏 and louse will be the vector. So 𝗏, louse will be the vector. Whereas this endemic, remember as 𝗏. Okay, 𝗏. Okay, 𝗏. So 𝗡 will cause us this endemic typus. So 𝗡 will cause us this endemic typus, and the organism which is responsible, it is what it is, Rickettsia type. Okay, then the scrub typus. Scrub. When you scrub something, you will see this sound, right? 𝗧𝗵𝗶𝗀𝗀𝗀𝗀. Okay, 𝗧𝗵𝗶𝗀𝗀𝗀𝗀𝗀. Okay, so see the scrubbing will be producing like this sound, right? So it is what? It is 𝗧𝗵𝗶𝗀𝗀𝗀𝗀, which is responsible for this scrub typus. Okay, and it is because of this mite. It is because of this mite. Okay, thrombocolate mite especially. It is because of this mite. Fine. Next, Rocky Mountain spotted fever. It is because of this Rickettsia rickettsii. Okay, and this too will be caused by this tick. Will be transmitted by this tick. Rocky Mountain spotted fever and Indian tick typus. Remember, it is Indian tick typus. So obviously it will be spread by this tick. And Indians like Indian tick typus, it is on the corners. So remember, it is Rickettsia cornei, Rickettsia conori. It is Rickettsia conori. Okay, and about this rickettsial pox, it is the acri. Acri, it is the rickettsial pox. So pox also will be caused by this mite. Next, cat scratch disease, it does not have any vector in India. So it is what? It is this Bartonella hensleyi. Okay, Bartonella hensleyi produces this cat scratch disease, remember. And bacillary angiomatosis, which is mostly seen in a case of HIV positive patients. It is seen in because of Bartonella hensleyi and Bartonella quintana. Bartonella hensleyi and Bartonella quintana. And then Q fever. Q fever, make this C and make it into Q. Okay, it is what? Q fever. It is Coxiella burnetii. So इसीलिए इसको है वेक्टर क्यों चाहिए? So Coxiella burnetii, it is Q fever and वेक्टर क्यों चाहिए? So there is no vector in this Coxiella burnetii. Fine. फिर उसके बाद आते हैं कि most important topic क्या? Mycology. And first in mycology, you need to know the stain. So to know this cultural characters, you will use this stain which is known as what? Lactophenol cotton blue. It is the cotton blue stain. So that's why the organism is what? Blue. Yeah, good Dr. Anjali, good Dr. Aishi. It is blue. Whereas if you are able to see, this is this black stain. This black stain. It is what? It is the 𝗵𝗵𝗶𝗀𝗃 silver stain. So whatever organism which stains black, it is what? It is this 𝗵𝗵𝗶𝗀𝗃 silver stain. And if its stain is pink, it is the PAS stain. And in PAS, you will be able to see this type of acute angular branching. Acute angular branching. Like 45 degrees, and along with this presence of the septae. So it is suggestive of which organism? It is suggestive of Aspergillus. Aspergillus. Yeah, good Dr. Naresh. Yeah, good. Whereas in the case of mucormycosis, you will see what? You will see this right angle branching in a case of mucormycosis. Okay, and it is not branch. So this is the typical Aspergillus. Okay. Next, what is the culture? Usually, what is the culture we use for this mycologist? We'll use this culture which is known as what? Seborrhoeus dextrosarcus. We'll use this Seborrhoeus dextrosarcus for culture of this mycologic organisms. Fine. And now, and in recent years, they started testing about this 3 species: Trichophyton, Microsporum, and Epidermis python. How will you remember this? It is tri. So means it involves all 3 structures. Hair may be involved karega, nail may be, or skin may be. Like in a case of Microsporum, it will involve just 2 structures. Remember, it is N. L, M, N. Like you know alphabetic order, right? Like N is next to M. So it will leave nails. So it will involve hair and skin. Whereas Epidermophyton, remember it is E, A, B, C, D, E, F, G, H. So it is near to the H. So it won't involve the hair. It will involve what? It will involve what? Only nail and skin. Yeah. You can remember it is like the same. Yeah. Good. Trichophyton, if you are able to see, 𝗵𝗵𝗶𝘀. Yeah. If you see, it is what? Trichophyton. You will able to see this like tie. Okay, tie. So it is what? It is the longitudinal and it is simple. It is what? It is pencil shaped. It is pencil shaped macroconidia. Okay, whereas microspora, it will be having this spindle shaped. Okay, whereas epidermophyton will be having this club shaped. Can anyone tell me where today we'll study this pencil shell cells? In which of the following conditions you will see this pencil cells in peripheral sphere? You will see pencil cells in a case of anemia. In a case of iron deficiency anemia, you will see this pencil cells. Okay, fine. And we have one more classification of fungi. They are known as what? Dimorphic fungi. Yeah, good, Dr. 𝗡𝗵𝗶𝗀𝗀𝗃. Good guys. Good, Dr. Rajat. Good, Dr. Anjali. Yeah, good. Very well. Like even you were hungry, but you are doing it very well. Okay, just we'll finish it off. Mycology over. Then we have the small part of virology and small part of parasitology. If it is done, then we are done for this microbiology part. We'll meet up after post lunch for pharmacology, and pharmacology it's like an easy peasy for you. Okay, we'll mostly go in depth in pharmacology. Okay, and after watching this too, you will I hope most of this important will be covered off. Fine. Next, about this dimorphic fungus, means it is two phases. One phase at your home, one phase with your friend. Okay, so this dimorphic fungus, it will be yeast at 36 degrees Celsius and mold at 26 degrees Celsius. So remember, it is mold at cold. At cold temperature, it will remain as mold. Okay, फिर उसके बाद to mnemonic is that body heat perfectly changes shape. Body heat perfectly changes shape. Okay, it is a mnemonic. Okay, so what are these organisms? It is the blastomyces, then histoplasma, P for paracoccidioidomycosis, C for coccidioidomycosis, and S for Sporotrix shankai, and one more P for Penicillium marnifi. So there are two P. One is paracoccidioidomycosis and Penicillium marnifi. Okay, how will you diagnose? Usually, in question they will give there is a patient who is presenting with history of subcutaneous mycosis. On evaluation, the following slide has been found, and in the following slide, the fungi is to show this broad-based budding. So, agar likha broad-based budding hai, so it is what it is the blastomycosis. So, broad-based budding, it is what it is the blastomycosis. And B, you can make it as like 8. So, it's look like an 8 with a big base. Take it with a big base. It is what it is the blastomycosis. फिर उसके बाद चलते हैं histoplasma. In case of histoplasma, it will remember like a, it will be like a tuberculate microconidia. Okay, but it is will be seen in a case of lactophenol. During culture, it will see. So it will show this tuberculate microsporidia. So you can know this histoplasma, right? It is also known as 𝗃's disease. Remember, histoplasma. Okay, it is also known as 𝗃's disease, also known as Ohio's disease. 𝗃's disease, Ohio disease, as it is involved in cave, it will be spread by this bat. Okay, Ohio's disease, and it will be having this tuberculate macroconidia. So as there is this tuberculate written here, so it will mimic which disease? It will mimic TB. And if you are able to see the next condition, if you are able to see this pilot veil appearance, it is seen in a case of paracoccidioidomycosis. And next coccidioidomycosis, you will be able to see this spheres and small spirules. Okay? And small spores. Yeah, good Dr. Hassan and good Dr. Naresh. So like it's in English, right? I guess I'm speaking in English. There's very small part where I speak other languages. Okay, mostly it will be in English. Okay, if you're unable to understand any accents, I'll be improving it. Okay, and next, if you're able to see this type of broomstick appearance, it is what it is, the Penicillium marnifi. And next, if you're able to see this rosette shapes, then if you see this rosette shape, it is seen in a case of sporotrichosis. Yeah, good Dr. Naresh. Broomstick, like you will hit for this rat. So bamboo rat, they are what? They are this reservoir of this Penicillium marnifi and produces this red pigments. It is a sporotrichosis. Okay, and we know it spread via the lymphatic route. Fine. Next, we'll come to this mycetoma. There is this history of walking barefoot. Like there will be a what? There will be a history of this walking barefoot, and there will be a history of multiple discharging sinuses. There will be history of multiple discharging sinuses, and all of them they are classically seen in a case of mycetoma. And there are two types of mycetoma. Yeah, Diana, it is most commonly seen in a case of Pharma's. Yeah, good Dr. Naresh. There will be associated pus discharge will be there, and there will be the swelling along with this sinuses discharging with the pus. It will be of two types. One is eumycetoma, another one is known as actinomycetoma. Eumycetoma means it is true. It is true like you and me. So it is the true mycetoma. So it will be caused by this fungus which is Mozzarella mycetomas. Okay, so it is will caused by this Mozzarella mycetoma. Whereas this actinomycetoma, it will be caused by this actinomyces species. It will be caused by this actinomyces species. Remember, okay? It is actinomycetoma. It is also known as a bacterial mycetoma. Okay, whereas true it is this eumycetoma which will be caused by this fungus one. Fine. Next one is the chromoblastomycosis. If you saw a patient who is presenting with this verrucous lesions, and on evaluation you will able to see this sclerotic bodies, also known as copper penny bodies, also known as medlar bodies. So all of the following will be seen in a case of which condition? Will be seen in a case of chromoblastomycosis. There will be presence of verrucous lesions with fungus history. Nice. Fine. That is the thing you need to know about this mycology part. Next we'll move on to this virus part. It will be a bit an easier aspect. If you see, they ask about the shapes, or they give this image and they will ask you what is the name of this virus. Okay, if it is a filamentous, it is what? It is the Ebola. Whereas rabies, it will be what? It will be bullet in shape, bullet shaped. Pox virus, it will be brick shaped with the dumbbell nucleus. And rota, it is what? It is the wheel shaped. It is the rotating wheel. And astro, it is what? It is the star shaped. Okay, star shaped. Okay, adenovirus, if you see, it is a kind of space. Yeah, box is a box, and in a box what you will kept? You kept the dumbbells. You kept the dumbbells, remember. Fine. Next, about the classification of viruses. There are different types of viruses based on these classifications. Based on the size, the pox virus, it is the largest one. Smallest, it is the parvovirus. Smallest is the parvovirus. And DNA viruses, usually viruses, they have either DNA or RNA. And DNA viruses, you can remember by mnemonic as HAPPY. Okay, so herpes virus, hepatitis B virus, adenovirus, parvovirus, pox virus, and papilloma virus. Parvovirus, pox virus, and papilloma virus. Okay, parvovirus, pox virus, and papilloma virus. So happy herpes, hepatitis B, adenovirus, parvo, pox, pappova. Okay, parvo, pox, pappova, and papilloma virus. All of them what? All of them they are what? They are the DNA viruses. Rest all of them they are RNA viruses. We know the DNA viruses, they will be having this double stranded DNA. Except one virus, which is this parvovirus, will be having a single stranded. Okay, usually RNA viruses, they are single stranded except virus, which has this two. Okay, all of the RNA they will be having a single strand, whereas DNA viruses they will be having what? Double strand. So except one virus which is not having double stranded DNA, it is what? It is the parvovirus, and we know parvovirus, it is the smallest virus. Okay, then there is the envelope. Like this virus will be covered with something. If it is covered, we'll call them as enveloped virus. If it is uncovered, we'll call them as non-enveloped virus. So non-enveloped virus, they are not resistant to our sanitizers. Okay, sanitizers. Yeah, good Dr. Naresh. Then it includes this two. In the case of DNA viruses, this parvovirus, adenovirus, and papilloma. This pap virus, they are naked. They are this naked virus or non-enveloped virus. Whereas RNA virus, which include Picorna, Astra, 𝗏𝗏𝗏, and 𝗵𝗏. All of these four viruses, Picorna, Astro, 𝗏𝗏𝗏, and 𝗵𝗏. Picorna, Astro, 𝗏𝗏𝗏, and 𝗵𝗏. All of these four viruses, they are this RNA viruses which are non-enveloped. Yeah, good Dr. Anjali. Whereas this DNA viruses like parvo, adeno, pappova, they are non-enveloped. Whereas the rest of the viruses, they are what? They are enveloped in nature. Likewise, this double-stranded DNA will be present in all DNA viruses except parvovirus. Okay, bas itna yaad rakhna. Then we'll move on to this intracellular and intranuclear inclusions. In intranuclear inclusions, we'll see two bodies, 𝗓𝗏𝐴 and 𝗓𝗓𝐵. Means this is 𝗓𝗓𝐴, means which is basophilic, which is blue in color. It is what it is, 𝗓𝗓𝐵. Whereas which is more or less blue or less pink in around the pink in color, it is what it is, the 𝗓𝗓𝐴 bodies. Remember, this 𝗓𝗓𝐴 will be seen in a case of herpes virus and yellow fever virus, whereas 𝗓𝗓𝐵 will be seen in a case of adenovirus and poliovirus. Adeno and polio will show this Cowdery B type of viruses. And there is this intracytoplasmic, inside the cytoplasm. You're able to see this type of fillings. It will be seen in a case of few conditions like rabies. Rabies, you will see this Negri bodies. Rabies, you will see Negri bodies. Next, this Anderson-Peterson bodies. Anderson-Peterson bodies will be seen in a case of molluscum contagiosum. In molluscum contagiosum, you will see this HP bodies. Yeah, good guys. Yeah, Negri bodies we'll do autopsy and we'll see in a case of rabies. Okay, remember. Good, Dr. Anjali. Good, Dr. Diana. Good. Next, there will be few conditions which will show both intranuclear and intracytoplasmic inclusions. Likewise, as I told you to morning, it is owl eye. If it is blue, it is क्या? Blue, it is the CMV1. अगर blue है तो CMV1. Red one, Reed-Sternberg cell. Red Reed-Sternberg cell. Reed-Sternberg cell seen in a case of Hodgkin's lymphoma. Whereas the CMV will show this central bluing. Okay, central bluing. It is what it is this intranuclear inclusions in CMV, whereas it will be having both intranuclear and intracytoplasmic inclusions. Right? फिर उसके बाद आगे बढ़ते हैं मीजल्स. इन मीजल्स में भी हमें both intracytoplasmic and intranucleus मिलता है. Yeah, good Dr. Diana, good Dr. Anjali. Fine. फिर about this classification of this viruses, the classification हमें क्या देखेंगे? We need to see what are the types of viruses based on this herpes virus. This human herpes family, it is divided into 8 classes. HSU1, it is this herpes simplex 1. So herpes simplex 1, remember, it is the first. So initially what you will do, you will start with your lips. Okay, you will start with the upper part of the body. So remember, it is above the waist. So HSV1, it involves the lips are above the waist. So it involves the herpes labialis and encephalitis. It will cause herpes labialis and encephalitis, temporal lobe encephalitis. Whereas this HHV2, it is a very ganda one. It involves what? It involves this below the waist, which will cause this genital herpes. So in a case of genital herpes, if you do a Zancks smear, I showed in pathology. If you do a Zancks smear, you will be able to see this multinucleated giant cells in a case of HSV, remember, okay? Yeah, below waist, below waist. Waist matlab around the hip, okay? And human herpes virus 3. So remember this 3? It is what? It is our famous chickenpox, okay? Chickenpox, which is this varicella zoster virus, and it will be having this pleomorphic rash. It will be having this pleomorphic rash, and this can remain dormant. This can remain dormant into the ganglia, and it can reoccur in old age or immunocompromised state. So this is what this is known as shingles, and shingles it will cause a post-herpetic neuralgia. And answer me, it is a pharma questions. In a case of post-herpetic neuralgia, what is the drug you will use? You will use this gabapentin. Fine, you will use this gabapentin. Okay, yaad rakho. Next, if you see this human herpes virus 4. Fourth virus kya? It is the Epstein-Barr virus. It is the Epstein-Barr virus, and we study this Epstein-Barr virus. It will cause a disease, which is what? Which is this infectious mononucleosis. Infectious mononucleosis. Okay, and this infectious mononucleosis, it will be caused by this involvement of the CD21 receptor, and because of this, it can even cause carcinogenesis. So remember, this HHV4, which is the Epstein-Barr virus, that will be having the involvement of CD21. It is very, very important. It is very, very important. Okay. Then uske baad this HHV5, it is the cytomegalovirus. Because this cytomegalovirus, it will spread via this congenital route, and it also causes this CMV retinitis. Itna yaad rakho. Next, HHV6. HHV6, it causes this. This is which is known as roseola infantum. Roseola infantum causing this slab cheek appearance. Okay. And HHV8, it causes this Kaposi's sarcoma. Kaposi's sarcoma, it will be caused by this HSV8, HV8, okay, which is mostly seen in a case of HIV positive patients. So remember, HHV1, it is the herpes simplex type 1. HSV2, it is the herpes 2, okay, it is the herpes simplex 2. HHV3, it is the chickenpox, which will be showing this pleomorphic rash. Pleomorphic means different types of rash or different stages of rash at the same time, okay, and it is associated with the itching, and if it resolves, if it happens and in older age as a dormant condition, okay, it is what? It is known as shingles, okay. And HHV4, HHV4, it is what? It is the EBV, whereas HHV5, it is the cytomegalovirus. HSV6, it is the roseola infantum, whereas HHV8, it is what? It is this Kaposi's sarcoma virus. Fine. Yeah, I guess this roseola infantile. Yeah, it will show this slab cheek appearance. Fine, or else let me confirm it once. Okay, just remind me after break. I guess it is this slab cheek appearance. And next, if you see about this egg, like eggs and larva, if you see this type of eggs, which is having this 4 flagellas, it is what it is, this giardia. It is a giardia. And remember, the giardia will be having this falling leaf motility. So remember, giardia gyradia. So it will be having this, giardia will be having this falling leaf motility, and it will be having this suckling disc. Okay, it will be having this suckling disc here. Okay, with 4 pairs of flagella. And if you're able to see this type of hair, like if you see this girls, right, they'll be having this curly hairs on the side. Okay, on the side. So it is what it is, the trichomonas. So if there like a hair, like a curly hair, it is the trichomonas vaginalis. And we know trichomonas will produce. Yeah, let me confirm you. Like, let me confirm you, Diana. Fine, just wait. Okay, trichomonas vaginalis, it will be having this hair-like one. Okay, it will be what? It is the trichomoniasis. Next, if you are able to see this type of sharpened ones, it is what it is, the acanthamoeba. Acanthamoeba. That is the acanthamoeba. It is the acanthamoeba. Yeah, we'll use this diamond media for this trichomoniasis. This acanthamoeba, it is most common cause of corneal ulcer in the case of contact lens users who washes this contact lens in the running tap water. Fine. And about few eggs we'll check. If we see about this eggs, having this barrel shaped eggs, which is having this opening, which is known as what? Which is known as operculated eggs, which is most commonly seen in a case of all cases of trematodes. Okay, and the cystodes, except a schistosomiasis. When schistosomiasis will give or will see this spine. Okay, spine will see in a case of schistosomiasis. And in Mansoni, and in mans you will see this lateral spine. Only the mans will come on back pitch, right? Not animals, they will come on back pitch. So mans, they will come on back pitch. So remember, it is the lateral spine which is seen in a case of Manzoni. Okay, whereas this central one will be seen in a case of hematobium. So schistosoma hematobium will be having this central spine, and whereas this japonicum will be having this knobs. Will be having this small one, which is this, or this rudimentary spine, which is seen in a case of schistosoma japonicum. And next, if you're able to see this type of hooklets along with this polar knobs and this polar filaments. So if you see, as this nana nani means this in old age, if you see the old age nana nanis, they will be wearing these specs. Okay, and most of them they will be alone, they will be separate. Okay, so this 𝗵𝗵𝗶𝘀, like no, this 𝗏𝗏𝗏𝗏, this will be having only one host. So initially in their young they will be like this, but on later on ages they will be bent like this. So it is known as what? It is also known as dwarf tapeworm. It is known as dwarf tapeworm. Okay, as like this two specs, they will be having this polar knobs. They will be having the polar knobs, and we know they will be having this vision difficulty. So they will be having this chashma, and it will be tied with a rope. So once you tied with a rope, it will be like a polar filaments and polar filaments. Okay, and they will be having the hooks. They will be having this hooks. So it will be having the central hooks along with this polar filaments and polar knobs. Okay, yeah, there's a theory pair. Fine, yeah, correct, guys. This, if you ask me, it is for a supplementation or is for final part of revision. This session along with this PYQ, it is more than enough. Okay, as a final point of revision, and you want exactly 150 score, and you can attempt or you can read each line by line everything, and you can get questions from it correct, then it is more than enough. But if you already studied with your main notes, make sure you are reading your main notes and making this as your supplement or extra edge, and make sure you are reading this in the final part of your revision. So this is how you will improve the scores, and you will get 150 marks for sure. Okay, but if you read this only, you will cross this 150 mark, but you make sure you are reading each and every part. Okay, that is the thing. Fine, yeah. Then if you see this 𝗵𝗵𝗏𝗏 vermicularis, if you see this 𝗵𝗵𝗏𝗏 vermicularis, if you see, this is known as what? This is known as spin worm. This 𝗵𝗵𝗏𝗏 vermicularis, it will be having this plano-convex egg along with this larva inside. It is seen in a case of 𝗵𝗵𝗏𝗏𝗏 vermicularis. Next, 𝗓𝗬𝗓, if you see, it is like a barrel shaped egg along with this mucus plug, okay. It is seen in a case of 𝗓𝗬𝗓. Yeah, you will see this thing which is known as what? Coconut cake rectum. You will see this coconut cake rectum and also rectal prolapse in a case of 𝗓𝗬𝗓, okay. And next, this is the only ciliated protozoa. It is what? It is the Ballontidium coli. So Ballontidium coli, it is the only ciliated protozoa. You can see, right, the cilia, okay, and it will be having the binucleated. It will be having the two nucleus, one big one and one other small one. So Ballontidium coli, it will be having the binucleated, okay. Then if you see this kind of segregations, okay, segregations inside the egg, it will be seen in a case of blastomeres, we'll call it as, will be seen in a case of ankylostoma duodenale. And next, in a case of ascariasis, there will be two eggs. Like ascariasis, if you see this type of rugged eggs or rough eggs will be seen in a case of unfertilized ascariotic eggs, whereas in a case of smooth edge will be seen in a case of fertilized ascariasis eggs. So most of this image of this thing will be asked from this part only. Okay, make sure you are reading it or checking it correctly. And about the malaria, you need to know about just few things. In a case of Plasmodium, we know the infective stage. In a case of infestive stage, it is in man, it is what it is sporocytes, whereas for mosquito it is the gametocyte. So in mans, if you see this type of banana shaped gametocytes, so this type of banana shaped gametocytes will be seen in a case of Plasmodium falciparum. And in Plasmodium falciparum, you will see this multiple rings. It is not single rings, it is multiple rings will be seen in a case of Plasmodium falciparum. Okay, and there are few additional dots you will see here. In a case of vivax, in viva they will shuffle and ask. So you will see this Schaffner's dots. Next, in a case of falciparum, remember it is, read from here, it is the Murier's dots. And in malaria, you will see the Zeeman's dots. Malaria, you will see Zeeman's dots. Vivax, you will see this Schaffner's dots. Falciparum, you will see this Murier's dots. And Vowel, you will see this James dots. Okay, so let's read and remember this dots for one more time. You will be able to get this thing. And in a case of vivax, it is not multiple rings, it is the only one ring. Okay, and here there is, you can see this kind of diffused gametocytes, whereas in a case of Plasmodium, you will see this banana shaped gametocyte in a case of Plasmodium falciparum. Okay, and finally, if you are able to see this type of Maltese cross appearance, where you will see this Maltese cross appearance, guys? In RBC, in which infection you will see this Maltese cross appearance? You will see in a case of, which is this? Babesiosis. You will see in a case of babesiosis. Good, guys. We will see in a case of babesiosis. Good, Dr. Naresh. Then about this last slide, if you see, you need to differentiate between this type of organisms. Okay, like if you see these forms, there is a presence of this sheath. Here there will be WBL, like, or LBW. Here there will be presence of sheath will be present here. There will be presence of sheath. Okay, but in a case of rest organisms, the sheath will be absent. Okay, you can see, right, there is no outer covering, the sheath will be absent. Okay, and now they will ask you which of the following organism is this based on their nuclei count. Okay, if you see there is no nuclei, there is no nuclei. If there is no nuclei, Bancrofti means there is no nuclei, it is Bancrofti. Okay, then if you see this malai, okay, if you see this malai, Brugia malai, it is what it is, the Brugia malai. So B for B, it will be having this two nuclei at the tip. So if it is two nuclei at the tip, it is what it is, the Brugia malai. Whereas if you are able to see the nucleus persisting till the end, but it is in a line. So if it is nucleus in line, then it is known as lava. So nucleus in line, it is lava, whereas no nuclei, it is what Eucheria Bancrofti, whereas Brugia malai, you will see two nuclei, and all of these three will be having this sheathette. Okay, there will be the presence of these sheaths, whereas rest they won't have the sheaths. So if you see here, if there is no nuclei going till the tip of tail, what do you think of? Which organism is this? No nuclei at the tip, and there is a presence of this sheath. What is this organism? It is what it is, the Eucheria Bancrofti. It is the Wucheria bronchiophthalmos. And final part, we'll discuss this and we'll leave off. Fine. If you see this one, this organism is responsible for diarrhea in HIV positive patients. HIV positive patients. Yeah. This previous conditions, previously this Wucheria bronchiophthalmos will cause what? Lymphatic filariasis. Okay. Here this diarrhea in HIV positive patients, it will be caused by this Cryptosporidium, Cyclospora and Isospora. But you need to differentiate. How will you differentiate this organism? Remember, this is crypto, means it is very small. So remember, it is very small. So it will be around 4 to 8 micron, okay, in diameter. Whereas this Cyclospora, it will be having this 8 to 10. It is the next line. It is double of it. So it is the 8 to 10. Whereas this Isospora, draw this iso. So it will be what? It will be oval in shape. It will be oval in shape. It won't be spherical. And then you can use one more method, which is what? Which is this acid fast staining. Acid fast staining. And in acid fast staining, if you see Cryptosporidium, it will stain perfectly. Whereas it is Cyclospora, it will be cyclical in nature. It will stain sometimes, it won't stain sometimes. So it is what? It is known as variable acid fast. Variable acid fast. Whereas Isospora, we can identify based on this oval shape. So guys, that's it. That's it. You need to remember about this Cryptosporidium, Cyclospora spot, and that these are the must know and most important topics from this microbiology perspective. Just remember one thing: if you study hard and stay motivated for this all along journey of next 40 days, then you can crack this examination for sure. Okay, just try to get your motivations from inside. Don't seek for external motivations, because external motivations, they will stay for only a while. Okay, guys, like that's it for this microbiology part. We'll have a good lunch break for 40 to 45 minutes. It is 2 o'clock exactly. We'll meet up at 2:45 p.m. Okay, we'll meet up at 2:45 p.m. Okay, that's it. If you have any doubts, I'll clear it off. Okay, fine. Yeah. Now, thank you, 𝗓𝗵𝗶𝘀. It is the 𝗓𝗵𝗶𝗀𝗀𝗀𝗀, the slab cheek appearance. Yeah, it is what it is, the erythema infectiosum. I'll correct it off. Okay, that's it. If you have any other doubts, you can put up in the chat section. You're welcome, Naresh. Have a good, good. Thank you, Dr. Anjali. Have a good lunch and come back. We'll see the pharma, because this 3, it will be a bit volatile. It will be a bit confusing. I know it will be very much hard to remember all these stuffs, but make sure you are giving an attempt. Until unless you read, you won't get it. So you need to read, you need to get, then only you will pass. Okay. Yeah, good Dr. Ambika, good Dr. 𝗓𝗵𝗀𝗀𝗀. Yeah, very interactive. Thank you, Dr. Diana. It gives me more energy to connect with you. Okay, fine. We'll have a good break, guys. Have a good lunch. We'll meet up after 40 minutes. Okay, we'll start our session at 2:45. We'll start up at 2:45 p.m. Okay. Thank you, Dr. Naresh. It feels very good, and it's your cooperative effort, because you were answering all along, and sometimes I miss your names. I really sorry for it, but you will always be into my minds. So just remember to keep on answering things. Once you answer, the things will come out, and you will able to answer the same correctly in the examinations. Okay, guys. See you after the lunch break. If any doubts, please put up in the chat section. I'll take up after the break. Fine. Bye bye, guys. Yeah. Good afternoon, doctors. Welcome back to the game changer session. This is our pharmacology part. Can all of you confirm about this audio and visuals are well? Yes, can you please comment in the comment section? Yeah, hi, Adil Shafiq from Azmi. Yeah, good. Yeah, good, Dr. Parul, Dr. Preeti. Yeah, see you back again. It's good. Yeah, hi, Aishi, hi, Sadaf, hi, Simple. Simple, like if you ask me, like if you know this sessions and PYQs well, then it is enough. But you should always supplement with your main notes, or at least for main subjects, so that will give you more marks and more push. Okay, but this is enough for your revisions. That is what I can tell you, and enough to score 150. The content is enough, but it will be difficult for you to read each and every line and each and remember, right? So just make sure you are reading your previous notes along with this. It will be the best one for your revision, and it will score you 150. If you read just this, if you read with your notes, it will get immense number of scores. That is the one. I guess you got it simple. Do you have any other queries? Yeah, fine. I guess there is no other queries. Like, let us start with this pharmacology part of this game changer session. And this session, it is it has a timeline of around 1 hour 30 minutes to 1 hour 45 minutes, and we'll be done with it after that. Okay? Yeah. PVQ भी करवा दो. हम करवाएंगे. Like we'll see. Like it's based on the timings and availabilities. हम करेंगे. ज़रूर करेंगे. कुछ ना कुछ करेंगे. बस आपके लिए करेंगे और आपके एग्जाम के लिए करेंगे. ठीक है ना? बस कुछ करेंगे. ठीक है ना? आप चिंता मत करो. Just have this patience and have this hope that you will do it with all the efforts you have putting up. So just go along with the sessions, keep on revising it, and I'll try to give this PDF as early as possible. But sometimes some unfortunate situations, I will share mostly in the morning. But rest PDF I will try to give you in the before class, and after once the class is done, I'll give you the annotated one. So don't worry about those things, but make sure you are revising the PDF and doing PYQs on the same day. Okay, that will be a best push up from your end. Okay, so that's it, a small chit chat, and after this let us start with this pharmacology part of our game changer session, and we'll start with the first. If you see the first one, it is asking about the phase of clinical trials. They will ask you, what is the name of the clinical trial where you will use, or what is the phase of the clinical trial where you will use this, or where you will see this maximum tolerability doses, or where you will measure this maximum tolerable dose. What will be the answer for you? What will be the answer? It will be what? It is the phase 1. So remember, there are different phases of drug testing. If you see about phase 0, it is just the microdosing. It is just the microdosing, usually done before human healthy volunteers. Whereas in a case of phase 1, it will be done in a healthy people. Remember, only is the phase 1, like because we consider phase 1, phase 2, phase 3 and phase 4 as a proper clinical trial. So phase 1 will be what? It will be done in a healthy human individuals. Whereas in a case of phase 2, phase 3 and phase 4, it will be done in patients. So if they given in a healthy individual, which of the following phase you will do? Option A, 1, option B, 2, option C, 3, option C, D, 4. What you will choose? Hey guys, what you will choose? Yeah, good, Dr. Nida Khan, good Dr. Ansh. Okay, it is what? It is the phase 1. The phase 1, it will be for this human healthy volunteers. Okay, it is the healthy human volunteers. And in phase 1, we'll measure this. Yeah, good Dr. Sadaf. And in phase 1, we'll measure the maximum tolerable dose. MTD will measure in a case of phase 1. Whereas in a case of phase 2, what we'll do? We'll do a testing which is known as efficacy. How the drug is efficacious. So we'll do efficacy testing in a case of phase 2. Whereas what we'll do in a case of phase 3? In a case of phase 3, we'll confirm the efficacy which is being tested in the phase 2. In phase 2, we'll give less number of patients. We'll do this in less number of patients. Whereas in a case of phase 3, we'll do from around 500 to 5,000 patients. Okay, and we'll confirm this efficacy that yeah, that this drug is working and this drug is miraculous. ठीक है ना? फिर उसके बाद चलते हैं fourth. The stage 4, it is actually what it is, this post marketing surveillance. ठीक है ना? After stage 3, the drug will enter into the market. Means the drug will be sold. Once the drug is being sold, then it will be in the market, right? So it will be in the market. So once the drug is in the market, then we need to monitor the side effects and its rare phenomena. Mainly the rare side effects, it will be come through this post-marketing surveillance. Fine. So that is the post-marketing surveillance, which is especially for this long-term outcomes and very rare side effects. And this also done in the patients, and it is very widely ranged because as it is available in the market, many of the patients will start using this drugs. So these are the 4 phases you need to remember. 0 is for microdosing, so just keep it aside. 1, it is for what? It is for this detecting of this maximum tolerable dose in human healthy volunteers. Fine. And in phase 2, it is the efficacy testing done in a small number of patients. Phase 3, it is done in a large number of patients, and it is to confirm the efficacy. And phase 4, it is what? It is this measuring this rare side effect or this post-marketing surveillance. Fine. And it is also done in patients. Remember these 4 points about this healthy or this randomized control trial phases. Fine. Yeah, maximum usually it will fail between 2 and 3. Just remember. And about this efficacy and potency graph, they will give you this graph and they will ask you which of the following drug is having the highest potency. Can anyone tell me which of the following drug is having this highest potency of this mentioned ABCD? Yeah, guys? Which has this highest potency in the mentioned curves? Yeah, good Dr. Ansh, good Dr. Naresh, good Dr. Nida. It is what? It is the drug A. Means remember the potency, P for potency and P for pass. Means the nearby one. The nearby one will be having this maximum potency. So if you see the drug A, it is starting here itself. So it is the highly potent drug. Whereas if you see this drug D, it is what? It is this starting late. So it is very less potent. Whereas if we see about the efficacy, it's about the height of the cow. Okay, how height is the cow, that much efficacy it is. Fine. See, if you see this drug D, it is having this low efficacy, whereas drug A, if you see, it is having the maximum height. So the drug A, it is the maximum efficacious in nature. Okay, right. So in this graph, if you see, most of them, they are equi-efficacious, means their efficacy is normal or is equal. Okay, it is equal in nature. Yeah, good Dr. Ansh. Fine. So these are the things you need to see on this efficacy and potency. So remember, potency matlab pass. The drug which is acting at very low dose, it is more potent. Okay, and the drug which is having this maximum effect, so it is known as what? High efficiency. It is known as high efficiency or mainly the height. Okay. Next, we'll move to some more formulas. Okay, they will ask you about this to calculate this drug safety index, or they will ask you the formula. So remember, the therapeutic index, it is what? It is this LD50 by ED50. Okay, it is the LD50 by the ED50. Okay, next about this volume of distribution, like once you give a drug, how it will distribute into the body. So the volume of distribution, it is what? It is this amount of drug or the given dose divided by how much amount is reached into the plasma. So our concentration in the plasma, how much it is being distributed. So the given dose divided by concentration of plasma, it is the volume of distribution. Next one, it is the maintaining dose. Like once you give a dose, you will give 2 types of doses. One, the loading dose to reach a proper half-life, okay, or the max to reach a proper peak effect, and after which you will maintain the dose. So first you need to know about this loading dose. You will think of its clearance and volume of distribution. So for this loading dose, you will think of volume of distribution and clearance. Whereas for this maintenance dose, you will just see the plasma concentration and clearance. So both of these will check into clearance, whereas loading dose, how it is widely spreaded, so that how much it can withstand and it can act. That is the loading dose. Whereas maintenance dose is that how much concentration we need to maintain the effect of the drug. That is known as maintenance dose. Okay, I hope I'm clear in this formula, and just see this formula because recently the trend is started changing and they started asking about these formulas. So make sure you are reading this formula before going to your examination. And about this part, this enzyme inducers and enzyme incubators, why they are important? Because if you give one drug, and the other drug which you are giving, it may incubate this metabolism of this drug, or it may induce this metabolism of this drug. For example, if it inhibits its mechanism, what will happen is that this drug level in the blood, it will keep on rising because the drug will be there. It will keep on taking those drugs. So the concentration of the drug in the blood will be increased. So these are this enzyme inhibitors. Whereas enzyme inhibitors, what it will do is, this will cause what? This will induce the enzymes. So inducing the enzyme will causing this rapid metabolism of the enzymes. If rapid metabolism occurs, then there will be no drug will be left over for a longer action. So remember, it is these drugs which are this inducer drugs, they will decrease the level of other drugs because of further things. Preeti, yeah, mostly you just remember about this formulas. They won't dive in depth and ask you about the calculations. Mostly the calculations are being asked from the PSM perspective. This formulas you just remember. You don't need to remember about the calculations part. Fine. Next, as what? If you see this enzyme inducers, what they will do? They will decrease the level of other drugs. Because what it will do? It will rapidly increase the metabolism. Fine. This include, you can remember is GPRS cell phone. Okay. Remember first one, it is the alcoholism, 𝗧𝗵𝗶𝗀𝗀, phenobarbital, 𝗵𝗵𝗿𝗀, smoking, 𝗵𝗵𝗶𝗀, and phenytoin. So alcoholism, 𝗧𝗵𝗶𝗀, phenobarbital, 𝗵𝗵𝗿𝗀, smoking, 𝗵𝗵𝗶𝗀, and phenytoin. All of the drugs, they act as an enzyme inducers. So if you are giving some other drugs with it, you should increase the dose. You should increase the dose so that the drug will stay in plasma for a longer time. Whereas in a case of enzyme inhibitors, what they will do? They will increase the level of these drugs. Means they will inhibit its metabolism so that the drug won't be metabolized. It will be staying in the blood for a longer duration of time. Okay. These drugs include valproate, ketoconazole, cimetidine, erythromycin, isoniazid, protease inhibitors in HIV, and omeprazole. So remember, the anti-TB drug which is inducer is rifampicin. Whereas anti-TB drug which is inhibitor, it is what? It is the isoniazid. Can anyone tell me what is the name of the vitamin does this isoniazid will cause deficiency of? Yesterday we studied in biochemistry. Yeah, guys. Yeah. What is the name of this vitamin deficiency will be caused by this isoniazid? It will be caused the vitamin B6. Yeah, good Dr. Diana, good Dr. Preeti, good Dr. Anansh, good Dr. Sadaf, good, yeah, well said. So it is what? It is the pyridoxine deficiency. It is the pyridoxine deficiency which is at the vitamin B6. So remember, it is I6. Okay, isoniazid cause deficiency of vitamin B6. Okay, then we'll move on to these two drugs. These are this brother and sister, like physostigmine and pyridostigmine. Looks similar. Maybe having some confusion, but remember this physostigmine, it is what? It is the tertiary amines. This tertiary amine means they're small. Okay, remember it is a small tertiary. Okay, so they can penetrate into the CSF. Whereas this quaternary amines like pyridostigmine and neostigmine, they cannot cross the blood-brain barrier, and so they cannot enter into the CNS. So in case of any CNS conditions, we can use this drug. For example, in a case of Alzheimer's disease where there is a decreased level of acetylcholine, in a case of such conditions, we need to increase the level of acetylcholine. There are different methods of increasing acetylcholine. Whether either we can directly increase, they are known as direct acetylcholine increasing drugs. Whereas there are few drugs, what will do? They will act indirectly. What they will do is that there is an enzyme which causes metabolization or which causes breakdown of this acetylcholine. They are known as acetylcholineesterases. So this drug will go and act on those drugs, and it will cause less degradation of the acetylcholine, by which the acetylcholine is meant to stay for a longer duration. So this is the role. So if you see this physostigmine, it is used in a case of Alzheimer's disease. It is used in a case of Alzheimer's disease. Yeah, guys. Yeah, Alzheimer's disease will use some more drugs. Yeah, the one of them, this categories will come under this donepezil. Okay, remember it is the donepezil which is used in the Alzheimer's disease. And next, physostigmine. Physostigmine, it is used in a case of atropine poisoning. So physostigmine, it is used in a case of atropine poisoning. So if you see in the case of atropine poisoning, it is the blockage of this parasympathetic system. Whereas to bring it back, we'll use this parasympathomimetic drugs like physostigmine, and it will increase it. So on atropine toxicity and datura poisoning and atropa belladonna poisoning, all of them, they looks almost similar. Okay, they'll be having a few typical features that I will explain you in further on. So just remember about the 𝗲𝗶𝗀𝗀, it is the drug of choice for atropine toxicity, whereas for Alzheimer's disease will give donepezil. Alzheimer's disease will give donepezil. Next about this quaternary amines, I told these are very large components and they cannot penetrate into the CNS. अगर ये CNS में penetrate नहीं करता है तो ये क्या होगा? It will stay in the outside, or it will stay in the blood or in the peripheries. So we can use in the case of conditions where we need them in peripheries. For example, in the case of myasthenia gravis, हमें पता है in the case of myasthenia gravis, the antibodies they are against this acetylcholine receptors. So in such cases, what we'll do, we'll increase the production or increase the release of acetylcholine in such cases. So that is what this pyridostigmine does. Okay, and this pyridostigmine is used in a case of myasthenia gravis and cobra bite. Like especially the neostigmines will be used in a case of cobra bite, and in a case of toxicity from this skeletal muscle relaxants, because muscle relaxants they are peripheral acting, right? There we can use this neostigmine or pyridostigmine. And there is one more class of this drug which is known as endothorium. This endothorium, it is a very short acting drug, and this endothorium it is used for diagnosis of this myasthenia gravis. So endothorium it is used for diagnosis of which disease? Myasthenia gravis, and the name of the test it is known as टेंसिलॉन test. So this टेंसिलॉन test it is used for the diagnosis of this myasthenia gravis. बस इतना याद रखो. So myasthenia gravis will use neostigmine or pyridostigmine. Okay, and physostigmine will use in a case of atropine poisoning, and donepezil will use in a case of Alzheimer's disease, whereas pyridostigmine will use in a case of myasthenia gravis, and endothorium it is used in a case of टेंसिलॉन test. बस इतना याद रखो हो जाएगा. Then about this OPC poisoning. Yeah, good Dr. Shanwas and good Dr. Anash. Okay, fine. Next one about this OPC poisoning and carbonate poisoning. So we know this OPC poisons, what it will does, it bind to the receptors and it causes overstimulation of the parasympathetic system. So once it causes this overstimulation of this parasympathetic system, it will be showing these features of what? There will be showing the features of increase in secretions, like there will be increase in lacrimation, increase in salivation, increase in vomiting, and increase in urination. So all of the secretions will be more. Okay, their secretions will be more, whereas the pupil will become constricted. We'll call them as pinpoint pupil. We'll see this pinpoint pupil, and in lungs there will be bronchoconstriction, bronchoconstriction, and there will be in heart there will be bradycardia. So there will be bradycardia, bronchoconstriction, pinpoint pupil, and there also will be all secretions as I told, and this diarrhea also will be there. And if they act on this muscular receptors, it will result into this muscular weakness. Yeah, we'll call them as dumbbells simply. Yeah, if you know these dumbbells, just keep them as okay. So these are the symptoms which we'll see in a case of OPC poisoning. But see, there are two poisonings. OPC, there is two reasons. One is this acetylcholine levels have been increased, and why it is increased? Because this enzyme which is breaking down this acetylcholine is not active. So now we need to reactivate the enzyme. So we'll give two drugs. One drug to decrease the symptoms and mask the signs, and second drug to reactivate this drug. So the first drug will give it is what it is the atropine, and the second drug will give it was what it is the tralidoxin. So atropine it blocks the receptor, but still there is an increase in ACH levels will be there, but it will not reverse the effect of the neuron junction and acetylcholine esterase binding. So we'll at the moment will give what? Will give the tralidoxin, or also known as PAM. Whereas in a case of carbonate poisoning, only atropine is enough. Whereas oximes like tralidoxins will be contraindicated in a case of carbonate poisoning. Okay? Yeah, good Dr. Naresh. Yeah, that is atropine plus oximes in a case of OPC, whereas only atropine in a case of carbonate poisoning. That's it. Next about the atropine uses. Fine. We saw this atropine, it is what it is this. It will opposites the action of this parasympathetic system. Okay, so if you give atropine in a bradycardia patients, it will increase the heart rate. So usually atropine it is used in the clinical settings to increase the heart rate, and we saw this OPC it is a parasympathomimetic. So parasympathomimetics causes constriction of the pupil, whereas this atropine will cause what? It causes powerful dilatation of the pupil. Okay, powerful dilatation of the pupil. Mostly about this atropine and toxicity, they will be having this typical history. This fruit, which I will show in the forensic part, which is known as this roadside poison. which is this datura. Datura, and if it is being thrown into you, you'll be having this datura poisoning, which will be having this active component of hyoscine or atropine. And in such cases, the datura will be having all these. D for it will be having this dry mouth and delirium, and there will be features of hyperthermia. You will be dry, so you will be hyperthermia. You'll be having this agitation, and there will be tachycardia. Dry mouth, delirium, hyperthermia, agitation, tachycardia, and there will be the features of urinary retention, and there will be accommodation will be lost. That's why we use this atropine in a case of dilatation of the pupil, and mostly, especially in a case of children's, we need very powerful dilatation, and that is being done by this atropines. Okay, and for treat this atropine poisoning, we already studied the drug we use. It is what? It is the physostigmine. Good, Dr. Anjali. We'll use what? We'll use physostigmine. Okay. Then we'll move on to the few drugs of anti-Parkinson and anti-Alzheimer's drugs. We saw already one anti-Alzheimer drugs, which is this donepezil, and we know donepezil, it is the drug of choice for Alzheimer's disease. Whereas for Parkinson, there are different drugs. For example, if it is a drug-induced Parkinsonism, we'll use these drugs like benzhexol, benztropine, and bipredin. Whereas in other cases, we'll combine with the levodopa. Whereas in a case of drug-induced Parkinsonism, we'll use benztropine, benzhexol, and bipredin. Okay, whereas in rest cases, we'll use levodopa and with other combinations. Okay, because we know Parkinsonism, it is due to the decreased level of dopamine. फिर उसके बाद आते हैं Alzheimer's disease. We know Alzheimer's disease, it is due to the deficiency of acetylcholine. तो हम क्या करेंगे? If we inhibit this enzyme, then we'll increase the level of acetylcholine in the blood. और हमें पता है कि quaternary amines, they won't cross, so we need to use tertiary amines. So we'll use this drug, which is known as what? Donepezil. And other drugs like rivastigmine, galantamine, and we recently introduced one antibody, which is this adacanumab. Remember, it is adacanumab. So it is used for Alzheimer's disease. And this drug, as I told you, there is one more drug which is used in case of Alzheimer's. It is what it is? Memantine, which is an NMDA receptor blocker. It is used in a case of Alzheimer's disease. Fine? Yeah, good Dr. Anjali, good Dr. Mohammad Anash, good. Well, you are following the pace, you are getting this correct. Just keep this Josh alive. Okay, just a few more time will be done. I think like after taking this pharmacology post lunch, it will be a bit hazy. You'll be feeling somewhat sleepy, but it's okay. But try to be connected with it, try to text it. I'll try to read it out, because once you tell the answers, you will get the motivations to go on. Because if you keep your answers inside, in exams also, you will keep your answers inside. Once you express it, you will have this click. Yeah, I told this. That's why this is the answer. Okay, so make sure you are telling it out, you are reaching it out, and make sure it is interacting. Yeah, it is. Yeah, mostly I will write like, but mostly the names will be, it is already written here. So this Parkinsonism, just remember, in usual scenario will use levodopa. Okay. So mostly the drug names it is written, and few drugs I will be writing. So don't worry, I will write it up. Okay, don't have any things. Okay, if any, please reach me out. I will help you out. Okay. Right. Next, about this receptor comparison. If you see about this adrenaline will act on most of the receptors like alpha 1, beta 1, and beta 2. Okay, so their net effect is what? It is the increase in heart rate. Whereas noradrenaline, if you see, it will increases the mean BP, whereas their net effect on heart rate will be low. So that's why if there is any decrease in BP, if there is any prolonged decrease in BP, then we'll use noradrenaline. Okay, and we know if we need to increase this BP, along with that we need to increase the heart rate. In a case of like during CPR, then we'll use adrenaline. Okay, isoprenaline will be having no or less effect on this mean BP, whereas it will increase this heart rate to a maximum extent because of this beta 1 stimulation. Bas, like just keep this thing in mind. फिर उसके बाद आते हैं adrenaline. Sorry. In adrenaline we know it is used in different types of shocks. One is the cardiac shock. In cardiac shock, mostly we'll secure the IV line and we'll give them in IV with a concentration of 1:10,000. Whereas in a case of anaphylactic shock, for example, there is a swarm of bees which has bitten, leading to this anaphylactic shock. So in such conditions, we'll give either subcutaneous or IM with a ratio of 1:1000. In a ratio of 1:1000, and this is how we usually do. Whereas in some special situations, we can give this adrenaline even endotracheal route as well. Okay, so there is this cardiac arrest will give IM, whereas anaphylactic shock will give means in cardiac will give IV, in anaphylactic shock will give IM. Okay, and in a case of brittle asthma, how will you give? Yeah, guys. In a case of brittle asthma, you will give in a subcutaneously. So we'll call them as EpiPen. Okay, EpiPen. So in brittle asthma, we'll give subcutaneous. And about this noradrenaline, as I told you, it will increase the BP or it will maintain the BP, okay, without increasing the heart rate. So noradrenaline is used as a drug of choice for septic shock. And dopamine, there will be a different receptor involvement. See, there will be involvement of this D1 receptor, beta 1 receptor and alpha 1 receptor. And because of this D1 receptor, then it can cause this diuresis. So because it can cause diuresis, so it is one of the drug of choice for cardiogenic shock, and which is presenting with oliguria. So cardiogenic shock plus oliguria, the drug of choice is dopamine, whereas noradrenaline is used for septic shock, whereas cardiogenic shock it is adrenaline, and anaphylactic shock also adrenaline. Just remember. Yeah, good. Next, about this dobutamine, it is used in a case of congestive heart failure. Dobutamine, it is used as an to increase the inotropic action of the heart. So see, so to increase this inotropic action or to increase this contraction of this heart, what we'll use this dobutamine because of this beta 1 stimulation. Okay, फिर उसके बाद we'll see this reaction which is known as vasomotor reversal of Dale. So if you see, normally usually this is the normal BP. So if there is this adrenaline, like if there is any noradrenaline which is being secreted from this pheochromocytomas, then what will happen is this will go and stimulate and will cause hypertension. If you just give alpha blockers, it will drop down the BP to this level. Whereas we know if we give this alpha blocker along with this beta blocker in a case of noradrenaline secreting pheochromocytoma, means normally the BP is this, and in pheochromocytoma there will be increased in BP, and when you give this alpha blocker, the BP will drop. The BP will drop initially, but if you give more beta blocker as well, then what will happen is that it will cause more hypotension. Remember, this is known as vasomotor reversal of Dale. Okay, just remember, it is most commonly seen in a case of pheochromocytoma. Yeah, there is this unopposed fall of BP. That's good, Dr. Shanaska. Next, about this beta 2 agonist. If you see about this beta 2 agonist, there will be like what? They are this bronchodilators usually used in a case of asthma. And we know there are this SABA, LABA, means they are this short acting and the long acting. And SABA, it is a short acting which act for less than 4 hours. They includes this salbutamol, okay, salbutamol and terbutaline. And LABA, it includes salmeterol and formoterol. So meterol will be used in a case of, they are classified as the case of long acting beta agonist, whereas SABA, it is used in asthma. It is a what? It is a very short acting. A good, Dr. Anjali, Ansh and Shanvas Khan. A good, well tried. Fine. Next, the side effects of this beta 2 agonist, which includes tremor, tachycardia, hypokalemia, and these are this main one. Like for example, if there is a chronic usage of this beta 2, there will be stimulation of this beta 2 receptors leading to tremors, and there will be some extent of this beta 1 stimulation leading to tachycardia, and also it causes this one of the significant side effect, which is this hypokalemia. That's why we can use in a case of hyperkalemia. What we'll do, we'll give salbutamol nebulization. We know in a case of hyperkalemia, we can use one more drug, which is this insulin. Okay, we can give insulin, which causes shifting of this potassium level from the blood to the cell. The same wise, this salbutamol, what it will does, this salbutamol, it will put the potassium into the cells. So that is why it causes hypokalemia. So it is tremors, tachycardia, like palpitations, and hypokalemia. And next, there is this beta 2 agonist, which are being used as tocolytic agents, means During a preterm labor, imagine the labor should start after more than 36 weeks. But if the labor or this labor pains start before that, then the baby will not mature yet. Means especially the lungs are not matured yet. So we need some time to make this lung to be matured with steroids. So in such cases, we'll give this tocolytic drugs. These tocolytic drugs which include ritodrine and isosporin. Ritodrine and isosporin. Just remember these two drugs. Next, about this blood drugs. If you see, you need to remember these two drugs, heparin and warfarin. You know, heparin we cannot give in oral route. Mostly we'll give in IV, or like mostly we'll give in a race of subcutaneous route and sometimes in IV route. Okay, so this heparin one, it acts by activation of this antithrombin 3. Okay, it's an anticoagulant. Whereas warfarin, it inhibits this gamma carboxylation of 2,7,9,10. It inhibits this gamma carboxylation of 2,7,9,10. So it will inhibit this vitamin K. Next, for this heparin, what it will do is that this heparin we need to test. For example, you have given a patient for heparin, but you need to monitor them, right? Like whether you are giving this adequate amount or you are given more than that, or the T-half you are giving or the maintenance dose you are giving is more or what. So in such cases, you need to know about this monitoring. You need to do tests. So remember, WEPT, W-E-P-T. Warfarin, it acts on this extrinsic pathway which is mainly involved, and it will be measured using the PT. That is, the PT will measure using for warfarin, whereas this PTT or APTT will use for this heparin. APTT will use for this heparin, fine, and it is for this short-term use because we are using in subcutaneous route, right? It is used for short-term use, whereas this can be used for a long-term. That's why in the case of any metallic wall patients, then we'll prefer warfarin than heparin. Fine. Then about we have its antidote for this. It is the protamine sulfate, and the antidote for the warfarin, it is what it is vitamin K. Okay, but the main game-changing effect is this. This heparin can crosses placenta and can cause heparin-induced thrombocytopenia and bleeding. And one more thing is that this heparin, it won't cause any defects. Okay, it won't cause any defects during this pregnancy. So that's why in the case of anticoagulants in pregnancy, for first few weeks we'll give heparin. Okay, then after that we'll shift to warfarin, because for first trimester this warfarin will cause incubation in this organogenesis. Then around the delivery, around 36 weeks, we'll again shift to heparin. Okay, again shift to heparin. Fine. Then about this low molecular weight heparin. This low molecular weight heparin, that is the modified form of the heparin, which is incubits this factor 10A more than the factor 2A. Fine. And fondoxpiranos, it will just incubate the 10A. Means so that how much less it is incubating, that much less is the side effect. Fine. Yeah. INR, VAR. Like, so remember, we can use one more thing which is known as what? Yeah. For this money, there is a war which is going on. So remember, this PT, it is one more centralized form which is known as what? International normalized ratio. So international normalized ratio, which we'll commonly use to compare between these two labs, whether the lab volumes were adequate or not. So warfarin will use PT and INR. Fine. And as I told you, warfarin we won't prefer during the time of organogenesis. So it will be contraindicated in this first few trimesters of pregnancy. Okay, so because it is teratogenic, it will cause this one more syndrome as a side effect, which is known as purple toe syndrome. It will cause purple toe syndrome, and means in a case of acute bleeding, for example, in a case of acute bleeding, we won't prefer warfarin, because in a case of acute bleeding, what will happen is that warfarin will take some time to go and incubate this gamma carboxylation. So in a case of acute episodes, we use subcutaneous heparins or low molecular weight heparins. Okay, in long-term management, we'll use warfarin. Okay, I guess you got it, guys. Do you have any doubt? Do you have any doubt, guys? Yeah, what is the doubt? If you have any doubts, yeah, okay, good, okay, good, Ansh, good, yeah, okay, Shanamaskan, yeah, good, well, I guess things are clear. Okay, if you have any doubts, please put up in the chat box. We'll take up in the middle, or else we'll take up in the end of our session. Okay. Then about the new generation drugs. These new generation drugs, they are known as what direct acting oral anticoagulants. There are few they are oral, but there are few drugs which are oral in nature, whereas few drugs they are taken IV. For example, in the case of direct thrombin inhibitors like dabigatran, it can be taken orally. So remember, it is the dabigatran, it is the direct thrombin inhibitors. Okay, and some of them they are used in a case of heparin induced thrombocytopenia, which include lepirudin and argatroban. Okay, lepirudin and argatroban. They will ask you which of the following is the only oral direct thrombin inhibitors. The answer is what? It is the dabigatran. It is the dabigatran. It is the dabigatran. Okay, and yeah, the 𝗵𝗵𝗀𝗀. Okay, fine. Then, if you see this antidote, sometimes there can be this scenario there this anticoagulant action has been overwhelmed. In such cases, we will use this antidote, which is this 𝗬𝗏𝗏𝗏. So remember, it is the 𝗬𝗏𝗏𝗏. So dabigatran, 𝗬𝗏𝗏𝗏. Dabigatran is the drug which we take orally, whereas it is will be incubated by this 𝗬𝗏𝗏𝗏. Fine. And there is few more drugs. They are known as factor 10A inhibitors. Okay, factor 10 inhibitors. So whatever the 10 inhibitors, their name will be having this XA. So it is rivaroxaban and apixaban. They are this factor 10A inhibitors. Factor 10A inhibitors. And antidote of this factor 10 inhibitors, they include this andexanate alpha. Here this antidote also will be having this XA. So andexanate alpha, it is the antidote of this factor 10A inhibitors. Fine. And in the case of atrial fibrillation, we prefer less using of this newly added anticoagulants, whereas mostly we'll use what? We'll use this warfarin. We'll use this warfarin for preventing the formation of clots. Fine. And if there is a clot formation, like in the case of MI, previously we used to do a thing which is known as clot lysis. For that, we'll use this fibrinolytic drugs. Previously, we used to use these drugs like streptokinase, but now it is being replaced by this drug which is known as alteplase and alteplase. These are this tissue plasminogen. These are the tissue plasminogen activators, and this tissue plasminogen activators, they will activate the plasminogen and they will lyse the clot. Okay, this includes this reticulase and alteplase. Okay, these are the true drugs. A good Dr. Puneet and a good Dr. Anjali. Yeah, good. Fine. Next, if you see about this anti-hypersensitive drugs, mostly they will ask in which condition or in which condition which drug you will use, or in this clinical scenario of a patient who is presenting with features of hypertensive emergency. Okay, hypertensive emergency means when you will describe it as hypertensive emergency. Hypertensive emergency means when there is an end organ injury is present. It is known as what? It is known as hypertensive emergency. And in the case of hypertensive emergency, what we'll use? We'll use this 𝗏𝐶ardipine. We'll use 𝗏𝐶ardipine. We'll use this 𝗏𝐶ardipine. Whereas in the case of subarachnoid hemorrhages, which is due to this hypertension part, we'll use 𝗏𝐵𝐴dipine. We'll use 𝗏𝐵𝐴dipine. So remember, hypertensive emergency, we'll use 𝗏𝐶ardipine, whereas subarachnoid hemorrhages, in the case of hypertension, we'll be using this 𝗏𝐵𝐴dipine. फिर उसके बाद आते हैं hypertension with BPH. You know, benign prostatic hyperplasia, उसमें हम क्या देंगे? हम देंगे terazosin. Okay, we'll give this terazosin. Okay, they are what? They are this alpha-1 blockers. We'll give terazosin. फिर उसके बाद hypertension in pregnancy. If just this hypertension in pregnancy, we'll use labetalol. कौन सा labetalol? We use oral labetalol. Okay, more than methyl dopa, because क्योंकि हमें पता है methyl dopa will cause a condition which is known as autoimmune hemolytic anemia. So we'll use what? We'll use labetalol. फिर उसके बाद आते हैं हाइपरटेंसिव इमरजेंसी इन प्रेगनेंसी में इमरजेंसी तक क्या यूज करेंगे? लाइक इन केस ऑफ इमरजेंसी इन प्रेगनेंसी विल यूज द सेम labetalol, but we'll use this labetalol in IV form. So it is IV labetalol will use. And if there is nothing, all of these drugs are 2 to 3 drugs combinations you tried, even on diuretics also you tried, but it is not residing. It is known as resistant hypertension. So in the case of resistant hypertension, you use spironolactone. Yeah, good Dr. Ansh, good Dr. Puneet. We use what? We use spironolactone. Good, well said. Then if there is a patient who is presenting with this hypertension, CKD and diabetes mellitus, if there is any hypertension along with this kidney involvement and diabetes mellitus, then the patients will give them AC inhibitors and ARB. Okay, angiotensin converting enzyme inhibitors and angiotensin receptor blockers. These are the two drugs we'll use in a case of diabetes along with this kidney damage or if there is any nephropathy. Okay. Next about this diuretics. I don't know why they love asking about this diuretics. Okay, and they love asking about this part of nephrons. If you see, initially this is the glomerulus part. Next one, it is the PCT. Around the PCT will be this release of bicarbonate, and we'll use this enzyme which is known as carbonic anhydrase, which helps in the breakdown of this sodium bicarbonate. So this incubators mostly they will act on this PCT. And next on the loop we have this sodium potassium 2 chloride pump. And the sodium potassium 2 chloride pump, it will be used in the loop of Henle. And if we block this pump, it will be what? It will be the loop diuretics. Okay, loop diuretics. Yeah, good. Dr. 𝗧𝗵𝗶𝘀, Dr. 𝗵𝗵𝗿𝗺, yeah. Yeah, good. Yeah, Dr. Puneet said, like in Jan 2023, it was a simple questions. They just put an arrow into the DCT and they asked, like they put an arrow and they asked which of the following diuretics they will ask. Okay, or which of the following diuretics will act here. So it is commonly repeated. So don't forget to study this image along with these concepts and along with the drugs and their side effects. Just see these things because it will give you more than 1 mark. Okay, fine. So loop diuretics, it will block at the level of sodium potassium 2 chloride pump. Fine. And next one, it is the thiazide diuretics, and thiazide diuretics will be acting on the DCT, distal converter tubules. And in the case of potassium sparing diuretics and aldosterone receptor blockers and ENaC inhibitors, all of them they will be acting at the level of collecting duct. And there is one more drug which is known as what? Osmotic diuretics. This osmotic diuretics mainly they act on this PCT and loop of Henle. It will be act on this PCT and loop of Henle. Yeah guys, correct. Good. Okay, so if you see first image, it is carbonic anhydrase incubators which is being act around this PCT. And we know this carbonic anhydrase incubators like acetozolamide, and we know this acetozolamide, it is the drug of choice for which sickness? Motion sickness? No, it is the drug of choice for this mountain sickness. It is the drug of choice for this mountain sickness, and it can be used in a case of glaucoma. Yeah, good, Dr. Shanavas Khan. Yeah, good, Dr. Puneet. Yeah, fine. Next about this osmotic diuretics. In case of this osmotic diuretics, what they will do, they will catch up this water. They will pull out this water. The example of this osmotic diuretics, it is what? It is the mannitol. And mannitol, it is used in a case of cerebral edema and acute congestive glaucoma. Means when there is this condition which is known as acute congestive glaucoma or angle closure glaucoma, in such condition there will be rapid increase in the pressure. So in such conditions, to decrease the pressure, we'll use this mannitol. ठीक है, फिर उसके बाद आगे चलते हैं loop of Henle. This loop of Henle will use this diuretics which blocks this sodium potassium 2 chloride pump, and we know this loop diuretics, they are known as high ceiling diuretics because they cause this maximum water loss. That's why we use them in a case of congestive heart failure to relieve this pulmonary edema. तो pulmonary edema को relieve करने के लिए हम क्या यूज करेंगे? Loop diuretics यूज कर लेंगे. और ये भी याद रखना कि loop loses calcium, so we'll avoid them in this calcium stones formations. Yeah, good. The example of this, it is the furosemide. Good, Dr. Shanavas, Anjali, and Ayushi. Good, well said. Right. Next, if you see the DCT, this distal converter tubule, there will be the thiazide diuretics will work. Okay, they will block this sodium chloride importer, and thiazide diuretics, it is one of the important diuretics. Why? If they ask you in the case of initial management of hypertension, what is the drug you will give? It is the thiazides, and there are these thiazides. You can read by this name which is known as chlorthiazide. There will be written thiazide only, but there are two drugs. They are not written thiazide in it, but they are actually thiazides. So remember, it is indapamide and metolazone. Remember this metolazone, it is effective even in renal failure. Okay? Effective even in renal failure. So they will ask you, which of the following diuretics you will prefer to use in a case of renal failure? उसमें हमें बोला कि metolazone, because in the case of chronic renal diseases we avoid using the diuretics, whereas in the case of thiazide diuretics they ask you need to tell metolazone where can be used in a case of renal diseases. Okay, and as I told you, this is used in a case of hypertension, and this saves the calcium. So it won't cause urinary excretion of calcium, so we can use in a case of calcium stones, and we can use them in a case of diabetes insipidus. We can use them in a case of diabetes insipidus, and as the saves calcium, they can be used in a case of osteoporosis. Osteoporosis में भी हम use कर सकते हैं इसको thiazide को. Okay, yeah. One of this absolute concentration is the gout and hyperuricemia. Because the thiazide, what it will do, it will increase the uric acid level and it will cause decrease in the value of this all other electrolytes. So since it causes increase in the uric acid levels, we'll avoid using them in a case of gout. Okay? Then about this collecting duct, there will be this potassium sparing diuretics. If you see all of them, this LH like loop diuretics and thiazide diuretics, both of them, they will be losing the potassium. So we need a drug if the patient is already in hypokalemia, but if you lose more potassium, the patient will be more hypokalemic. So in such scenarios, you need to use this potassium sparing diuretics like aldosterons, okay, and like spironolactone and epinephrine, okay. And there will be this some more drugs which are known as epithelial sodium channel blockers. And this epithelial sodium channel blockers, which include triamterene and amloride. Remember about this amloride. This amloride, it is used for the drug of choice for lithium-induced diabetes insipidus. Usually, thiazides are the drug of choice for the diabetes insipidus, whereas amloride, it is used for the management of this lithium-induced diabetes insipidus. Remember, and we know this spironolactone. This spironolactone, which is actually which is this aldosterone receptor antagonist, they'll be having this side effect of gynecomastia. We studied in the morning, there is a syndrome which will be having this gynecomastia as a clinical feature. What is the name of the syndrome, guys? Yeah, spironolactone, it is associated with this disco drugs. Yeah, good. Yeah, that is correct. So what is the name of the syndrome which is associated with the gynecomastia? It is what? It is the Klinefelter syndrome. It is the good, guys. It is the Klinefelter syndrome. Good, Diana. You have this strong memory power. Like it is the Klinefelter syndrome. Like yeah, good, Dr. Ansh. Yeah, good. Shanvaskan, Trisha. Yeah, well. Very well. Okay, see. So in a case of Klinefelter syndrome, you will be able to see what? You will be able to see this feature of gynecomastia. Fine. And to prevent this in males, will give epinephrine. And this is the drug of choice which we use in a case of cirrhosis induced congestive heart failure and Cone syndrome. Cirrhosis and Cone syndrome will use epinephrine. Okay. Then about this ACE ARB inhibitors. We know this ACE and ARB will use in a case of hypertension along with diabetes mellitus and along with the renal dysfunction. Okay, along with this renal dysfunction. Hello, this 𝗵𝗵𝗀𝗀, like the topics which we have already covering, which is already available in our Telegram group. You can just check the link below, you will get it. Okay. Yeah, good, Dr. Ansh. It is what it is, the hypertension, diabetes mellitus and renal dysfunction. Yeah, good. Well said, Dr. Puneet. Yeah, CAP2 and linso, they are programmed. Yeah, that's true. Yeah, good, Dr. Shanavaska. Fine. Next, this AC inhibitors. Remember, this AC inhibitors will be ending with this names as prils. Captopril, linsopril and enalapril. We know this captopril, it is what it is, the capto and linso, they are the prodrugs. And as I told, they are the drug of choice for hypertension in case of diabetes mellitus and in a case of chronic kidney disease. Okay. And this will be having these few side effects. There are few side effects which include this. AC inhibitors will be having this maximum side effects, which include this angioedema, cough, which is a dry cough, which is most common one, associated with this angioedema, and along with this taste alteration, which is known as dysgeusia. And this captopril will be having a specific feature or specific or maximum chances of postural hypotension. And this AC inhibitors and ARB inhibitors, they are contraindicated. Especially this AC inhibitors, they are contracted in the case of bilateral renal artery stenosis. So in the case of bilateral renal artery stenosis, AC inhibitors are contraindicated. And remember, this AC inhibitors and ARB inhibitors, both of them, they cause hyperkalemia. Whereas as I told you, salbutamol causes hypokalemia. Itna yad rakho. Then ARBs, they will be having this name as statins. Especially this telmisartan, which is being widely used now because it will be having a function of PPR gamma agonist, and it can even reverse this insulin resistance. That's why in a case of ARB, which we want to use in a case of diabetes patients, we are preferring telmisartan. Fine. Yeah, good Dr. Mohammed and good Dr. Anjali. Good, well said. Good Dr. Puneet and Shabazka. Right? Then about this management at the congestive heart failure. In the case of congestive heart failure, we'll tell them it is a congestive heart failure if the ejection fraction is less than 60%. And there will be two types. One is decompensated, means initial phases are also known as acute congestive heart failure. This is known as decompensated congestive heart failure, where the ejection fraction will be less than 40%. Okay. Whereas in a case of compensated or chronic congestive heart failure, the ejection fraction will be less than 60, but it will be more than 40%. Okay, bas itna yaad rakhna. And here, in a case of congestive heart failure, what are the drugs we'll use? In a case of acute congestive heart failure, it occurred acutely. So it will, what will do? The heart is unable to pump. So it will reflex back its blood. Where it will reflex back? It will reflex back into its lungs. Agar ye lungs mein reflex kar raha, then lungs mein ज़्यादा पानी भरेगा, and there will be more water into the lungs. अगर if there is more water into the lungs, हमें क्या करना होगा? We need to remove the water by using the furosemide. So we'll use furosemide to decrease the fluid. Okay. Then we need to help the heart to pump more. So we'll increase this inotropes. For example, the inotropes include this 𝗏𝗏𝗏. We told, right, 𝗏𝗏𝗏 will, it is an inotrope which causes increased contraction. Fine. And we can use one more drug which is an ionodilators, which cause constriction of the heart as well as it will dilate the vessels and decrease the pressure. So this is the management in a case of CHF, which is in acute stage or decompensated stage. Fine. Whereas in a case of chronic congestive heart failure, there our approach is very different. Here means the heart is exposed to very long, so it will be adapted to it. In such scenarios, what we need to do is we need to decrease the blood volume or decrease the blood pressure. So in such cases, to decrease this venous return, what we'll do, or to decrease this arterial pool, what we'll do, we'll use this dilators like nitrates, hydralazine, and AC and ARBs. Okay, and AC ARBs, especially this nitrates and hydralazines, they will cause dilatations of the vessels and it will decrease the work. And to decrease the fluid, as usual, we'll use what? We'll use the diuretics and decrease the left ventricular hypertrophy. Because of this long-term pushing, this can lead to this left ventricular hypertrophy. So to prevent this remodeling of this heart, we'll use few drugs like beta blockers, carvedilol, metoprolol, and bisoprolol. Okay, it is what it is, the carvedilol, metoprolol, and bisoprolol. Carvedilol, metoprolol, and bisoprolol. Just remember all these drugs. Fine. And there are a few more drugs which decreases the motility, which include sacubitril. They are this A, B drugs like AC inhibitors, ARBs, beta blockers, and 𝗵𝗵𝗶𝗀. 𝗵𝗵𝗶𝗀, it will decreases this contraction points. Right? And the only one diuretics which we use here, it is the spironolactone. That is the spironolactone. And so as we see here, this beta blockers, it will be used in a case of chronic congestive heart failure, whereas it is contraindicated in a case of acute congestive heart failure. बस इतना याद रखना. In acute हमें क्या करना है? हमें blood का volume को कम करना, तो we'll use diuretics. और एडिमा को भी कम करना, तो देन विल यूज डायरेटिक्स. उसके साथ साथ हमें हार्ट का पंप करने का मतलब एनर्जी को बढ़ाना, तो विल इंक्रीज द आइनोट्रोपिक एक्शन बाय गिविंग 𝗏𝗏𝗏. whereas in a case of chronic or compensated congestive heart failure में हमें क्या क्या करना होगा? We need to decrease the preload and afterload, so we'll give this dilators like nitrates and hydralazines. फिर उसके बाद then we need to decrease the fluid, then we'll give what? We'll give the diuretics. फिर उसके बाद क्या करना? We need to decrease this left ventricular hypertrophy or remodeling. तो तभी हम क्या करेंगे? We'll give this carvedilol, metoprolol, and bisoprolol. फिर उसके बाद उसके साथ साथ we'll give this drugs which also decreases this remodeling and decreases the motility, which includes sacubitril, beta blockers, 𝗵𝗵𝗏𝗏, and spironolactone. 𝗵𝗵𝗏𝗏 and spironolactone. Yeah, 𝗵𝗵𝗏𝗏𝗏, these are these drugs which we use as a selective beta blockers for this hearts. Right? Next about this classification of antiarrhythmic drugs. So you know this mnemonic, I guess, right? So beautiful Priyanka Chopra. So it is what it is. This so beautiful Priyanka Chopra. Just give me a second. So it is what it is. This so beautiful Priyanka Chopra. So if you see this thing, then the class 1, they are this sodium channel blockers. Okay, and this class 1, they are classified into 3 more classes. It is class 1A, 1B and 1C. How they are classified? It is based on this potassium channel action. So if the potassium channel is getting blocked, it will be seen in a case of 1A. Okay, it is seen in a case of 1A. And because of this potassium channel blocking, it will lead to this QT prolongation, which is known as what? Which is known as 𝗧𝗵𝗶𝗀𝗀𝗃, which is known as 𝗧𝗵𝗶𝗃. And the drugs which include or which comes under this classification of 1A, it includes this procainamide and quinidine. It includes procainamide and quinidine. Next one, it is the 1B. 1B, it opens the potassium channel. It includes lidocaine and phenytoin. It includes this lidocaine and phenytoin. Yeah, good guys. In the case of 𝗧𝗵𝗶𝗃𝗀, we'll use, to treat this, we'll use magnesium sulfate. We'll use this magnesium sulfate. Okay? फिर उसके बाद 1C, it is the flecainide. Flecainide will use in the case of Ŵlff-Parkinson syndrome. Then about beautiful, we'll use this beta blockers, which are classified as class 2, whereas 3, but is P for Priyanka, it is the potassium channel blocker. As I told you, there also will be this 𝗧𝗪𝗏, where we can use this MGSFR, and the main potassium channel blocker, it is what? It is this amiodarone. And if there is a long-term use of this amiodarone, it leads to this blue man syndrome. Yeah, good Dr. Puneet, it leads to this blue man syndrome. Good Dr. Shanavas Khan, Dr. Puneet. Then about this Chopra, it is this calcium channel blockers, which is especially this L type of calcium channel blockers. This includes 𝗵𝗵𝗶𝗀, which is used as a prophylactic for this PSVT. So as the Priyanka Chopra is very beautiful, or so beautiful Priyanka Chopra, it will be having additional guys who will be roaming as a security. So we have this class 5 drugs. This includes this digoxin, atropine and adenosine. Digoxin is used for this atrial fibrillation in a case of patients with congestive heart failure, and along with this atropine, it is used for this bradycardia and AV block, whereas adenosine, it is used for this treatment or this acute management of this PSVT. Whereas for this prophylaxis of this PSVT, which drug will you use, guys? The same adenosine? No, we'll use 𝗵𝗵𝗶. Good guys. Good Shanavaska. Don't get confused, Ansh. Fine. Next, about the statins. We know the statin drugs. Yesterday also we saw in biochemistry this FMGE reductase inhibitors. What are they? They are the statins. So FMGE synthase, it helps in the formation or the synthesis of ketone bodies, whereas FMGE reductase, it helps in the formation of cholesterol synthesis. And if you incubate this process, then there will be decreased level of this cholesterol. Yeah, good Dr. Ansh, good Dr. Shanavaska. Yeah, good Dr. Puneet. Yeah, fine. So it is what? So it is the statin. So statins will incubate this FMGE reductase inhibitors. Next, the examples of the statins will be having the statins in their name. This include lovastatin, rosuvastatin, pravastatin and simvastatin. And the mechanism, as I told you, it will incubate FMGE reductase inhibitor. Yeah, the rosuvastatin, it is the longest acting. And their main purpose is to decrease this bad cholesterol, which is this decreasing the LDL. Then we have one more drug which is known as fibrates, and fibrates which will mainly used for the decreasing the triglyceride levels, to decrease the triglyceride levels. Okay, and fibrates include this fenofibrate and clofibrate, and along with this, it will decrease the triglyceride levels, and the mechanism of action is PPAR alpha inhibition. We know this PPAR gamma inhibition will be seen in a case of telmisartan, whereas here it is PPAR alpha will be seen in a case of fibrates. ठीक है, याद रखो. हाँ बिल्कुल, लवर को रोज दोगे तो रोजुवास्टाटिन दोगे तो लॉन्ग चलेगा. बस बढ़िया. Good Dr. Shanavas Khan. अच्छा है. Then if you see this drug which is this niacin increases this good cholesterol, which is this HDL, and we have few new more drugs. For example, bile acid sequestrants. We know this bile acid, it helps in the absorption of these fat particles. If we give these drugs against them, then it will decrease the absorption of cholesterol. This include cholestyramine, cholestyramine and cholestyramine. Okay, this include this cholestyramine, cholestyramine and cholestyramine. Okay, just remember, it is this cholestyramine, cholestyramine and cholestyramine. Next, about this next drug, which is this 𝗧𝗵𝗶𝗀𝗃. What will happen is that with the help of bile it will absorb, but without it also it can get absorbed. But this 𝗧𝗵𝗶𝗀, it will prevent this intestinal cholesterol absorption. Okay, intestinal cholesterol absorption it will prevent. So if there is no intestinal absorption, then obviously the level of the LDL will be decreased. So there will be a decrease in the LDL. Okay, फिर उसके बाद आते हैं PCSK blockers. PCSK blockers, they are recent advantage. They are this monoclonal antibodies like 𝗵𝗶𝗀𝗀𝗀𝗃 and 𝗵𝗲𝗀𝗀𝗀𝗃. 𝗵𝗶𝗀𝗀𝗀𝗀 and 𝗵𝗲𝗀𝗀𝗀𝗃. फिर उसके बाद this PCSK9 inhibitors, what they will do? They will increase the LDL receptors. Q? Because what they will do, these are the antibodies and they will go and bind to the LDL. So if they go and bind, means there will be decrease in LDL. So the body will think there is no one is binding or there is no place to bind. So it will produce more of the receptor. So they will increase the LDL receptors to bind. Okay. Just itna yaad rakhna. Then we'll move into these drugs which we use during this peptic ulcer disease. So this include the drugs which reduce the acid secretions or famous proton pump inhibitors like omeprazole, pantoprazole. Then H2 blockers like ranitidine and M1 blockers like pyrazipine and telanzipine. Then drugs to neutralize the acids like antacids like sodium bicarbonate, aluminum and magnesium bicarbonate. Sodium, aluminum and magnesium bicarbonate. Next one, this can occur due to the presence of infection like H. pylori. And H. pylori to treat will use this metronidazole, amoxicillin and clarithromycin. And about the next group of drugs, they are known as ulcer coating drugs. And this ulcer coating drugs which include this what? This include this sucralfate bismuth. Means they will just coat the ulcer and they will prevent from the injury from the acid. So it is this sucralfate and bismuth. And as I told you, this omeprazole and lansoprazole, they are actually what? They are this PPI. Yeah, we can use this triple therapy which includes this antibiotics like amoxicillin along with this PPI like omeprazole or pantoprazole, then this sucralfate or bismuth. Fine. And omeprazole, it is a PPI and it is having a few side effects like if there is, it will decrease the absorption of calcium, so it will cause osteoporosis. At the same time, it will decrease the production of intrinsic factor, so it will decrease the vitamin B12 level and it increases the levels of infections. Okay, the three side effects. One is osteoporosis, decrease in vitamin B12 and increase in infections part. Okay, and drugs affecting the motility. Which motility? If you see about the esophagus, there are few conditions which occurs due to the relaxation of the sphincter. For example, our GERD, gastroesophageal reflux disease, which causing this Barrett's esophagus. So this GERD occurs because of this less tension or this relaxation of the sphincter. So if we give some drugs which causes this tightly adherence, like this is the relaxation. If we give some drug which causes this tightly adherence, then we can prevent this GERD. So these drugs include the Day-2 blockers, IST receptor antagonists. This much Pharma isn't enough for exam because it is difficult to remember drugs. Yeah, like this, you should means like Pharma it is difficult, but at least you should remember this much Pharma. Okay, this much Pharma it will give you more than half marks. Okay, first read this and along with this read your main notes and it will help you out. Okay, if you did not understand the concepts, but make sure you are at least reading this. If you don't read this and if you think it is difficult, obviously I will sign and give you it will be difficult. So start reading it and do something. Start reading it, just complete 2-3 revisions of this and do see your main videos and do solve PYQs. No, it will be done easily. So or else what you do, you just revise my PDF and evening go and solve some PYQs and come on tomorrow and tell me whether you will able to do your questions or not, whether you will able to get at least more than 60 to 70% of correct from the sessions itself. Okay, with simple revisions. So I guess this will be enough to means give an apprehension about these PYQs and the most important ones. Yeah, Punit, you said it correct. Okay. Yeah, no, that's also good, Dr. Shahnawaz Khan. Yeah, good. Yeah, fine. Then about this GERD, I told you, this includes this D2 receptor blockers, 5-HT3/4 receptor antagonists, and this motilin receptor. Yeah, Arjun will discuss about this at the end of the session. Just please have some patience. Okay, let me continue with this Pharma part. We'll finish it and we'll have all your doubt on clearing sessions. Just wait for another 30 minutes or 25 minutes. Fine. Next, if you see this receptor, it is this D2 blockers, 5-HT4 antagonist, 5-HT4 agonist, and motilin receptor agonist. This D2 blockers include metoclopramide and domperidone. Okay, metoclopramide and domperidone. If you see This metoclopramide, this can cross the blood-brain barrier and it can cause dystonia. Remember, which of the following antiemetic will cause dystonia? It is what? It is the metoclopramide. And doperidone, it is used in the vomiting in the case of levodopa induced vomiting. We know this levodopa, it is used in the case of Parkinsonism. So in such cases we'll use this. Fine. And next, it is 5-HT4 agonist like cisapride, mosapride and renazapride. These are used in the case of GRD to prevent this motility. Okay. Next, in motilin receptor agonists, like for example erythromycin. If you take up this erythromycin, it will increase the motility. So this increases the motility of these drugs. And about this vomiting drugs, usually we know this one vomiting drug, which is what, which is ondansetron, which is this 5-HT3 receptors, like which is this serotonin blockers, which is this ondansetron. And it is used in a case of yearly treatment for this chemotherapy induced vomiting. Okay, there will be this yearly treatment of this chemotherapy induced vomiting. And whereas for delayed, we need to use this substance P agonist like aprepitant. Okay, substance P agonist like aprepitant. Fine. So there will be, in a case of chemotherapy, there will be side effects. One of the most common side effects, it is what? It is the vomiting. So if this vomiting occurs within 24 hours, it is called, it is the yearly. So it is due to the ondansetron. If it is occurs after 24 hours, we'll call them as delayed vomiting. In such cases, we'll use aprepitant. Okay, fine. Then if you see, there are the drugs which we use for this constipation. Either will make the stool to be bulk. For example, the fibers will give them like fibers, bran, methylcellulose. These are this drugs which will improvise their fiber content of the stool. Next, from the osmotic agents, how we saw this mannitol, right? It will pull the water. It will pull the water so that the stool won't be hard. It will be softer in nature. This improves our lactulose. Then about this surfactant, it will soften the stool. It will soften the stool like docosahexaene sodium, calcium, and mineral oil and liquid paraffin. All of this, it will soften the things. Whereas we use some more thing which are known as stimulants, which include biscodyl, senna, and cascara. And one of this thing which causes this side effect, which is known as what? Melanosis coli. Can anyone tell me which of the following stimulant constipations drug which causes this melanosis coli? Yeah guys, yeah, waiting for your answers. It is what? It is the senna. So if there is any over usage of the senna, then what will happen? This will lead to this type of side effect, which causes this blackish pigmentation over the colon, which is known as what? Which is known as melanosis coli. Good Dr. Ansh and good Dr. Shanvaska. Fine. And next, we'll see what are the drugs which we use in a case of osteoporosis. You know, the osteoporosis, there are multiple kind of drugs which we use, but whatever the case of osteoporosis might be, the drug of choice is what? The drug of choice is bisphosphonate, like alendronate. And we know this bisphosphonates are these drugs, they will cause what? They will cause this maximum esophagitis. So what we'll tell, once you take this drug, we'll tell the patient to sit straight for 30 minutes, then go and lay down. Okay. If we use this type of bisphosphonates, like injectable type of bisphosphonates for a longer time, it will cause this type of mandibular degeneration or mandibular necrosis. Okay, causes this necrosis over this mandibular region. Okay, then as I told you, it is the drug of choice for osteoporosis and it is a drug of choice for hypercalcemia due to malignancies, and it is also drug of choice for this Paget's disease. Okay, then we have few more drugs which are used in a case of osteoporosis, but they serve as a different purposes. For example, if you see about this teriparatide, what will do? There is two phenomena. There is this osteoblast which form this bone. There is osteoclast which reabsorb the bones. This teriparatide, it will stimulate this osteoblast and it will bring the calcium and it will make the bone stronger. Okay, that is the teriparatide work. Whereas strontium ranelate, if you see, it will be acting in both things. It will increase the bone formation and it will decrease the bone resorption by acting into the osteoclast. So they will ask you, which of the following drug will act on this both mechanisms? Yeah guys, what will be your answer? Your answer will be strontium ranelate. Fine. Next drug, which is this denosumab. If you see, as I told you, this osteoclast will be having a ligand which is known as what? Which is known as this rank ligand. So this denosumab, it is the antibody against this rank ligand. Next, there is one more antibodies or one more receptor which is known as sclerostin. So this antibody against this sclerostin, it is what? It is the 𝗵𝗵𝗀𝗀𝗧𝗵. So denosuzumab, it is the antibody against the rank ligand, whereas 𝗵𝗵𝗀𝗀𝗀𝗧𝗵, it is the antibody against the sclerostin. It is the antibody against the sclerostin. Next one, it is the 𝗓𝗏𝗪. 𝗓𝗏𝗪, it is now for the stimulation of this SR receptors. They are actually what? Calcium sensing receptors. So they will stimulate this calcium sensing receptors. Right? These are the drugs which you use for osteoporosis. So in this, you need to know first thing. You just remember all of these osteoporosis components. The drug will use, it is the bisphosphonates. Calcium phenolate, it will be used for both. It will be having this both mechanism, which is the bone formation and bone resorption. And teriparatide, it will stimulate the osteoblast. Whereas for rank ligand against the antibody, it is the denosumab. Whereas this sclerostin antibody, it is what? It is the 𝗵𝗵𝗀𝗀𝗀𝗧𝗵. 𝗵𝗵𝗀𝗀𝗀𝗀. Fine. And next we'll move on to this antihistaminic drugs. Fine. Then about this antihistaminic drugs. If you see about this antihistaminic drugs, there are different generations. Mostly they will rely into this. How will you differentiate, or what is the reason which we use first generation drugs, or what is the reason which we use this second generation drugs? We know this first generation drugs, they have the side effect of sedation because they cross the blood-brain barrier, and as a side effect, what they will do, they have the side effects of antiemetic. But in few conditions, we use this antiemetic side effect as a effect. So, for example, in the case of doxylamine, we'll use in the case of morning sickness. So, for this drug of choice for morning sickness, it is doxylamine, whereas drug of choice for mountain sickness. What is the drug of choice for mountain sickness, guys? Is it same doxylamine? No, it is what? It is the acetazolamide. So, morning sickness, it is the doxylamine, whereas mountain sickness, it is what? Acetazolamide. Well done, Anjali, Ansh, and Shanavas Khan. Well done, Patel. So it is what? It is the acetazolamide. Okay, remember. Next, there is the drug which is known as promethazine, and this promethazine, it is also used for this prevention of this motion sickness. Okay, promethazine also. Fine. We'll use this common drug which is the diphenhydramine for this cough. For this cough, it is what? It is this Benadryl, in the form of Benadryl, which is the diphenhydramine. Fine. And the second generation, they won't cross the blood-brain barrier, so they won't produce sedation. Okay, it's include the levocetirizine. लेकिन हमें levocetirizine खाने के बाद भी नींद आता है, और फार्मा पढ़ने भी वक्त भी नींद आता है. So whenever you read pharma, biochemistry, which is very hard subjects, then you will feel sleepy, and if you take levocetirizine, then also you will feel sleepy. But actually levocetirizine, it will not cause sedation. Okay, and we'll use this one more drug which is known as, which there is, I guess I told correct. Yeah, we'll use this one more drug which is known as hexofenaclin, which has a side effect of QT prolongation. And this second generation, they also used in a case of allergies or similar common cold. And there are few drugs which can be used in a case of Parkinson's. For example, our promethazine, they can be used in a case of drug-induced Parkinson's diseases. Fine. And mainly, but we'll use in a case of like benzoxole-bipyridamine. Okay. Next, about this migraine, there will be one question because it is interlinked with pharma and medicine. It is interlinked with pharma and medicine. So just remember. So this migraine drugs, initially, if it is mild migraine, she is complaining, sir, there is a headache, but I am able to bear it off. Then you try using the NSAIDs. But later on, if there is any acute episodes or very severe episodes, then you should use this proper drugs. What are the proper drugs you will use? The proper drugs you will use include the 5-HT1B1 receptor antagonist. Okay, wow, that's good, Dr. Mohammed Shanwaz Khan. That's good. Yeah. That is the split Shanwaz. Fine. If you see this drug, which is this 5-HT1B1 drugs, these are what? They are this triptans, like somatriptan. Okay, these are the somatriptan drugs and razitriptan. These are this drug which is used in a case of severe migraine and in a case of acute episode of migraine. So in a case of mild, we'll start with NSAIDs, whereas in a case of severe and acute episodes, we'll use this triptans, which is what? Which is this 5-HT1B1D receptor agonist. It is not antagonist, it is the agonist, because there will be, it will cause what? It will cause vasoconstriction or decreased blood supply to the cranial vessels, so that it will be relieved from this headache. Fine. And next, about this prophylaxis of this migraine, we can use this propranolol. We'll use this propranolol, and we can use this intranasal butorphanol. We can use this one more drug, which is the intranasal butorphanol. Fine. And new drugs which are in the market, they are known as lasmiditan, which is 5-HT1F receptor, and it will decrease this CGRP release. So if you can just remember this one drug, which is this lasmiditan. Then monoclonal antibiotics which is used here, it is the 𝗵𝗵𝗶𝗀. Fine. And there is a CGRP agonist, which is the 𝗧𝗵𝗶𝗀𝗃. Okay. This lasmiditan, 𝗵𝗵𝗶𝗀, and 𝗧𝗵𝗶. Okay. These are the drugs. Yeah. Last time this was the question, like what is the drug which will use for the prevention of the migraine? So agli bar they will ask some more questions. So make sure you are reading them perfectly. Take it perfectly. Okay. Hence, what are the drugs used in the epilepsy? It is a 3 subjects integration. It is a pharma, pedia, and medicine. So in a case of generalized tonic-clonic seizures, if it is active seizure, first we will give the lorazepam. Okay, and we will position them. Whereas in a case of GTCS, first we will use this drug, which is this lamotrigine. Lamotrigine you will use. If there is no lamotrigine, you can try for valproate or levetiracetam. Whereas this drug of choice, it is what? It is the lamotrigine. Lekin lamotrigine ka bhi kuch side effects hai. If used in a case of for a prolonged time, it can, or elderly, it can lead to this Stevens-Johnson syndrome and toxic epidermonecrolysis. फिर उसके बाद है valproate. Valproate causes liver damage and pancreas damage and PCOD. ठीक है, valproate में याद रखना, it causes liver damage and PCOD. Liver damage, PCOD by this valproate. And yeah, and this lamotrigine, which will be used for a case of GTCs, and it is the drug of choice. Badhiya Nida Anjali. Good. Then about this partial and focal seizures. About this partial and focal seizures, here you need to use this drug, which is this 𝗵𝗵𝗶𝗀. 𝗵𝗵𝗶𝗀. Remember, it is the 𝗵𝗵𝗶𝗀 which is used in a case of trigeminal neuralgia as well, and also in a case of partial seizures. Okay, and in a case of absent seizures, and it is mostly the pediatric patients. They will tell like the child is presenting with this like a vacant look. Okay, he will become absent for a few seconds. So it is known as what? It is known as absent seizures. And for a child who is less than 2 to 3 years, will use this ethosuximide, or if it is child is more than 3 years, will use valproate. Okay. Yeah, that is the criteria, guys. Yeah, less than 30, or we will call, means like if there is less, we'll call them as Stevens-Johnson syndrome. If it is more, we'll call them as toxic epidermonecrolysis. If it is, we'll call them as spectrum type of disorders. Okay. Then about these 2 drugs or 2 phenomena, just infantile spasm, then we'll use ACTH. If there is just infantile spasm, we'll use ACTH. Whereas if there is a presence of this infantile spasm along with this tuberous sclerosis, remember it is the TV. If there is tuberous sclerosis, हम यहाँ क्या देंगे? We'll use this 𝗵𝗵𝗶𝗀. Yeah, good guys, good Ansh and good Shanavas. We'll use what? We'll use 𝗵𝗵𝗶𝗀. बढ़िया. Then in a case of eclampsia, तब हम देंगे magnesium sulfate. Whereas in a case of hypertensive emergency in pregnancy, में हम क्या देंगे? We'll give IV labetalol. Hypertensive emergency in pregnancy, we'll give IV labetalol. Whereas in a case of eclampsia, we'll give magnesium sulfate. And in the case of status epilepticus, as I told you, we'll take up this lorazepam. हम क्या देंगे? Lorazepam देंगे. ठीक है, कोई भी benzodiazepines. Okay. And in the case of febrile seizures, we'll keep this rectal diazepam, because the child is having the seizures. So we cannot access to his mouth. So we'll put the rectal suppositories. So we'll give this a rectal diazepam. Okay. Or else sometimes we can give intranasal midazolam as well. Yeah, good Dr. Puneet, good Dr. Anash, Anjali, and Shanavas Khan. Yeah, better, best. Fine. And about this final drug, which is the phenytoin, which previously we used for this both GTCS and partial seizures, because of the side effects, we'll use them at the last resort. So this phenytoin will cause the side effect of gum hypertrophy, hirsutism, and deficiency of this folate, vitamin K, and vitamin D. So it causes 3 deficiencies: folate deficiency, vitamin D deficiency, and vitamin K deficiency. Whereas we know this one, valproate, it will cause what? It will have hepatic damage and PCOD. Whereas this phenytoin will cause gum hypertrophy, folate deficiency, vitamin K deficiency, and vitamin D deficiency as well. And this phenytoin, it is teratogenic. And in questions they will give you, there is a female who is willing to be pregnant, pregnant. Now she is taking phenytoin, okay, or valproate. So what you will do? Yeah guys, what you will do? Will you change or keep like this? You will change. You will change into levetiracetam, okay, levetiracetam or either lamotrigine. Mostly in the case of lamotrigine. Whereas if the female who is already pregnant, okay, here the most preferred one, it is the levetiracetam, okay. The female who is already pregnant, let me write in good handwriting, okay. Female who is already pregnant, now, and she is taking valproate or phenytoin, and it's her 13th week, okay. If she's already pregnant, then don't change them. If she's taking phenytoin, tell her to take the same. Don't change it. If you want additionally, you give this folic acid supplementation. Okay, supplementation. Okay, which is a therapeutic dose. Folic acid supplementation you give them. Yeah, guys, good, absolutely awesome. You are in correct pace. You are in perfect lineup. Perfect. Okay. Then we'll see about this gout. Okay, gout, if there is any initial stages, if there is any simple gout, or if there is any simple gout or mild gout, what we'll do, we'll start with this NSAIDs like indomethacin. Or if there is an acute gout, there will be this uric acid. But here the uric acid is not the problem. It is the cells which is causing this inflammation. Because of this uric acid is the problem. Okay, so in such cases, we'll use anti-inflammatory drugs. We'll start with non-inflammatory non-steroidal anti-inflammatory drugs like indomethacin. Followed by this, we can start steroids. Whereas we can give one more drug which is known as colchicine. And this colchicine, it will inhibit this tubulin which prevents this neutrophil migration. We studied with one thing. We studied one thing, that interleukin 8, it causes neutrophil chemotaxis. And if this neutrophil need to move, then there should be this tubulin component should be present. Okay, this tubulin component should be present. So in such cases, if you don't want them to move, you will break this tubulin, and once you break this tubulin or you will incubate this tubulin, it will cause this neutrophil chemotaxis to be incubated. So there will be no neutrophil going to there, and if there is no neutrophil goes there, there will be no inflammation at the site. Then there will be no pain. So this is the management of acute gout. Whereas in a case of chronic gout, the main problem it is the increased uric acid. Either what you can do, either you make them to excrete out of the body, or you make them to produce into alternate component, or you produce it decrease, or you decrease the production. So what we can do is that we can incubate this xanthine oxidase which produces this uric acid. Okay, the drug which you use, it is the allopurinol. Remember, allopurinol is used for chronic gout, and it is a drug of choice. And we can use other drugs like febuxostat, which is also an xanthine oxidase inhibitors. We can use one more drug which is probenecid, and this probenecid, what is the help it will do is that it will increase the excretion of this uric acid. And then we can use one more drug which is known as recombinant uricase, like rasbicuricase and pegloticase, and both of this thing will be used especially in a case of tumor lysis syndrome. We know in a case of tumor, we give what? We give chemotherapy. Once we give chemotherapy, the cells will be broken. Once the cells are broken, it will get into digest. Then there will be the proteins and there will be the purines. And all of them, it will convert into what? It will convert into the uric acid. So what we'll do? Allopurinol, it is also used in a case of Lesch-Nyhan syndrome. Yeah, great guys. You see, this uric acid will be produced. So what we need to do is that we need to make this uric acid to be excreted out. So in such scenarios, we'll use this drug. They are known as what? Rasburicase and pegloticase, used in a case of tumor lysis syndrome. Okay? Then about this antimicrobials. Antimicrobials में तुम्हें बस इतना याद रखना, what is the mechanism of action of antimicrobials. अगर तुम्हें देखना cell wall synthesis incubators, remember by this mnemonic, firmly bind to bacterial cell wall. Okay, so here you need to know about this beta lactam. So bind to refers to this beta lactam. Firmly for phosphomycin, bind to for beta lactam, and beta lactam they will incubate this transpeptidases. So if it inhibits this transpeptidase, it won't form the cell membrane, and if there is a disruption of the cell membrane, the bacteria will die. And followed by this, B for bacitracin, cell for cycloserine, and V for vancomycin. And vancomycin, it will incubate this transglycosylase, which helps in this elongation of this cell membranes. So vancomycin, it incubates this transglycolase. बस इतना याद रखना. Okay, fine. Then about this protein synthesis inhibitors, there are two classifications. There are this 30S inhibitors and there are this 50S inhibitors. This 30S inhibitors, remember it as by at 30 and cell at 50. ठीक है ना? तुमने 30 पे कर दा और 50 पे भेज दिया. तो A for aminoglycosides and T for tetracyclines. And 50S, remember it is for cell. So it is the streptogramins which previously we used to use, and the erythromycin which comes under this macrolides, and then linezolide and lincosamide. Linezolide, lincosamides, yeah, good Dr. Shanavas, good Dr. Anjali, and then chloramphenicol and clindamycin. Chloramphenicol and clindamycin, these are these two additional drugs. So cell, it is what? It is the streptogramins, erythromycin like macrolides, and linezolide and lincosamide. Linezolide and lincosamides. These are the protein synthesis inhibitors. Then about this like metabolisms, like for example sulfonamides, they are this metabolism inhibitors which acts on this folic acid synthesis. So this includes the sulfonamides, and there will be this combination of these sulfonamides. They are known as what? Cotrimoxazole. And this cotrimoxazole, it is used in a case of Pneumocystis jirovecii. It is used in a case of Pneumocystis jirovecii, and it causes pneumonia which is known as PCP pneumonia in HIV positive patients. And if you see this PCP pneumonia, if you see this PCP pneumonia on staining, like staining with gomori methamphetamine silver stain, it will produce a typical appearance of which appearance? It will produce the appearance of crushed. Remember, it is the crushed ping pong ball appearance. It produces this crushed ping pong ball appearance. It will produce as there is a silver stain, silver will showing this block. So see, it is the normal ball, it is the crushed ball. Okay, it is the crushed kind of ball. Okay, it is a crushed ball. Okay, fine. Next about this trimethoprim and pyrimethamine. Then about this DNA gyrase. This DNA gyrase inhibitors, this include this fluoroquinolones. And we know this fluoroquinolones, they cannot be given during pregnancy because they interfere with this. Which function? They interfere with this formation of this tendons. Okay, tendons in the teeth. And drugs acting on the cell membranes include daptomycin, polymyxin B, and polymyxin E. So membrane, it is the MD. Membrane, it is the daptomycin. It is the daptomycin. फिर उसके बाद आते हैं antineoplastic drugs and its side effects. हमने पढ़ा है कि one of this most common side effect of this antineoplastic drugs क्या? It is what? It is the vomiting. So in a case of yearly chemotherapy induced vomiting, हम क्या करेंगे? हम क्या देंगे? In a case of yearly chemotherapy induced vomiting, we'll give ondansetron. अगर if there is a case of delayed chemotherapy induced vomiting, तब हम क्या देंगे? We will give aperipitant. Okay, we'll give what? We'll give aperipitant. बस इतना याद रखना. Yeah, good guys. इसकी PDF you will get in the group. You just check the scroll down the link, you will get it. Okay, don't worry. Then about this alkylating agents. Okay, about this antineoplastic drugs, we'll just see very superficially. If you see this alkylating agents like cyclophosphamide, it will cause a side effect which is known as hemorrhagic cystitis. In bladder, it will cause hemorrhages. It is known as hemorrhagic cystitis, and to prevent this, we'll use this drug which is known as Mesna. And there is one more thing which is known as Melphan. It is used in a case of multiple myeloma, which is also in alkylating agents. And busulfan, it will cause pulmonary fibrosis. It will cause what? It will cause this pulmonary fibrosis. Then there is this platinum components, and this platinum components, it like cisplatin, it will be causing this nephrotoxic and ototoxic. Next one, anti-tumor antibiotics like doxorubicin, daunorubicin. हमें पता है रूबी दिल ले जाती है. Okay, so while these ruby drugs, it will cause damage to this heart and it will cause what? Restrictive cardiomyopathy. So to prevent this, we'll use this antidote which is known as what? Dexrazone. Okay, it is the, yeah, not though. So it is what? It is the dexamethasone, remember. And next one is the bleomycin. Bleomycin and busulfan, both of them, they causes what? They causes this pulmonary fibrosis. And remember one more thing, this bleomycin will cause this kind of flagellated pigmentations over the trunk. It will cause this type of flagellated pigmentation. Then one this vincristine and vinblastin. Remember this vinblastin. Okay, vinblastin will suppress the marrow. So remember, vinblastin, it will blast the marrow. Likewise, it suppress it. Fine. And this 5-fluorouracil, this is asked in the recent FMGE examination. It will cause hand and foot syndrome. And cytarabine, it will cause us this cerebellar side effect. It will cause us this cerebellar side effect. Okay, I have given these two things. One is this antidotes and the drug of choice, whatever mostly I discussed. There are few extra will be here. So you just go through this drug of choice. Whereas antidote I will tell you. Okay. For ergot alkaloids, it is the nitroprusides. For example, in a case of migraine, previously we used to use this ergot alkaloids. So and it will cause severe vasoconstriction. So for this we'll use this nitroprusside. And beta blockers will use glucagon. Beta blockers will use glucagon. And OPC and carbamates, I told you, it is the atropine. And OPC extra will use what? Will use what? Along with this OPC, atropine will use this pralidoxin. Okay. And benzodiazepines or all the Z drugs will use flumazenil. Okay. Like what is the Mazeko nil carnivale drug. Then cyanide will use hydroxycobalamin. Then amyl nitrate. Yeah, good. Dr. Shanavas, Dr. Anjali, good Puneet. Yeah, good. Okay, amyl nitrate and sodium thiosulfate will be used as an antidote for cyanide. And can anyone tell me, cyanide inhibits which of the following component of this electron transport chain? That is the fourth one. It is the fourth. It is the fourth one. Okay, that is the fourth one. Yeah, good, good. Dr. Shanavas, Dr. Anash. Yeah, good. Fine. Then alcohol will use this drug, which is the fumipazole. Iron will use this desferroxamine. Then acetamine, paracetamol, we know paracetamol toxicity, will use this N-acetylcysteine. And aspirin, what will do? Means because of this, it is an acidic drug. Then we need to do forced alkaline diuresis. If there is any alkaline drug, then we'll use that forced acidic diuresis. But mostly for acidic drugs only, we'll do this forced alkaline diuresis. Then about, I told you, isoniazid, there will be toxicity, will give pyrazine. And opioids will use this naloxone, and one more drug which is the maintenance drug, which is this naltrexone. Fine. And opioids will be naloxone. And scorpion sting, what will use? Yeah, good, good, Dr. Puneet. And scorpion sting will use prazosin. And for atropine, I told it is the physostigmine. Fine. And about this physostigmine, belladonna and datura poisoning will use atropine. So it is the interchange of this both these two. Fine. And this FMGE inhibitors will have this XC, which is the andexanate. Okay, it is the andexanate alpha. Next about this dabigatran. It is dabigatran. We'll use this idarizumab. Dabigatran, it is the idarizumab. And we know it is the one of the oral direct acting thrombin inhibitors. Then for heparin, we already discussed, it is the protamine sulfate. And cyclophosphamide, which is causing this hemorrhagic cystitis, will use this mesna. And cisplatin will use amifostine. Okay, anthracyclines like ruby, जैसे दिल ले जाती है, like doxorubicin and donorubicin will use dexamethasone. Then for methotrexate will give alternate folic acid. Alternate folic acid, also known as leucovorin. So remember about these antidotes, and just most of this drug of choice I have discussed. Just go through this drug of choice once. Okay? So whichever I have not discussed, I will tell you. Okay? So antithyroid drugs in pregnancy, it is the propyl thiouracil. Okay? Then brucellosis, you should use doxycycline and rifampicin, and rest we told mostly. Cytomegalovirus, you should use ganciclovir. Fine. And diabetes insipidus, as I told you, if it is mostly, if it is central, then we'll use desmopressin. If it is nephrogenic, then we'll use thiazide-diuretics. If it is only lithium induced, then we'll use this amiloride. In type 1 diabetes, we'll use insulin. Type 2 will use what? Oral hypoglycemic agents. Okay. And like metformin. And ketoacidosis will use insulin along with IV fluids. Whereas pregnancy will use mostly of insulin. Okay. Drug induced Parkinsonism, we told it is what? It is the benzoxazole. Good, good, good guys. Then typhoid will use this ceftriaxone. And we told like this altiplase, if there is an overdose, we'll use this EACA or tranexamic acid. Fine. For the cystodes and trematodes, we'll use pranziquintal. For nematodes, we'll use albendazole. For giardiasis, amoebiasis and trichomoniasis. And also for bacterial vaginosis, we'll use metronidazole. Then about herpes simplex, we'll use 𝗲𝗲𝗀𝗃𝗀𝗴𝗿, and in hypertension pregnancy, we'll use 3 drugs. One is what? One is this labetalol, then alpha-methyl-dopa previously we used to use. Then we'll use for emergency, we'll use IV labetalol. Okay, and in emergency, we'll use nicardipine. Yeah, fine. Yeah, that is the mnemonic for this metronidazole. Yeah, good guys. Fine. For osteoporosis or any osteoporosis, it is the bisphosphonates. Okay, and talk with oliguramia, it is what? It is the dopamine. Okay, and steroid induced osteoporosis, any osteoporosis, it is bisphosphonates. Okay, and for surgical prophylaxis we use cefazolin. And hypothyroidism, our only one drug, which is what? Which is this levothyroxine. Whereas if it is a case of hyperthyroidism, तभी हमें सोचना है, because usually we'll use carbimazole or methimazole. Whereas in a case of pregnancy में it can lead to this 𝗃𝗫𝗀 𝗀𝗃𝗀. So in such conditions, for first trimester of pregnancy हम क्या use करेंगे? Yeah, that is good guys. It is first trimester में हम क्या करेंगे? Propyl thiouracil. Yeah, good Anjali, good Shanavas. It is the propyl thiouracil. फिर इसके बाद second and third trimester में हम use करेंगे methimazole और carbimazole. और हमें पता है कि syphilis will use benzathine penicillin, and termination of PSVT will use adenosine, and for prophylaxis we are using verapamil. For toxoplasmosis we'll use pyramycin, and PDA yesterday we discussed PDA is a which pharyngeal arch artery? Yeah guys, it is which pharyngeal artery? It is a 4th, 5th, 3rd, 2nd and 6th pattern ductus arteriosus. Or ductus arteriosus is which pharyngeal arch artery guys? Yeah, treatment of PDA is indomethacin or ibuprofen. Yeah. Yeah guys, that's great. Wow, it is the 6th. It is the 6th, and it is especially on the left 6th pharyngeal arch artery. Yeah, absolutely awesome. I guess, like, I hope you have revised it. That's why you are answering well. Yeah, really well, really good Anjali and Shanavas Khan. Well, yeah, just good. Yeah. For keep it open, like in the case of any cyanotic disease, then we'll use prostaglandins or lax like alprazolam. Good, fine. Then about this trigeminal neuralgia, today only we discussed. It is the carbamazepine. And hypertriglyceridemia, we used to use fibrates, and this to decrease the LDL, we were using this statins, fine. And about this infantile spasm, we used ACTH, and Kala Azar will use this liposomal amphotericin B, and malignant hyperthermia will study in anesthesia, will use dantrolene sodium. And for mydriasis, in children, today only I told atropine will use, whereas in adults will use topiramide. Okay, and for oral hypoglycemic agents in obese patients, it is the metformin, and also will use in a case of PCOD. And influenza E will use oseltamivir. And for prophylaxis of this malaria, okay, usually there are two things, like prophylaxis of the malaria and yeah, Kala-Azar VQ, we use RK39 test. That's absolutely awesome. Yeah, good guys. So in case of prophylaxis of this malaria and treatment of the malaria, prophylaxis, there are two prophylaxis. One is the short-term prophylaxis, another one it is the long-term prophylaxis. So remember, short-term will use doxycycline, long-term will use mefloquine. And for treatment, there are two areas. Northeastern state will use artemether along with lumefantrine. Yeah, meflo for lung. Yeah. Whereas in the case of rest of India, it is artesunate plus sulfadoxine or pyrimethamine. Okay. Remember, it is northeast. It is the artemether plus ARL. Okay. It is the northeastern state. Remember. Yeah. Doxycycline daily for less than 6 weeks. Yeah, that's absolutely awesome. For plague, will use doxycycline. Then for pneumocystis pneumonia, will, as I told you today, it is the cotrimoxazole. And rheumatic fever, we discussed in pathology, the drug of choice for prophylaxis, it is the benzathine penicillin. We also use for syphilis. Then for whooping cough, we'll use macrolides like erythromycin. Then focal seizures, it is the carbamazepine. And performance anxiety, and as a migraine prophylaxis, we'll use what? We'll use propranolol. We'll use propranolol. Yeah, that's it guys. That is about the main point. Just we'll look into this few extra dates, then we'll wind up for the day. Fine. If you see about this receptors, there are few receptors. This ionotropic receptors, they uses the ions. So once they use this ions, they are the much fastest in nature. This includes GABA A, NMDA, NN type of receptors, and NM and 5-HT3 receptors. All of them, they are the ionic receptors, and they are most fastest receptors. Then you use this tyrosine kinase receptors. You remember this big. Prolactin insulin and growth hormone. They are the pig hormones. They act by this receptor which is known as tyrosine kinase receptor. Fine. Then there are this few intracellular receptors. In intracellular there will be two types. There might be intracytoplasmic or intranuclear. Intracytoplasmic one, it will be for this vitamin A, glucocorticoids and mineralocorticoids. It is the DMG, vitamin D, mineralocorticoids and glucocorticoids. Whereas nuclear, it is this vitamin A, thyroid hormones and sex hormones. Fine. And other receptors, they are this GPCR type of receptors. Fine. That's it. You need to know about this receptor points and about this benign prostatic hyperplasia. As I told you, this benign prostatic hyperplasia along with this hypertension will use zosine type of drugs like prazosin, terazosin. Okay. Then there are two components. For example, the patient will be complaining of two things. Either he will be complaining of acute things because of this prostate hyperplasia. So we can do two things. We can give some drugs which give an instant relief to him, or else we can give some drug which decreases this synthesis of this new cells again. Okay. Sorry guys. So if you see this alpha 1A blockers, it will give this immediate relief by acting on the dynamic component. So that is what that is this tamsulosin. Whereas we know this happens because of this conversion into this 5-hydroxytestosterone. So what we'll do, we'll give this 5-alpha reductase drugs to inhibit this conversion. So to inhibit this conversion. So the drugs include this finasteride. The drugs which include it is the finasteride, and it will act as a static component. So dynamic component, it is the tamsulosin, which is an alpha 1 blockers, whereas 5-alpha reductase inhibitors will use finasteride, which is a static components. Okay, bas itna yaad rakho. Yeah, good Dr. Naresh. Yeah, good Dr. Shanvaska. And during chemotherapy or some other aplastic crisis, we need to give some supplementation, or we need to promote the growth of this new blood cells. For RBC, we need erythropoietin. So we have this poietin analog, which is this dibropoietin, which is used in a case of chronic renal failure where there is decreased erythropoietin. Next one, WBC. For WBC, there will be this leukopenia after this chemotherapy sessions like bone marrow suppressions. In such cases, we have two things. If it is GCSF, we'll give filgrastim. If it is GMCSF, if it is include the monocyte also, it is 𝗧𝗵𝗶𝗀. Remember. And for platelets, we'll use oprivilkin, which is an interleukin 11 stimulant. Fine. Then about tuberculosis, we know this first line drugs HRZT. Okay, and we know isoniazid causes 6 deficiency. Patient took some medicine and had episode of orthostatic hypotension. What was the drug? Answer: yeah. They may be asked this question like, yeah, it is one of the means. It is used in hypertension, but it can cause one more side effect. Side effect, it is what? It is this orthostatic hypotension. So it is the side effect of it. Yeah, good point, Dr. Puneet. Fine. This is the first line drugs. It is the HRZT. Fine. It is this isoniazid which is causing this, pyridoxine which is causing this peripheral neuropathy, and rifampicin, it will cause red colored secretions like red colored urine. Okay, urine and what? Red colored urine and red colored tears even. Okay. Then ethambutol, it causes this red green color blindness because of this optic neuritis. And we have few new drugs, like just remember this name. They are this bedaquiline, delamanid and protamanid. And now there is a TB patient who is presented with HIV. So what he will do first? Will he start HIV treatment first or TB treatment first? What he will do, guys? You should do the TB treatment first. And after 2 weeks, yeah, good. First TB treatment. After 2 weeks, what he will do? He will start this HIV treatment. Best. Yeah. One of the side effect of bedaquiline, it is what? It is the QT prolongation. Yeah. First it is the ATT followed by this HIV treatment. For HIV, what we'll do? We'll give this type of drugs in the name of regimen, which is known as highly active antiretroviral therapy. And in this, we'll give this combination methods, which includes 2 NRTIs plus 1 NNRT or integrase inhibitors. So usually we'll give this TLD, tenofovir, lamivudine and dolutegravir. This is the usually fixed combination we'll give, and the same we'll use for this post-exposure prophylaxis. Like imagine, means you and your friend cleared your FMGE examination. Now you joined the internship, and while collecting sample, unfortunately sometimes you pricked your finger or your friend pricked your finger. Then you should take this post-exposure prophylaxis if the patient is HIV positive. Then in such cases, you need to take this TLD. You need to start this TLD within 72 hours, and you need to take for 28 days or 4 weeks. Okay, yeah, that's it guys. That's it for this HIV one. And finally, as I told you about this malaria, for eastern states will use artemether along with this lumefantrine, whereas for rest of the states will use artesunate along with sulfadoxine and pyrimethamine. Okay, sulfadoxine and pyrimethamine. So these are these drugs and things you need to know from the pharmacology perspective about this most new and most important topics. And if you know these things, it will change your game for sure. If you have any doubts, I am open to you. You can ask. Yeah guys, do you have any doubts? Yeah, in hepatitis B also we will use around this same drugs. And just remember one thing, just believe in yourself. If you believe in yourself, you will earn the success for sure. For that, you should have the belief that you can do it. Okay, if you have this belief that you can do it, you are halfway ahead and you will do these things for sure. If any doubts, please let me in the comment section. Hey guys, do you have any doubts? Yeah, Virat Kohli. Yeah, do you have any doubts? And yeah, tenofovir is used in both HIVs and hepatitis B. Yeah, that's correct. Yeah, thank you guys. I hope you enjoyed the session. I just want you to be continuing for next 40 days with the same set of confidence, and we'll be meeting for next 3 more days, and we'll try to cover all of your 19 subjects with this high yielding topics, so that you won't be having any regret that you missed this. Okay, if you about CD4 count, CD4 count I will tell you in medicine. सर इसमें से क्वेश्चंस आएंगे बस. हाँ बिल्कुल इसमें से आएगा. ओके, या थैंक यू डयाना, थैंक यू निदा, थैंक यू पुनीत, या थैंक यू वेरी मच, थैंक यू. ओके, या नरेश, या गेम चेंजर, yeah, we are the lovers of Wiki. Yeah, that's yeah, sure. Yeah, good. Thank you, Rakesh, and thank you, Shanavas Khan. We'll meet up soon. Okay. If any doubts you have, just please put up, or else just keep it with you. We'll be joining for next 3 more days, and we'll enjoy it. Fine. And that's it from my end, guys. We'll see you back. We'll see you tomorrow. Bye bye. Thank you.